Hi. Hello.
Good morning.
Morning, Zia. Lots of rains in Mumbai.
Acha. Okay.
So, Dr. Bhosle should be reaching in some time.
No problem, sir.
Problem is that our first speaker may not reach the hospital. Hello.
Okay.
Hello. Our first speaker may not reach the hospital, so we might have to get either second or third talk, which is recorded, ready with us.
Okay. How we will get to know? Maybe 5 minutes, 10 minutes before.
Yeah. We are trying to contact him. He's not contactable on phone. The roads are flooded. So I don't know.
Okay, sir. So please let us know. Maybe in 20 minutes time, so we can
Yeah. There is 20 minutes time. So I'll call you.
Sure, sir. Sure.
All right. ये बारिश रुकी the Zia, the other thing was that the Saraswati Vandana is quite short, no? So we can play it on loop till we are ready to begin. For a
Okay.
minute or so. I think it is only 30 seconds. Isn't it?
Yes, sir.
So we can play it on loop for say a minute and a half.
Okay, sir.
And can we get a slide made which we can display, or just a notation at the bottom of the screen saying that the speaker order may be changed due to heavy rains in Mumbai.
Okay.
And in the
Okay.
meanwhile,
I,
I
I,
will
I'll,
try to
I'll
contact
just get it done,
Dr.
sir.
Devatia.
I'll just get it done, sir.
Yeah. So I'm leaving the meeting. I will join in 10 minutes again.
Sure, sir.
Uh,
Sure.
I'll talk to Dr. Devatia in the meanwhile.
Sure. Sure.
धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः 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 शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः 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 शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः 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 शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः
Good morning, friends. Good morning, friends. I welcome you to this year's edition of case-based review in critical care medicine, a course for the examinee, that is BRITE 2021. Our speaker order has changed a little bit because of heavy rains in Mumbai. So we had requested Dr. Karnik to start. I hope all of you benefit from this knowledge and wisdom of all the knowledgeable examiners who are going to talk to us over the next 3 days. I'll hand over the mic now to Dr. Sheel Bhosle.
Good morning, friends. Welcome to all the delegates. It gives me immense pleasure to invite all the speakers who have been very gracious to accept the invitation at short notice. It shows their passion for teaching the critical care students. And to kickstart the day, I would like to invite Dr. Nitin Karnik. He is the head of the medical ICU at Sion Hospital. He's been the examiner for critical care, DM critical care program for quite a few years now, and he is an avid teacher in critical care medicine. He will speak about the poisoning. Over to you, Dr. Karnik.
Hello, good morning, everybody. First of all, let me thank Dr. Atul Kulkarni and the team of Tata Memorial Hospital for inviting me to give a talk on unknown poisoning in this prestigious BRITE, the third edition of it. It would be a case-based talk, and see, the common poisons in ICU which you see are the pesticides and rodenticides because of their easy availability. Then sedatives, antipsychotics, antidepressants, analgesics, anti-epileptics, floor cleaners, and herbal products are also commonly used. Alcohols, recreational and illicit drugs have the potential to become a poison. The most dangerous is if the patient is a medic or a paramedic because they have access to potentially fatal medicines and knowledge of the fatal dose. So they pose a management challenge. So uh, what approach we take in unknown poisonings is a toxidromic approach. Now, toxidromes are defined as a collection of symptoms representing certain classes of poisonings which help in making a diagnosis. The approach has to be like a clinical detective. Motivated search for clues is the cornerstones. You have to interrogate the family members, the friends, the work colleagues, and even the family physicians, and a thorough search of the home or hostel room, doing a tablet count of the current medications of the patient or family members helps. Targeted investigations and good supportive care may win the battle in the race against time and uncertainty. So let's start with the first case. This was a 63-year-old male who was a known case of depression on treatment. He was found unconscious on the bathroom floor. He had been prescribed escitalopram and amitriptyline for his depression and had been recently complaining of futility of living further. On arrival in EMS, he was unconscious, hyperthermic, and had probably had an episode of vomiting with aspiration. On examination, the patient looked dehydrated, was febrile, had a heart rate of 130 and a BP of 170 by 110. Bilateral pupils were dilated and sluggishly reacting to light, and there were scattered crepitations. The bowel sounds were sluggish. So, what are the diagnostic challenges in this case? The diagnostic possibilities were number one, amitriptyline poisoning, number two, escitalopram poisoning, of course, a mixed poisoning. He could have taken some other sedative hypnotic poisoning, and you have to rule out a febrile illness with a septic encephalopathy, a metabolic cause of a coma, or meningeal infection. Now, what is a toxidromic approach to unknown poisoning? We go by the constellation of the signs and then try to predict the poison. So if there is tachycardia, it's usually because of anticholinergics, antihistaminics, antipsychotics, sympathomimetics, including cocaine, amphetamine, theophylline, and tricyclic antidepressants. Hyperthermia on presentation is there with anticholinergics, antidepressants, antipsychotics, antihistaminics, salicylates, antihypertensives, sedatives, opiates, and heroin. Hypertension is seen with thyroid hormone overdosage, cocaine, nicotine, sympathomimetics, caffeine, and anticholinergic drugs. And comatose patients can be severe organophosphorus poisoning, alcohol, ethylene glycol, methanol, tricyclic antidepressants, anticonvulsants, antipsychotics, antihistaminics, and hypoglycemic agents. mydriasis, dilated pupils, datura, atropine, and sympathomimetics. Dry skin is antihistaminics and anticholinergic. So here, if you see, most of the signs were fitting into amitriptyline poisoning, and hence amitriptyline poisoning could be a possible diagnosis. The second drug is escitalopram. What about the role of escitalopram? Number one, it had a contributory role in worsening TCA poisoning. It has no role. This is a case of serotonin syndrome, or it can aggravate the cardiovascular toxicity of tricyclic antidepressants. So which of these four would you choose? See, escitalopram is a selective serotonin reuptake inhibitor and alone rarely causes serious poisonings. But if drugs are taken together with it or in high doses, you can get a serotonin syndrome. The combinations of these drugs can be SSRIs combined with SNRIs like serotonin and norepinephrine, trazodone, duloxetine, venlafaxine, TCAs, pain medication like codeine, fentanyl, meperidine, oxycodone, tramadol, street drugs like LSD, cocaine, ecstasy, amphetamine, and miscellaneously linezolid, migraine medications, ritonavir, and buspirone. So what we have to see is individually these medications will not cause, but if you have a SSRI taken in combination with other SSRIs or these 6 groups mentioned here, you can get a serotonin syndrome. So what is serotonin syndrome? It's a triad of autonomic hyperactivity, neuromuscular abnormality, and a mental status change. In mild cases, you have tachycardia, autonomic symptoms like shivering, diaphoresis, mydriasis, also myoclonus or tremors. In moderate cases, you have hyperthermia, tachycardia, and hypertension. Patient can develop hyperactive bowel sounds, diaphoresis, hyperreflexia, and clonus. And severe cases can have fever more than 40 degrees, severe metabolic acidosis, shock, rhabdomyolysis, high liver enzymes, high creatinine, seizures, and DIC. So what is the initial management plan for this patient? History and physical examination, the ABC approach involving a ensured airway, adequate ventilation, and circulatory stability. Symptomatic and supportive care. Give IV dextrose if the random blood sugar is below 80 milligram per deciliter. Give thiamine in alcoholics, and do a risk evaluation where the intensivist predicts the likely clinical course and potential complications at presentation. This should be quantitative and take into account the possible agent, the dose, the time of ingestion, the current clinical status, and the individual patient factors. Now, what is this patient's risk evaluation? I would put it this way. Number one, he has severe amitriptyline and escitalopram poisoning. There's a possibility of a moderate serotonin syndrome. He also has aspiration pneumonitis, and this is a deliberate determined self-harm attempt. In TCA poisoning, life-threatening events occur within 6 and usually within the first 2 hours of ingestion. There's increased risk of arrhythmias and sudden cardiac death due to combination of poisons. So this patient would need a close ICU monitoring. What investigations would you plan for this patient? So investigations in unknown poisonings in all patients do a CBC, serum electrolyte, LFT, RFT, RBS, ABG, a 12-lead ECG for conduction abnormalities, medico-legal gastric aspiration, save contents for chemical analysis, do a urinary toxin A and B screen, a chest X-ray and a bedside 2D echo in elderly, save 5 ml plain and heparinized blood for special investigations if needed for the future. Does GI decontamination have any role in poisoning? Gastric lavage, it's useful only if given within an hour or 2 of ingestion, but it's contraindicated in corrosive poisoning, both acid and alkali, and volatile hydrocarbons like kerosene and diesel, because you can get chemical pneumonitis. Activated charcoal used within 1 hour of ingestion, it's useful for anti-malarials, barbiturates, carbamazepine, and dapsone poisoning. Not useful in pesticide, insecticide, acid, and alkali ingestion. Catharetics accelerate defecation. A single dose of sorbitol 1 ml per kg may be considered in poisoning due to sustained release enteric-coated drugs. If the dose is large, you can use PEG through RT for whole bowel irrigation. How do TCA poisons act? They inhibit the presynaptic reuptake of norepinephrine and serotonin in the CNS. There's blockade of muscarinic receptors, so signs of anticholinergic toxicity, altered mental status due to blockade of histaminic receptors. The cardiac toxicity is because of blockade of fast sodium and potassium channel and QRS prolongation. You get bradycardia, heart block, even torsade points. The toxic dose is more than 1000 milligram. Life-threatening dose is 10 to 20 milligram per kg, and more than 30 milligram per kg can cause cardio and neurotoxicity. So how is TCA poisoning managed? The drug of choice is soda bicarb. It is used in hypotension related to TCA poisoning. As a second line after fluid resuscitation, it provides sodium for entry into the myocardial cells despite the sodium channel block, alkalinizes the blood, and prevents acidosis. The next is high dose intravenous glucagon in refractory cases of hypotension, as glucagon has both inotropic and chronotropic effect. Refractory life-threatening arrhythmias may respond to lipid emulsion infusion. TCA is a highly lipid-soluble drug. This provides an intravascular lipid compartment, enhances the free fatty acid availability for cardiac metabolism, and increases intracellular calcium. How do you manage SSI poisoning and serotonin syndrome? Of course, supportive care, fluid resuscitation, and use benzodiazepines like IV midazolam to control the agitation, because if you use physical restraints, this can lead to isometric muscle contraction, precipitating lactic acidosis and hyperthermia. 5-HT2A antagonist cyproheptadine 12 to 32 milligram in 24 hours binds with 85 to 95% of the serotonin receptors. The drug can be given orally via NJ tube. Tachycardia and hypertensive emergencies should be handled by short-acting agents like ismolol and sodium nitroprusside. We come to the second case, the unconscious traveler. This was a 42-year-old male who was found unconscious at Sahar Airport on 15th March 2010 in the waiting lounge after checking in for a flight to Mauritius. He had no companion with him. There was no order of alcohol. He was taken to Cooper Hospital from there by police. At Cooper Hospital, he was intubated in view of his altered state and disordered breathing. Subsequently, he was shifted to a private hospital for further evaluation and ventilator management. So what would be your differential diagnosis? Hypoglycemia, intracranial bleed, a febrile encephalopathy. He had a sudden cardiac arrhythmia with a hypoxic ischemic encephalopathy. Query a sedative hypnotic overdosage. Query substance abuse. His blood sugars, electrolytes, LFT, RFT were normal. The ABG was suggestive of a mild metabolic acidosis with hypoxia. The contrast CT brain was within normal limits. He was given empirical antimalarials, antibiotics. Mechanical ventilation was continued. He remained comatose and was mechanically ventilated for 3 days. Diagnosis still evaded the treating doctors, and he was shifted to KEM hospital on day 4 because of financial constraints. In KEM on examination, his vitals were stable. Pupils were 3 millimeters. The plantar was flexor. There was no neck stiffness. What differentials would you entertain at this stage? Of course, sedative hypnotic poisoning, knockout drops or powder like chloral hydrate or nitrazepam. A similar agent could be used for homicidal purpose. He could have been robbed after checking in. He could be on recreational drugs. He could have had a brainstem infarct. But if he had a brainstem infarct, he would be coning. He would have had central neurogenic respiration, and plantars would be extensor. Now coming back to the toxidromic approach, what clue do the pupils give us? Constricted pupils are seen in organophosphorus poisoning, carbamate poisoning, opiates, and carbolic acid. Respiratory depression is seen with sedative hypnotics, alcohol, opioids, and marijuana. Coma is seen with OP poisoning, hypoglycemic agents, heavy metals, isoniazide, ethylene glycol, tricyclic antidepressants. Seizures with OP poisoning, hypoglycemic agents, isoniazide, salicylates, TCAs, and ethanol withdrawal. So what were the management options? Conventionally, in unconscious patients, a cocktail of 50% dextrose, naloxone, and thiamine is advised. Naloxone reverses opioid-induced respiratory depression and sedation with a 2 milligram dose. For opioid addicts without apnea, the initial dose may be reduced to avoid withdrawal symptoms. Naloxone has side effects, seizures, hypertension, pulmonary edema, arrhythmias, cardiac arrest, and hence you have to use it very carefully. Flumazenil is a specific antidote for benzodiazepines. Its empirical use should be avoided in acute poisoning, and in fact, in chronic benzodiazepine users, flumazenil may precipitate withdrawal and seizures. So we continue with the case. On day 4, he was in MICU unconscious. On day 4 of admission, a high drama unfolded. The staff nurse on night duty was waiting till 9 a.m. to give some vital information to me. During cleaning and bed making, she had noticed he had passed 2 suspicious packets in stools. Each packet was rectangular, about the size of an eclair chocolate, containing some powder wrapped in a blue back insulation tape. What are the diagnostic possibilities and investigations? We did a plain X-ray abdomen, and as you can see, the entire bowel is showing numerous radio opaque foreign bodies dotting the entire length of small and large bowel, as well as you can see few in the stomach. So now what is the diagnosis? It was clear that he was a body packer or a drug courier. His urine tox screen was positive for benzodiazepines and opiates. He was administered flumazenil and naloxone with no improvement. He developed hypotension with a high CVP on day 5. So what is the next line of management? Would you give high dose naloxone, high dose flumazenil, complete bowel irrigation, or none of the above? A practoclise enema was given, after which 11 similar packets were retrieved from the lower GI tract. We informed the crime branch and the police and the administration. What is the next line of management? Meanwhile, a surgical opinion was sought since there were still many packets left in the GI tract. High risk consent for surgery was taken. Our surgeons in KEM performed an emergency exploratory laparotomy with gastrotomy and ileotomy. 35 sachets were retrieved surgically. 3 of these were partially ruptured and the rest were intact. It was noted that in addition to the above, there were some loose bits of insulation tape, which probably a fully disintegrated packet, thus explaining the patient's persistent unconscious state. So these were the packets which were retrieved surgically from the multiple stomies. He had an uneventful post-op course, and because we had removed the major poison, he regained consciousness on post-op day 3, subsequently weaned off ventilator after 8 days, needed some high antibiotics, but he was handed over to crime branch on day 14 post-op. Now, medical documentation in poisoning, alleged history should be the term used. The nature of poison and its severity is documented along with the emergency treatment. Document the informant's name, document and photograph and preserve the poison bottle, drug strips, document the smell of the poison. Consider toxic alcohol poisoning in case of mass casualties with vomiting, visual blurring, severe metabolic acidosis, even if history of illicit liquor consumption is not forthcoming. Document the antidote given and its dose, and consider multiple poisoning in atypical cases. Now, this is our case 3, the bradycardiac resident. A 25-year-old resident doctor got admitted in ICU of Sion Hospital with giddiness, sweating, and uneasiness of acute onset since 1 day. He gave history of low-grade fever since 2-3 days with fatigue. There is no past history of any medical illness. He had a bradycardia, pulse was 56, the BP was 84/60. Yeah, he was febrile, 99.6 degrees Fahrenheit. ECG showed low voltage complexes with sinus bradycardia. Chest X-ray was normal. His rest of the investigations and 2D echo were normal. He was treated symptomatically with IV fluids and coamoxiclav. He had 2 episodes of hypotension with bradycardia on day 2 of admission and was on inotropes on day 3 for persistent hypotension. The BP had dropped to dangerously less than 60 millimeters systolic. He denied any history of consumption of drugs or any substance abuse. What are the possibilities? Is it viral myocarditis? Is it a sick sinus syndrome? Is he having intermittent heart block, or is this a deliberate self-harm with a cardiotoxic drug? Now, see, the combination could be a fatal bomb because he's a medicine resident and he's hiding what he's taken. Role of specific testing is to identify the poison. Now, drug concentration measurement is useful in paracetamol, salicylate, valproic acid, digoxin, methotrexate, and iron. Toxicology test results are difficult to interpret, and a negative result may not exclude poisoning. Gastric fluid analysis is helpful only for forensic study, and that too is done only if the patient expires. Serum cholinesterase estimation is low in OP poisoning, so that can be a marker. Should one attempt to hasten excretion of an unknown poison? Various methods of enhanced excretion are forced diuresis with alteration in urinary pH, peritoneal and hemodialysis, hemoperfusion, hemofiltration and exchange transfusion, multiple doses of charcoal. Now, forced alkaline diuresis is useful in cases of salicylate, phenobarbital, and lithium poisonings because these substances are acidic. And then if you give them alkalinize the urine, then it can make an ionized form than a chemical which gets trapped in renal tubules and actively excreted. Dialysis is a most effective way of excretion of water-soluble low molecular weight compounds, including salicylates, theophylline, phenobarbital, lithium, ethanol, methanol, and ethylene glycol by either hemodialysis or peritoneal dialysis. Antidotes antagonize the effect of poisoning, and the well-known antidotes are naloxone in opioid poisoning, flumazenil in benzodiazepine, pyridoxine in INH, digibind in digoxin, IV calcium in calcium blocker poisoning, glucagon in beta blocker, N-acetylcysteine in paracetamol and ratol paste poisoning, ethanol for methanol poisoning, and atropine and PAM for organophosphorus compounds. So coming back to the resident, he had 2 episodes of hypotension with bradycardia. He had persistent hypotension. He denied any history of consumption of drugs or substance abuse. On day 3, he was cold, clammy. ECG was only sinus bradycardia. Neurologically, he was alert, conscious. There was no focal deficit, but the look in his eyes was very challenging and resigned. Luckily, at that time, one of his friends confided in me about his recent one-sided infatuation. That lady resident was currently doing an ICCU posting. Acting on a strong index of suspicion and going through the list of drugs which on overdosage could present in similar fashion, the list narrowed down to beta blockers, digoxin, and calcium channel blockers. What would be the next step? Recheck the electrolytes, repeat ABG, do serum digoxin levels, keep intracardiac pacing facility ready, give IV calcium and see the response, give IM glucagon and see the response, and send urine tox B screen for antipsychotics and TCS. We sent his blood to Hinduja for serum digoxin levels. We gave injection glucagon. There was no improvement. On day 4, we received the serum digoxin report in the evening. The levels were 12.8 nanograms per ml, very high. Even the therapeutic range is just between 0.5 to 0.9 nanogram per ml. We gave him digibind, which is a digoxin specific Fab antibody, 40 milligram vial, binds 0.5 milligram digoxin. We gave him about 8 vials by IV infusion. He improved rapidly and was discharged by day 8. He needs counseling, and I think as a treating physician, you are the best counselor in that situation. So meditating over facts, the pertinent history may not always be available, and a keen scientific analysis and unbiased approach is a need of the hour. Let's come to case 4, which was mass poisoning. Story of New Year's Eve 2005-6, Vikroli, Tagore Nagar. Over a period of 2-3 days, 56 patients got admitted in Sion Hospital with abdominal pain, nausea, vomiting, and breathlessness of a 1 or 2 days duration. On admission, most had severe metabolic acidosis, pH less than 7. They had hypotension, few had altered sensorium. 12 of these were brought gasping with ABG very low. They expired within 1 or 2 hours. Many developed a high serum creatinine within 2 to 3 days of admission. What are the possibilities? This could be spurious liquor, hooch tragedy, methanol poisoning. The similar symptoms could be seen in ethylene glycol, isopropyl alcohol poisoning. Very rarely, food poisoning like staph toxin in sweets or Bacillus cereus Chinese fruit rice could cause vomiting and metabolic acidosis. Uh, then there was history of consumption of country liquor in a home setting bar run by a middle-aged lady in Vikhroli. Sporadic cases were reported over the next few days from the slums of Sayan, Kurla, Dharavi, and Bandra because she had supplied the liquor to these local bars. The MIC of Sayan Hospital and the medical wards resembled a battleground. Now, what is the clinical course of methanol poisoning? Patients have severe metabolic acidosis, myocardial suppression with hypotension, renal failure, convulsions, coma. They can get permanent blindness due to formaldehyde effect on retina, shock due to myocardial depression. What are the ABG findings? Severe high anion gap metabolic acidosis, and metabolic acidosis with increasing osmolar gap may be present in poisoning due to methanol, ethanol, and ethylene glycol. How do you treat them? The antidote is ethanol. You give it as a competitive substrate IV or as a 10% solution through RT. Use IV soda bicarb for the metabolic acidosis, hemodialysis for severe poisoning, folinic acid, give 25% dextrose, thiamine, folic acid. And since these are all police cases, you have to save gastric contents for analysis, collect blood samples from ethanol and methanol, but you have to document it that you have collected it without using spirit. Just use cetavlon for cleaning. This is for medical legal purpose. Similarly, in 2007, Sion Hospital saw another mass poisoning when 40 males were brought from pain after consuming food and alcohol. They had gathered to celebrate the political win in the ZP elections of their candidate. They had nausea, vomiting, abdominal pain, dyspnea, metabolic acidosis, hypotension, altered sensorium. 8 patients expired soon after. And the most peculiar feature was they had severe hypocalcemia with each ECG showing deep symmetric arrowhead T-wave inversion, which we classically see in subendocardial infarct. So what are the diagnostic possibilities? They are ethylene glycol poisoning, isopropyl alcohol poisoning, mixed poisoning with methanol. We got a true story from a relative. A crowd of 350 suddenly turned up against an invited crowd of 200 plus. So obviously there were agents that were added to the available alcohol to increase its potency despite dilution. Now, what are these agents? It could be ethylene glycol, which is present in old batteries as an antifreeze agent, isopropyl alcohol, psychotropic drugs, and of course locally available datura seeds. But he had no sign of anticholinergic poisoning. Source confirmed. Low calcium is a classic finding of ethylene glycol poisoning, confirmed by demonstration of oxalic acid crystals in the urine. How is ethylene glycol poisoning managed? IV calcium gluconate 10 ml 10% to be given slowly, repeat after 1 or 2 hours. They needed hemodialysis, ethanol and other treatment as for methanol poisoning. 32 patients recovered totally and discharged. The ECG abnormalities corrected within 48 hours and none developed blindness. The second last case is a mysterious death of a 25 years female. She was brought to Sion Hospital EMS at 2 a.m. complaining of uneasiness and breathlessness since 8:30 p.m. She was referred from Thana Civil Hospital for tachypnea and hypoxia. She gave history of consumption of a slimming pill in the gym at 7:30 p.m. There was rapid onset of hypoxia, hypotension, needed intubation, mechanical ventilation. She expired by 3:30 a.m. and there was onset of rigor mortis within 15 to 20 minutes. Literature search revealed that you have such pills which contain 1,2-dinitrophenol, and it has produced sporadic deaths worldwide. And DNP is advertised as a slimming pill, but has known side effects including multiple organ failure, coma, and cardiac arrest. The last cases which we saw about 2 weeks back in Sion Hospital, a young 16-year-old male came with a alleged history of consumption of a blue colored liquid followed by multiple episodes of vomiting and abdominal pain. He had severe tachycardia. His BP was 110 by 70. Pupils were 4 millimeter reacting to light. The ABG was suggestive of a metabolic acidosis with hyperkalemia. The CBC was showing a high WBC count. He had a renal failure with a BUN of 40 and a creatinine of 4.5 milligram percent. Serum cholinesterol levels were normal. The ECG, if you see, revealed poor R wave progression. So this is the ECG which revealed sinus tachycardia, pulse of more than 150. There was a sagging of the ST segment, but if you see the anterior leads from V1 to V6, there was a very poor progression of R waves. Now the differential diagnosis here, apart from your methanol and ethylene glycol poisoning, included salicylate poisoning and paraquat poisoning. Now he had consumed a blue colored liquid. Uh, Methyl salicylate is usually not blue colored unless somebody colors it. So apart from methanol and ethanol, we considered paraquat poisoning and salicylate poisoning. For paraquat poisoning, we preserved a urine sample of the patient and next day sent to biochemistry laboratory. There's a simple diagnostic test. 10 ml of the urine sample with 2 ml of a freshly prepared 1% sodium thiothionate in 1 normal sodium hydroxide is added and mixed well. Interpretation: if the urine sample turns blue or green, it indicates presence of paraquat in the urine sample. If it turns black, it indicates a very high concentration. So we talked to our biochemistry HOD, Dr. Ingle, and he immediately agreed. He had these chemicals in his biochemistry lab. And in this case, a blue color developed immediately after adding 1% sodium dithionite, which then turned black. So this is the urine sample, and after testing, this is the black color. So diagnosis of paraquat poisoning was confirmed. Now, what are the clinical features? They depend upon the quantity of ingestion. Large amounts of liquid concentrate result in pulmonary edema, cardiac failure, renal failure, hepatic failure, and convulsions due to CNS involvement. So you can see that paraquat, though it is advertised as a herbicide, has multi-organ failure, and patients generally have severe hypoxia, shock, and metabolic acidosis. A patient expired within 24 hours. Clinical features, one of the pointers is, as you can see here, the tongue, you get mucosal lesions of the mouth and tongue appearing within the first few days. You have ulceration with bleeding, and such are also seen in pharynx, esophagus, and stomach. How do you manage paraquat poisoning? Initial resuscitation for acute paraquat poisoning follow standard guidelines, except that oxygen should not be administered unless there is confirmed hypoxia, because oxygen may exacerbate the oxygen mediated cellular damage induced by redox cycling. Give isotonic fluids. Decontaminate gastric decontamination with activated charcoal as soon as possible, either orally or via NG tube. Its effects are maximized if GI decontamination is done within 2 hours of ingestion. However, forced emesis and gastric lavage are contraindicated because of possibility of a caustic injury. Use dexamethasone 8 milligram IV 8 hourly for the first 72 hours. Antioxidants. Treatment with hemoperfusion for 4 hours if it can be initiated within 4 hours of ingestion. Intermittent hemodialysis or hemofiltration is effective in enhancing elimination at comparable blood flow rates because paraquat has a low protein bounding. Continuous pulse oximetry is required to monitor for deteriorating gas exchange. Signs of severe systemic illness are severe hypoxia, hypotension, or acidosis. These indicate a poor prognosis. So to summarize, it's a rapidly acting non-selective herbicide that is relatively inexpensive. Accidental or deliberate ingestion has an extremely high case fatality rate. Paraquat is highly polar and corrosive. Paraquat is rapidly but incompletely absorbed from the gut after ingestion. It then rapidly distributes into other tissues with maximum tissue levels reached about 6 hours after ingestion. And the fatality rate is very, very high. Thank you for a patient listening.
Sir, we have one question from Dr. Ajit Vishwanath for you.
Yeah.
Omeprazole in methanol poisoning and its availability in India.
Okay. Now, yeah. Am I audible?
Yes, you are.
Yes, sir.
Yeah. See, traditionally we have been using ethanol as a competitive substrate for the alcohol dehydrogenase enzyme in methanol poisoning, because when the alcohol dehydrogenase uh, metabolizes methanol, you get formaldehyde and formic acid, which cause severe metabolic acidosis, and the formaldehyde damages the retina and you get a permanent blindness. So to prevent that, we give a alcohol infusion as a competitive substrate. Fomeprazole is a direct inhibitor of the alcohol dehydrogenase enzyme, and we have started, see, these cases were back in 2000, I think 7 and 2008, but now for the past 5 years fomeprazole is available. You have to buy it. It's available in Royal Chemist or certain chemists in Princess Street, and we have been using it to treat our recent we had about 2 years back, again we had about 60 cases of spurious liquor poisoning. We have been using fomeprazole. So it is available in India. However, it's not in municipal hospitals. It is not available in stock. We have to make a special indent and buy it.
Thank you, sir.
Yeah.
We don't have any other questions as of now. Okay.
Sir, is there any guidance about in which patient you should avoid gastric lavage?
Yeah, gastric lavage is avoided in corrosive poisons, means even acid and alkali ingestion, and in kerosene poisoning, because you get an aspiration with chemistry. So diesel and kerosene, suspected kerosene and diesel poisoning, so we avoid a gastric lavage, because then they say it gets aspirated, goes into the lungs, and you get a chemical pneumonitis. What we've seen now is about 7 to 8 cases of harpic consumption in the past 1 year in Sion MISU. And as residents, we used to dread acid ingestion. People used to drink sulfuric acid or nitric acid, especially people who had access to them, or people working in colleges and chemistry labs. Now the trend is to ingest harpic, and harpic is equally or more bad than acid, because it's an alkali which is causing corrosive ingestion. And what we see is you get a esophageal perforation, then you get a bad mediastinitis, sepsis, septic shock, severe myocardial depression. So these corrosives, acid, including acid alkali and your diesel and kerosene poisoning, we avoid gastric lavage.
Thank you, sir.
Okay, sir, we have another question. Why do we use dexamethasone in parakeet poisoning? This
Yeah,
is
see, there's a lot of inflammation in the tissues. So under antibiotic cover, small, say 8 milligram TDS of dexamethasone we use for the first 24 to 48 hours. But let me say that parakeet poisoning almost has a fatality rate of 80 to 90%. We've had about 7 in the past 3 years in Sion Hospital.
okay. Sir, is there any role of coconut oil in parakeet poisoning?
Yeah, coconut oil acts as a it layers the GI tract and layers the, so if you give it in time, it may prevent the damage to the mucosa. So it's a very good locally available agent, provided you use it within the first 1 or 2 hours. There's no harm. You can but see, the problem here is even putting in a RT becomes very risky, because you can perforate the esophagus. So if he is conscious, we give him about 50-60 ml of coconut oil to ingest, to drink. But it has been advocated purely as it layers the mucosa and prevents a corrosive injury.
Okay. So we have another question by Dr. Surendranath Vilamala. He is asking whether digoxin can cause ECG changes. Can we detect by that?
See the standard Deej effect is the reverse tick mark sign on the ECG. Otherwise, digoxin can cause all sort of blocks, including a complete heart block. The issue here is we cannot diagnose the digoxin poisoning based on the ECG, because that time there was I mean, we were not on the same thinking term with the cardiology people, because they felt this is viral. He had started with fever, so they felt it was viral myocarditis, and they felt that the blocks are because of myocarditis. So the blocks which come in digoxin poisoning may not be very specific. See, reverse tick mark sign also, if you have electrolyte imbalances and all, you can get, or some acidosis of patients of chronic renal failure, you can get. So you cannot use it as a diagnostic test for digoxin poisoning. The diagnostic test is a serum digoxin level.
Sir, and there is
Role
another
of PAM
question
in OP poisoning.
role of PAM. Yeah.
See, PAM has no role in Agon, that is carbamate poisoning, or organochlorine compounds like DDT, pralidoxim has no role. In organophosphorus compound poisonings, the primary antidote is atropine. We do use pralidoxim because what happens is the phosphate of the organophosphorus binds to the esteratic site of the cholinesterase enzyme and causes a permanent destruction. So if you use pralidoxim, the oximes bind to the phosphoratic site of the organophosphorus compound and then will release the esteratic site. So it acts as a competitive substrate. The oxime of the pralidoxim binds to the phosphorus of the organophosphorus compound. So the standard textbooks mentioned 1 gram as loading and 500 milligram BD for 48 hours. This was the dose given in old Harrison. What we use slightly higher doses now, because if people have come, and it's useful only if you use it within 48 hours. So if somebody is brought to you from village 5 days later and he's had a respiratory depression or an intermediate syndrome, he's going to be on a ventilator till the body regenerates the cholinesterase enzyme. So oximes we use in the first 48 hours. Nowadays, we may give a 1 gram every 3 to 4 hours for the first 48 hours and then continue 500 BD for the next 48 hours, depending upon the clinical feature. There are some patients of organophosphorus poisoning who continue to get fasciculations and all despite atropine over the, even 3 to 4 days. So there we continue pralidoxin for about 5 days.
Sir, and there is another question which is tell your views about sulfose poisoning and your experience.
By sulfose, does it mean aluminum phosphide poisoning?
Yes, possibly, sir.
Possibly. See, aluminum phosphide is used as a rodenticide in granaries. And basically, we have a lot of case reports and case series coming from North India. Our side, see, Western India, our farmers are not using a lot of aluminum phosphide. I have seen occasional cases of aluminum phosphide where basically the management, the diagnosis is difficult and the management is mainly symptomatic.
I think that's
Okay.
about it, sir. Yeah, it was a wonderful to hear you, sir. I think we have another minute. Any other, sir, salient features, points, highlights you want to tell the students?
See, what I would like to tell them is that you have to be on lot of time, you know, the commonest poison, वो मच्छर मारने का दवा खाया है, चूहे मारने का दवा खाया है. So what happens is my residents, moment they say चूहे मारने का, they say it, they think it is either a warfarin based poison or it is your phosphorus. But you have to be very careful, because what happens is even simple insecticides cost about 200 to 300 rupees. what the people use it is those 10 rupees and 20 rupees compounds which you get on say Dharavi bridge or Dadar ka full market ka bridge, and you are not sure what it is. So what my earnest plea is, if they say chuha marne ka dawa, it could still be an OP compound, and when they say khatmal marne ka dawa, it could still be a rodenticide. So you have to go according to the clinical features and be totally unbiased. I mean, you give a stomach wash, if there's a smell of OP, treat as OP. You see constricted pupils and fasciculations, treat as OP. You start getting a deranged INR and then hepatic involvement, you know it is rodenticide.
Still, I think you take one more question.
Yeah, N-acetylcysteine in paraquat poisoning. We do see, as I showed, there's multiple organ failures. So N-acetylcysteine, if you see that the liver is getting involved and there's a rise in liver enzymes, we do give them N-acetylcysteine, just as we give for paracetamol poisoning.
Okay. I think there is one last question, that is role of ECMO.
No, I've had no access to ECMO in either KM or Sion Hospital where I've worked. So we'll have to see the references.
No, so Sheil, I think we can take it later, because
Yeah,
I think we need to
we'll
go on
take
to the
a
next talk.
few questions after the session, sir, if you are around.
Yeah.
Okay. Thank you so much, sir, for an excellent talk. And there are a few housekeeping announcements. So we have got, the delegates can buy 2 books at subsidized cost. That is, one is the Infectious Diseases in Critical Care Medicine, that is by CBS Publications, and the cost is you can buy it on the website portal from the BRITE. And we also have the case-based review book that is exclusively for the BRITE book, which is again for which is a great book for the exam going students. You can buy that at a subsidized cost from this portal. So the delegates can take that benefit of buying it online through this link that is provided on the portal. Please put your questions on the chat box. We will take them as and when we can. We finish the session. At the end of the session, we'll take the whatever questions that we can. So moving on for the next talk, I would like to invite Dr. J.V. Divatia. He is well known to all of us, and we always take great pleasure to listen to him. He is the professor and head Department of Anesthesia, Critical Care and Pain at Tata Memorial Hospital, and he will be speaking on the ventilator graphics and the ventilator patient dysynchrony. I invite Dr. Divatia to speak on the topic.
Good morning, and thank you very much for asking me to speak in this meeting. So today we will be speaking on ventilator waveforms, and I hope you can see my screen and you can hear me clearly. So the ventilator waveforms are amazing tools. They are almost like the ECG of the patient who's being mechanically ventilated. So it is very important to understand the waveforms. And while I'm talking about the waveforms, there is a lot of science behind it. But just like the ECG, it is very nice and easy if you can just eyeball the waveforms, and you can make a sort of almost something like a spot diagnosis, or you can see the trends very easily when you look at ventilator waveforms. So we'll now talk about some of these sort of waveforms. So almost all ventilators today have got some form of graphics, right? So they've either got a separate screen, or there's a small screen inside your control panel in which you can see these waveforms. And essentially there are 2 types of graphics, right? Waveforms plot either flow rate, airway pressure, or tidal volume versus time, okay? And the loop plot pressure versus volume or flow versus volume. So when something is plotted against time, they are used, we call them as waveforms, and the commonest waveforms, like I said, are pressure versus time, flow rate versus time, and volume versus time, and loops are pressure and flow volume loops. Okay. Now just remember, for all the fancy looks that the ventilator has and all the sort of awe-inspiring sort of stuff on the graphs and so on, a ventilator essentially does only one thing: it pushes air into the patient, and the flow of air into the patient is directed by valves. Right? So when inspiration starts, when the inspiratory valve opens, at that time the expiratory valve is closed, and during inspiration you can close the inspiratory valve by pressing a button called the inspiratory pause, or you can set the ventilator to have an inspiratory pause. At that time, both the inspiratory and the expiratory valves are closed, right, and the flow rate becomes zero. Expiration is a completely passive process. So the ventilator controls only the inspiratory phase of respiration. Expiration is completely passive. All that the ventilator does is it opens the expiratory valve. The expiratory valve opens, expiratory valve is closed, expiratory valve opens, and if you close the expiratory valve in expiration, then that is what you're giving is an expiratory hold, and that is so that's what happens in the expiration. This is again just a short cartoon. So here you're seeing that this is going towards the patient. This is gas flowing from the ventilator into the patient. This is the inspiratory valve. So when the inspiratory valve opens, you've got gas going into the patient. This is, so that is the beginning of inspiration. Okay. Now when you plot flow rate, right? So I'm plotting here, I'm showing you the flow rate. When you plot flow rate versus time, you have flow rate on the y-axis and you have time on the x-axis, or the horizontal axis. The part above the horizontal axis is the inspiration. The part below the horizontal line is the exhalation. Right. So the inspiratory valve opens, gas goes in, then remains at that point till the inspiratory time, and then you close the inspiratory valve in inspiration. So when you close the inspiratory valve in inspiration, the flow rate comes down to zero, and this is the period of the expiratory pause. The expiratory valve is still the inspiratory pause, and the expiratory valve is still closed. So this is the period of the inspiratory pause. And then the expiratory valve opens and you have exhalation taking place. And exhalation, like I said, is completely passive. The ventilator does nothing to control exhalation. The ventilator only controls this phase in different modes. And so the exhalation is identical no matter what mode of ventilation you are using, right? And see how the exhalation goes. It sort of the rapid initial flow out of gas out of the lungs, that is the peak expiration, and then the flow rate gradually sort of declines till it reaches the baseline. So please have a good look at the expiratory waveform, because this is a typical expiratory waveform. So we'll now come to the pressure time graphic, and that is the classic sort of graph. And here you plot airway pressure on the y-axis versus time on the x-axis. So you have got volume control ventilation and you've got pressure control ventilation. We know that in pressure control ventilation, the airway pressure is held constant throughout the inspiratory time. So this is the inspiratory time. So that you see a constant pressure during pressure control ventilation. In volume control ventilation, the pressure is variable. And we'll talk more about the pressure time graph in volume control ventilation. Now, volume control ventilation and the pressure time graph is the best sort of way to look at some of the respiratory mechanics of the patient. Right. So now we said inspiration starts when the expiratory valve opens. So here you've got gas going into the patient. Now, when gas goes into the patient, it overcomes the airway resistance, the resistance in the airways, and it overcomes the stiffness of the lung. So it has to generate sufficient pressure to overcome airway resistance and the stiffness of the lung. And the resultant pressure which is generated is called the peak inspiratory pressure. So this is what happens when the inspiratory valve is open and there's gas flowing into the patient up to the peak inspiratory flow, right? Then if you close the inspiratory valve in inspiration, now this is the inspiratory pause. What happens is the flow rate, like I showed you earlier, has come down to zero. The pressure does not come down to zero because now the airway pressure is looking at the pressure in the inflated lung. The lung has already inflated. So now when the flow rate has come down to zero, there is no resistive component. And the only component which is contributing to the airway pressure is the pressure inside the distended lung. And this pressure is called the plateau pressure, right? This pressure is called the plateau pressure during the inspiratory pause. And this plateau pressure is extremely important because it reflects the pressure inside the distended lung. If the plateau pressure is high, we assume that the lung is over distended. So we say if the plateau pressure is more than 30 centimeters of water, the lung is over distended, and that can cause ventilator-induced lung injury. So one of the goals of mechanical ventilation is to maintain your plateau pressure less than 30 centimeters of water. So please remember the plateau pressure depends only on the compliance and it reflects the pressure of the distended lung. The peak pressure reflects the compliance as well as the resistance, airway resistance. And for the gap, the difference between the peak and the plateau reflects the airway resistance. Okay, and then the expiratory valve opens and the pressure comes down to exhalation, comes down to 0. So like I said, the peak pressure reflects the airway resistance as well as the compliance. The plateau pressure is influenced only by the compliance, and therefore the difference between the peak and the plateau is actually reflects the airway resistance, right? This is the airway resistance. So the wider the gap between the peak and the plateau, the higher is the airway resistance. If the compliance, so if the resistance rises, the peak goes up, plateau remains the same, and there's a big gap between the peak and the plateau. If the compliance falls, say pneumothorax or pulmonary edema, then both the peak and the plateau go up because the peak is affected by resistance and compliance, and so is the plateau also affected by compliance. So both will go up, and the gap between peak and plateau will be essentially the same. Now, based on this, you can actually calculate some of the parameters respectively. For example, so if you have the peak minus plateau divided by the flow rate gives you the airway resistance. That's you can calculate the airway resistance by the peak minus plateau divided by the flow rate that you've set in volume control ventilation. The tidal volume divided by the P plat minus the P is what we call as static compliance. The plateau pressure is the, remember, is where there is no flow. So that is reflects a static compliance of the lung. And the dynamic compliance is the compliance when there is airflow. So that for that you have to use the peak airway pressure. So the peak pressure minus the peak, the tidal volume divided by peak inspiratory pressure minus the peak gives us a dynamic compliance, and this is affected by resistance and compliance, and this is affected only by the compliance of the lung. And remember, when we are talking of compliance and resistance, we're talking of the compliance of the respiratory system because you've not partitioned the respiratory system into lung and chest wall. Okay, so this is essentially when I'm saying lung, I essentially am talking of the total respiratory system compliance. Okay, I hope this part is clear to everyone. If you want, I can explain it later. Now, one important information you get from the pressure time graphic is whether it's a mandatory breath or an assisted breath. And when a patient takes an inspiration, which is assisted by the ventilator, there'll be a dip in pressure below the baseline, and that is a patient effort. You can make out patient effort very nicely on the pressure time curve. So both these are assisted breaths with the patient effort followed by the ventilator breath. You can, of course, make out the PEEP from a baseline of 0 or whatever is the PEEP which you've set. You can make out PEEP. And you see that the pressure time curve varies in volume controlled ventilation versus pressure controlled ventilation. Pressure controlled ventilation, like I said, you've got a constant pressure. In volume controlled, you get a variable pressure. And we saw the peak pressure and the plateau pressure and the system. Now, we already talked a little bit about the flow time graphic, right? So, like I said, you can know the different flow rates, the peak inspiratory flow rate, the inspiratory time, the inspiratory pause, the peak expiratory flow rate, when the expiratory valve opens, right, and the expiratory time. Now, this is a very, very important slide and probably one of the most important slides which you must know. Now, the flow time graph helps you distinguish a volume or a flow controlled breath versus a pressure controlled breath. In a classical volume controlled breath, the flow rate is held constant throughout the inspiratory time. So you get what we call as a square wave pattern, right? So this is a volume controlled ventilation. Now, you know, we say volume controlled, but most ventilators, when they give a volume, give you a tidal volume, they maintain a constant flow rate, and the tidal volume is determined by the inspiratory time. So the flow rate into the inspiratory time gives you the tidal volume. So essentially what the ventilator does, it holds the flow rate constant, right? So when you have that volume controlled ventilation, the flow rate is held constant throughout the inspiratory time. In a pressure controlled breath, the flow rate is always decelerating. If you see a decelerating flow, it is almost certainly a pressure limited, some kind of a pressure controlled or a pressure limited mode of ventilation. Okay, so please remember this: constant flow, volume controlled; decelerating flow, pressure control or pressure limited. And remember, I said that the exhalation is completely passive. It's not determined with the ventilator. So the expiratory waveform is exactly identical in both volume controlled as well as pressure controlled beds. It's only the inspiratory waveform which will change. Okay. Now you can plot a loop, which this is the classical pressure volume loops. You got pressure on this axis and volume over here. And you can see that as the airway pressure increases, the tidal volume goes up and then it comes down. But the important thing to understand is that the expiration doesn't come down on the same path as inspiration. It goes up like this, but it doesn't come down the same way. It takes a different path. And this difference between the inspiratory and the expiratory parts of the loop is called hysteresis, right? And this is because, to put it simply, it is very difficult to open a closed lung, but once the lung is open, it is easier to hold it open. So when the patient is in inspiration, when you're ventilating, opening up a closed lung, you need this much pressure to open the lung. So you get only so much volume when the pressure is so much over here. But once you open the lung, right now here the lung is open, the volume has gone in. When you come back to the same pressure, there's a much higher volume inside the lung. So once you open the lung up, it's easier to hold it open. So just keep this in mind as well. Then you can have a flow volume loop. And so here you've got inspiration on above the line and expiration below the line. Both should come to start and end at 0, right? And this is a peak inspiratory flow rate over here. And this is a peak expiratory flow rate. So what can we use these ventilator forms, the waveforms? One is you can identify the mode and pattern of ventilation. And we said you can easily make out flow control and pressure control. So in flow control or volume control, you will have a constant pressure waveform in the flow, a constant flow waveform. And in the pressure control, you have a decelerating flow. Pressure waveform, variable in volume control, constant pressure in pressure control. And in the flow, the expiratory waveform is exactly the same in on volume control and pressure control. You can make out an assisted breath with a pressure below the baseline, suggesting patient inspiration. No inspiration, no dip below the baseline. So pressure support ventilation is a very interesting mode. It is a completely spontaneous mode. So it is patient initiated, pressure limited, and flow cycle, right? So what happens is the flow rate increases, and you can see then it starts decelerating because it's a pressure limited mode. And when the flow rate decelerates to a certain point as the lung fills up, the ventilator switches over or cycles over to exhalation. So it's a flow cycle mode, right? So it's so you can see it's patient initiated, pressure limited, and it is flow cycles. That's a very interesting mode, but it's very easy to make out once you know what is pressure support ventilation and you see the graphics. Now, very importantly, you can use these waveforms to identify problems during mechanical ventilation. Right? So let's see some of the problems. So like I said, if the peak and the plateau pressures both go up, it suggests that the compliance has fallen. And you have to figure out what is the cause of low compliance. If the peak goes up, but the plateau remains the same, it suggests an airway resistance problem, bronchospasm, whatever the reason may be, right? So you can very easily make out what has happened in this patient, right? So when you look at a resistance problem, let's say looking at volume control ventilation, you'll see that now in volume control ventilation, the tidal volume remains the same. So the flow rate will be identical. You will see changes in the expiratory waveform, right? So what you will see that the inspiratory part remains the same because that is controlled by the ventilator. But in the expiratory waveform, you'll see 2-3 things. One is the peak expiratory flow rate is reduced. And you'll see that the exhalation is prolonged because airflow obstruction or airflow limitation is the feature of increased airway resistance. So the reduction of peak expiratory flow and a prolonged expiration, right? And if you treat the patient, you can see the improvement as well. You see the peak expiratory flow rate increasing and the expiratory time shortening. And you can see something like that in the flow volume loop as well. This is a normal loop, but if you've got airflow obstruction, you get a scooped out pattern over here. And that suggests the airway resistance has increased. And you can see the peak expiratory flow has also reduced. Now, one very important thing you see when there is expiratory airflow obstruction is the presence of air traffic. So you see here the expiration has started, it's prolonged, And the next inspiration comes before this expiration has reached the baseline. So this suggests that there is air trapping, right? And when there is air trapping, there will be autopeep because the trapped air exerts a pressure inside the lung, and we know that there is autopeep. Now in the flow volume loop also you can see air trapping. This expiratory waveform doesn't return to baseline, and this is the amount of air which is trapped inside the lung. Now in order to know what is the autopeep, the ventilator manometer will not see the autopeep until you close the expiratory valve in expiration. Then the air which is trapped inside the lung will exert pressure, which will be picked up by the ventilator manometer. Right? So what you do is you occlude, give expiratory occlusion to close the expiratory valve in expiration to the expiratory hold button, and then you see that the pressure rises, and this is the total peep which reflects the intrinsic peep, right? So this, the presence of, you can see in the graphic that there is air trapping, and if you want to quantify the auto peep, you have to press the expiratory hold button, and you will see the airway pressure rising. You can use the graphics to fine tune mechanical ventilation, and you can see over here that there's a leak over here. The tidal volume doesn't come to baseline. Okay. Same thing as a leak. If you see the serrations, it suggests that there is water in the circuit, which is, so you need to empty your water traps and so on. You can set your expiratory cycling in pressure support ventilation. In some ventilators, you can actually change the cycling criteria. It is classically set at 25% of the peak flow, but some ventilators allow you to change that criteria. So you can increase or decrease the duration of the inspiratory time. So for example, this is set at 25%. If you want to shorten the expiratory time, what you get the inspiratory time, then you make the sensitivity, or you tell the ventilator to cycle at 35% of the peak inspiratory flow. So it actually cycles earlier when the flow rate has decelerated to 35% of the peak inspiratory. Same way, if you want to increase the inspiratory time, you make it say cycle at 15% of the peak inspiratory flow, then it will keep coming down till it comes down to 15% of the peak flow, and then it will cycle over to expiration. So you can use this to set the fine tune your inspiratory time in expiratory cycling in pressure support ventilation. Same way, the rise time, so sometimes the ventilators, the rate at which the flow rate rises in pressure control ventilation can be too fast. Sometimes it could be too slow. So you can use the rise time setting in some ventilators to optimize the rise time. So here you can see this is too slow over here, right? And here sometimes this is so fast that there's a pressure overshoot. And so this makes it uncomfortable for the patient. So if you see something like this, too fast a flow rate, then you can actually reduce the rise time and slow it down a little bit. Okay, you can use it to fine tune. In some ventilators, you can use the pressure volume loop to optimize your peep setting. So you've got this pressure volume loop over here. So like this. Now what happens here is at this point, which we call as a lower inflection point, the compliance of the lung has increased, and you see from a almost flat line, now the lung has started opening up, and it opens up very nicely. And so this is the beginning sort of recruitment, and the lung starts opening up. So this we call as a lower inflection point. If you give too much tidal volume, then at this point over here, which we call as the upper inflection point, the compliance again starts reducing, and that is because the alveoli are over-distended, are beginning to get over-distended. So this is the upper inflection point. So you can set your PEEP so that it is above the lower inflection point, so the lung remains open, so lung is much easier to open, and you make sure that your tidal volume that you set, the plateau pressure, is below the upper inflection point. Right, so you essentially ventilate the patient between the upper and the lower inflection points, and you can set your tidal volume to achieve the plateau pressure, which will be below the lower inflection points, and you set the PEEP so that you're above the lower inflection point. So this you can use to optimize your ventilator settings. Okay, but so this is sort of very basic use of graphics, but very important now. We can use graphics to determine patient ventilator asynchrony. Now, in most of the times, we do not want to keep our patients flat and knocked out. We want the patient to be awake. We don't want to give deep sedation, and we want the patient to breathe, and we want the ventilator to synchronize with the patient's effort. Okay, so essentially that means that when the patient breathes, the ventilator should give a breath, and when the patient exhales, the ventilator should open the expiratory valve. And if that happens, it's very good. If it doesn't happen, the patient can actually end up doing more work of breathing, which can make ventilation difficult, and it can hamper weaning as well. And this was a study which suggested that, one of our knee-jerk reactions to patient fighting the ventilator is to give sedation, knock the patient out, or paralyze the patient. But if you actually adjust your ventilator settings so that you can match the patient's effort, then you can actually have much less asynchrony than by just knocking the patient out. And asynchrony usually occurs in the setting where the resistance is high or the compliance is either very high or very low. And in the setting of expiratory airflow obstruction, COPD, where you've got auto PEEP, and we'll talk about that. So when you have auto PEEP, there is a high chance of all sorts of asynchrony happening, right? And also asynchrony happens when the patient has a very strong respiratory drive, like in pneumonia, ARDS, and which produces a high minute ventilation. So when the patient is actively breathing with a very high respiratory drive and tends to generate high tidal volumes and respiratory rates, that's also when you can get a lot of asynchrony. So you need to be careful in these sort of situations. Now, we know the differences between volume control and pressure control ventilation. We know in volume control, we like it because the tidal volume is held constant no matter what's happening in the lung and airway. In pressure control ventilation, the problem is the tidal volume varies with the lung characteristics. But one of the most important things to remember as far as volume and pressure control ventilation is concerned, as far as synchrony or asynchrony is concerned, then volume control ventilation, remember we said you've got a fixed flow rate, right? The flow rate is set and flow rate remains constant. So if the patient's ventilatory pattern changes, and then there can be asynchrony, unless you recognize that there's a change in the ventilator patient's ventilation and you adjust your flow rate accordingly. So there's a chance because the flow rate is fixed. On the other hand, in pressure control ventilation, the flow rate is not fixed. It is the airway pressure that is fixed, and the flow rate varies to reach that pressure, but that flow rate follows the patient's respiratory pattern. So the flow will vary according to the patient's demand. And therefore, in some instances, some sort of pressure preset ventilation might be more suited for synchrony rather than volume control. Right? So one of the advantages of pressure control ventilation is synchronization with patient effort is probably a little better with pressure control ventilation. Volume control ventilation, you can synchronize, but you have to keep paying attention. Okay. Now, every breath, any breath that we have, any mode of ventilation is decided by three things. One is what triggers the patient breath, what limits the patient breath, and what cycles the patient breath to exhale. So something has to tell the patient expiratory valve to open, and that is a trigger criterion. So then something has to tell the patient to limit the breath. So that's either the flow rate in volume control ventilation or the airway pressure or the pressure in pressure control ventilation. That cycling criterion is something which tells the ventilator to open the expiratory valve and switch over to expiration. So you can have trigger asynchrony in all three phases. Ventilator asynchrony in all three phases. You can have a problem during triggering, you can have a problem during the flow, and you can have a problem during cycling, right? So we'll start with trigger asynchrony. So that's a problem in the triggering of the ventilator. And this is probably one of the commonest types of asynchrony, right? And the common ones are ineffective triggering and double triggering. Okay. Now, so let's talk about this. So if you see this graph over here, this is the flow rate. Now we've not got a horizontal line, but okay, there's a horizontal, there's zero over here. So this is the horizontal line. This part above the line is inspiration. This part is expiration, right? Now, there are a lot of interesting things we are seeing over here. So one is, if I've drawn a line here, you can see that the air expiration is not coming to baseline and the inspiration is taking off below the baseline. So one is, we know that we are dealing with a situation where there is air trapping and auto PEEP. Now here you can see that in the pressure time curve, this is a breath. You can see the negative deflection, but it's not followed by a patient breath, by a ventilator breath. This breath is followed by a ventilator breath. This breath is followed by a ventilator breath, but this breath over here is not followed by a ventilator breath. In other words, the patient has breathed, the patient has generated a negative pressure breath, but it has not triggered the ventilator. And this is called ineffective triggering. Right? So this is ineffective triggering. Again, you can see over here, ineffective trigger in here the breath, but no, not followed by a ventilator breath. This is followed by a ventilator breath. This is followed by a ventilator breath. This is followed by a ventilator breath. This one is not followed by a ventilator breath. These are ineffective triggers, right? So why does this happen? One is you may not have set the triggering threshold right, but most commonly it is seen in the setting of autopsy, right? You can see over here that there is airflow obstruction, right? Or the patient is deeply sedated, or is weak, or he's got so either he's got depressed respiratory drive or his respiratory muscles are weak, and he cannot generate sufficient force to trigger the breath or to trigger the develop the pressure to trigger the breath. And what is the implication of this? Is that patient is breathing, but he's not getting assistance. And if there are many triggered breaths like this, ineffectively triggered breaths, it actually means he's breathing but not getting assisted, and that is going to tire out the respiratory muscles. It's going to result in respiratory muscle fatigue, and that can eventually lead to weaning failure or delayed weaning. Right. So this is an extremely important sort of problem that we need to identify, and it's not so difficult to treat it because most often the cause, right? It's in the setting of decreased airflow. I mean, increased expiratory airflow obstruction. So one of the things you can do is apply an external PEEP. So that external PEEP will offset the auto PEEP and it will improve the triggering, right? You can use flow triggering rather than pressure triggering, but most ventilators today are flow triggered. You can change the trigger sensitivity settings so that it's become more sensitive. And if the patient is sedated, then of course you should decrease the sedation and allow the patient to breathe. So you should try and reduce ineffective triggering. Now, as opposed to ineffective triggering, sometimes you get what we see as a double triggering. Okay, so now what is happening here is you can see this is the flow. You can see cut 2 breaths going up, and again in the pressure time curve, you can see that this patient has triggered a breath. The ventilator has given a breath, and immediately after that, it's followed by a next breath, which is not, which is immediately, there's no gap in between them. Right? So essentially what you get is 2 consecutive ventilator cycles separated by a very short expiratory time. Right? Now, when does this happen? This happens when the ventilator has gone into expiration, right? So the ventilator time inspiration is short, but the patient is still breathing. So the ventilator expiratory valve is closed, but the patient has got a very strong respiratory drive. He continues in the inspiration with a very strong inspiratory drive, and so that opens the inspiratory valve, and so essentially you get a double breath. So in the patient's same breath, he's triggered the ventilator 2 times. The patient's effort is not completed at the end of the ventilator cycle, and his ongoing inspiration, which is strong enough, triggers a second ventilator cycle. Okay, so again, same thing. Patient's inspiratory effort continues. It remains present even after the ventilator inspiratory time has finished, and the patient's inspiratory breath is strong enough to trigger another breath. So what are the implications of this? He actually gets a double tidal volume. In the same breath, in his own breath, he gets 2 ventilator breaths, which means he gets double the tidal volume. You think you're giving lung protective ventilation of 6 mL per kilo, but actually he's got 6 plus 6 ml per kilo in his breath, which is, it may be double the tidal volume. So that's injurious to the lung. So in double triggering is not just a fancy thing which you look on the waveform. It can be detrimental because it gives you a overinflation and can lead to ventilator-induced lung injury. And essentially, it means there are 2 conditions that you need. One is you need a strong patient drive, and second, you've set an inspiratory time which is too short. So what you need to do is you need to prolong the inspiratory time. So increase the mechanical inspiratory time, and you can overcome this. You can sedate the patient to decrease the respiratory drive, but if changing the ventilator setting achieves this goal, it is probably better. Sometimes you get what is called as auto triggering, that a small trigger will set off the ventilator, like cardiac oscillations or some even fluid in the circuit the movement of fluid can trigger it. So you need to change your ventilator threshold. Now you can get synchrony during the flow phase, right? When the gas is flowing into the lung. And essentially your ventilator flow can be either too fast or too slow for the patient. And again, it happens largely in volume control ventilation because you've kept the flow rate constant. And unless you change the flow rate to match the patient's ventilatory flow rate, you will get a asynchrony. In pressure controlled ventilation, it's less likely to happen because the flow pattern is generally matching the patient, except the rise times you can set a little faster or slower. Okay? And this is important to have matching of flow because again, if the flow rate is inadequate, you will actually the patient will end up doing more work. The work of breathing will increase. So here you've got pressure time, flow time, and tidal volume. And here you can see that what's happening is normally the pressure should have risen like this with a convexity as seen by the dotted line, but here there's a slight concavity in the rise in airway pressure. Right? And you can see the flow rate here is about 50, 60 liters per minute. Now here you can see it's even worse, right? It's almost like the patient is sucking air, and here it's getting even worse. The pressure is going all the way down, and this is at a lower flow rate, and here the flow rate is even lower. And so you can see that there is a sucking out of the breath almost in the pressure time curve, and this suggests the flow rate is too low. Here it's not too bad, it's just a little less, and here it's getting progressively lower. So this means that the flow rate is too low, or the patient's ventilatory demand is too high. So your flow rate is not matching the patient's demand. So you can increase the flow rate, or you can switch to a pressure limited mode, which will match the pressure. Sometimes you can get a flow rate which is too high, right? So this means that the flow rate is going up too fast, and what happens is you can see over here that there's an overshoot of pressure in the pressure time curve. The flow rate is constant, but it's too high, and there is an overshoot in the pressure time curve over here and over there. So in the early part of inspiration, you see a peaking, but an excessive pressure suggests that the flow rate is too high, right? And that can also lead to problems. Now, so you've seen pressure to flow rate too low and pressure to flow rate too high. Now cycling. Either the ventilator can cycle before the patient wants to exhale, or it will cycle after the patient wants to exhale, right? So this is what is delayed cycling. Here the patient has exhaled, but the ventilator is still in inspiration, right? So the patient's muscles are exhaling, but the expiratory valve of the ventilator has not yet opened. And so what you will get is a bump in the airway pressure in the late part of inspiration, right? So this suggests that the exhalation is delayed, right? On the other hand, you could get when the ventilator exhalation is occurred too fast, it's occurred much earlier, and here it will happen. And here, this is exactly the time where you actually get bubble triggering, right? So the patient will still be in inspiration, but the ventilator has changed over to exhalation. And if the patient's effort is good, it might double trigger the ventilator over here. So this is delayed cycling, right? Can you see over here that this is a bump in the late part of inspiration, and that suggests that there is a delayed cycling over here. Now, this graph over here has got all the waveform, all the many problems over here, right? So you can see here there is ineffective triggering. You can see here there is delayed cycling, and you can see in this breath there is actually too fast cycling. I mean, too fast a flow rate. It's all sorts of things are happening in this patient, and someone needs to figure out what is going wrong in this patient. Okay, and finally, there is a new sort of thing which people have realized more is what we call as reverse triggering. Now, we said a double triggering occurs when the patient breathes and that continuing breath triggers the next breath. Reverse triggering occurs when the patient is not breathing. There is no breath, but the ventilator breath triggers a patient breath, right? So the patient is not breathing. The ventilator breath which was given was a non-patient triggered breath, but that breath of the ventilator triggered a patient effort, and that triggered the next breath from the ventilator. So it's a little difficult to make out, but first thing that you need to see is that there is no patient trigger over here. Right? This is a ventilator breath which is not triggered by the patient. And as the patient's ventilator is going here, the ventilator has triggered this breath over here. Right? It's taken the trigger over here. So, and you can see over here that results can also result in breath stacking or double tidal volume being given. So this breath is not given by the patient. This is given by the ventilator. And here, this has triggered the breath. And you can see a dip over here and over here. And here you can see the rise in pressure. And that is now giving rise to the next breath. And it usually occurs in heavily sedated patients, maybe when they're transitioning from the sedate to the awake state. We don't know what is the exact mechanism of disorder, whether it's something to do with the stretch receptors or whether it's something to do with the diaphragm activation, because this has also been described in patients who are brain dead. Right? So, but essentially what happens is that you might get a breath stacking and a double tidal volume being delivered. So this is just to make the difference. This is a double trigger. So this is the first breath. This is a patient trigger breath. You can see the patient trigger over here. And then that is triggered the next patient, the ventilator breath, right? So this is a double trigger. This is a breath. Again, you're seeing two breaths over here, but the breath which has triggered the second breath is not a patient triggered breath. This is a ventilator initiated breath, and that is actually given the next breath. So this is a reverse triggering. Okay, so I think I've covered it. I'll just quickly see if we can go over some of the things. So tell me what sort of dysynchrony is this? Right, I'll tell you here that the inspiration is too long because you can see it's just going on and on over here. So this is too long an inspiration, right? Now this, so here you can see this you can see two consecutive breaths. So is this double triggering or reverse triggering? And this is double triggering because in the pressure time curve, you can see a negative deflection. Yeah, so this is a patient triggered breath. Again, you can see a small deflection in the airway pressure and then the next breath goes up. So this is double triggering. Okay. Now what is happening here? See, the flow rate is less than 40 over here. And you can see the severely scooped out flow rate. So this is a inadequate flow rate. Now you can see here, these are patient efforts which are not followed by a ventilator breath. So this is ineffective triggering. And this, there is no asynchrony here, right? You should also be able to make out breaths where there is no asynchrony. In fact, this is fully controlled ventilation. There is no patient effort. So there is no problem over here. So I think I'll stop here and thank you very much for listening. And I'm happy to take questions.
Thank you, sir. Thank you for this very lucid and very informative talk about the basics of ventilation and patient ventilator synchrony. So we're waiting for the questions from the delegates. So delegates, please type your questions and send to us so that we can answer all your queries. Any questions so far, Rohit?
Not
No,
yet.
sir.
No, so in the meanwhile, let me just announce that there will be no tea break and no lunch break. So the questions and the presentations will continue without any breaks. You will have to make your own time for your tea and coffee and lunch. There are tabs on your auditorium where you can book the study material or for the new book. So please go there and book your books if you want. We have obtained special discount from both the publishers, CBS publishers as well as JP. So you can order a copy of this book and the book on infectious diseases in critical care. Okay, so Jiggy sir, let us give them another minute to see if there are any questions. But it was very, very clear, so maybe there won't be any questions.
Okay, great. Thank you.
No, sir, please stay logged in. We'll wait, give them a couple of minutes.
Okay, sure.
If you want to add something in the meanwhile, you can. Okay, there is a question about PRVC for you. What about PRVC? So how will you see the graphics on PRVC is what Dr. Neeraj wants to know. And he
So-
wants you, someone else, Dr. Pulagandla, wants you to explain the cyclic trigger graph again.
Cyclic trigger graph. Okay.
So I'm not sure what he means. Dr. Rashmi, can you please clarify cyclic trigger graph? What do you mean by that?
Is this the one? Which one? Is this the one you wanted to explain?
No, sir. I'm just waiting for her to type in again. What does she mean by the cyclic trigger graph? Okay.
Yeah. So I
So
think
in the meanwhile, how to measure plateau pressure in the PCV mode is another question.
Yeah.
While we wait for the answer about the.
Yeah, so I'll talk about PRVC and the plateau pressure. So in PRVC is exactly a pressure control mode of ventilation, except that the inspiratory pressure setting is determined automatically by the ventilator so that you get your desired tidal volume. So if you say I want a tidal volume of 400, the ventilator will estimate that I need say 15 pressure to give this tidal volume. So it will start ventilating the patient with a pressure controlled breath. So although it's called pressure regulated volume control, it is actually a pressure controlled mode, right? Designed to give you a target tidal volume of 400 ml or whatever tidal volume you set. So it starts when it gets 15 ml at 15 centimeters pressure. And let's say the tidal volume that you get now is 350 ml. So the ventilator says, okay, I'm getting 350 ml. So it will automatically increase the pressure control level by 3 to get the tidal volume of 400 ml. So essentially what is happening is a pressure control mode in which the ventilator automatically adjusts the pressure control level in subsequent breaths to achieve the target tidal volume, right? So the waveform will be exactly like in pressure control ventilation. Now, what about plateau pressure in pressure control ventilation? That's a very good question. Essentially you have to, in many vents, you can't close the inspiratory valve inspiration in pressure control ventilation, but you can, if there is the top inspiratory pressure is the equivalent of your plateau pressure. So in whatever is your pressure control setting is equivalent to your plateau pressure in pressure control ventilation, because that is the pressure which is going to be there when the lung is fully expanded, and that's going to match the pressure inside the lung. So that you can take as your plateau pressure.
one more question regarding PRVC from Mulabali. What is your experience with PRVC ventilation?
Not much. We don't really use much of PRVC. Again, it's let's say you want to use you want to use pressure control ventilation and you want to guarantee tidal volume. Now, theoretically, let's say a lung is very stiff with ARDS and you don't set a pressure limit. The pressure can go on increasing, say to 50 centimeters of water to get your 400 ml tidal volume. So you can guarantee your tidal volume, but you will get a very high airway pressure to achieve that tidal volume because the ventilator keeps stepping up the pressure control level to reach your tidal volume of 400 ml. Now you will get, so what is the problem? Now you will have a very high airway pressure, or the plateau pressure equivalent will be 50, and which is injurious ventilation, right? So even in PRVC, you have to set a cutoff, or you have to set a limit beyond which the ventilator will not increase the pressure. And typically it's about, depending on your ventilator, the ones we have, it is 5 centimeters below your airway pressure alarm limit. So if you set your airway pressure alarm limit says 40, then the maximum the ventilator will automatically adjust the pressure up to is 35 centimeters of water, right? Now at 35 centimeters of water, you will not get 400 ml tidal volume because the lung is very stiff. You will get only 250 ml. So your patient will get hypoventilated. So although you think you've got a pressure targeted mode and you've got pressure control ventilation with a guaranteed volume target, it still depends on how stiff your lung is or how bad your airway resistance is and what kind of pressure limit you've set. And if your lung is really stiff, you will not be able to achieve that tidal volume even with your PRVC. So you need to be aware of this limitation in PRVC. So PRVC works well for normal to moderately severe lung disease, right? So in that case, the adjustment of airway pressure which takes place will still be within your protective lung ventilation range, and you will set your target tidal volume obviously within your 6 ml per kg range, and you can ventilate the patient. So in post-operative patients, in say Guillain-Barré syndrome or neuromuscular diseases, or someone with mild pneumonia or ARDS, you can use PRVC because you don't have to fiddle around too much and worry too much about these things. But the moment you have a problematic lung, I would personally stick to simple volume control ventilation because I'm guaranteed my tidal volume. If my plateau pressure is high, I will start coming down on my tidal volume and adjust accordingly. And I know exactly what is happening with my tidal volume. In any pressure control ventilation, the biggest danger is the pressure is constant and the tidal volume keeps falling as your lung gets worse. And then you'll get suddenly you'll find that the patient is got a very high CO2 and there are other problems that are occurring because of that.
So you don't recommend PRVC in ARDS? Are you recommending?
Certainly not in moderate to severe ARDS. In moderate, mild to early moderate, maybe might be okay. But you have to be, whenever you are ventilating someone with a bad lung with any pressure control mode, and PRVC is a pressure control mode, you have to be careful about the tidal volumes and which are being generated. And in PRVC, you have to also worry about the pressures which are being generated.
So there are a couple of questions regarding inflection point and how to set PEEP and tidal volume based on the pressure volume curve.
Okay, so I will need to share my screen again if possible. Is my screen being shared?
Yes, sir. It's shared.
So this is the pressure volume curve. So now again, this I've shown it very easily over here, but what you need is a ventilator in which you get a quasi-static pressure volume curve. So you have to have a flow rate which is about 10 liters per minute. You have to set the flow rate to 10 liters per minute. You give a prolonged inspiratory time and set the tidal volume of about 800 ml to 1 liter, right? Some ventilators will allow you to do it, will have a setting for it. Others you have to do it manually. You also need a ventilator which allows you to put cursors to see your inflection points and measure the points. Now what happens now over here, the lung as the lung expands, here it is a little stiff and it's difficult to inflate the lung. When it goes beyond this point, which is called a lower inflection point, is here where the compliance has changed. And now the lung opens up very easily. Here it's not opening easily. And here a small change in pressure is producing a large change in volume. So here the compliance has opened up. As you inflate the lung beyond a point, the compliance drops again, right? The line is falling flat. And that is called the upper inflection point. So you should set your PEEP above the lower inflection point, which means the lung will be open most of the time. And you should set it below the upper inflection point so that the lung is not over distended. So your PEEP has to be here and your tidal volume and your plateau pressure must be maintained below the upper inflection point. So essentially you're ventilating the patient in this zone over here. I hope that answers your question. But you need to set your ventilator to get the slow flow rate, which is like a quasi-static, because it has to be compliance related, right? It has to be low airway resistance, so low flow rate. And you need to have adjust the cursors to identify a lower and your upper inflection points and the corresponding tidal volumes and pressures. Sometimes you don't see these inflection points, and then you can't really use this to set your PEEP. But if you do see this, then you can use this sort of technique. It's a very fiddly, it's quite fiddly, it's quite painful, and therefore there are other simpler ways of setting PEEP. But if you want, you can certainly use this method.
Now we are now getting flooded with the questions.
Flooded?
Yes, sir. One question, Dr. Harsha Vardhani. Sir, how do you titrate trigger sensitivity, inspiratory time rise during weaning in COVID times?
Yeah, I mean, during weaning, so I mean, essentially, whenever you're in weaning, you will be on a pressure limited mode, hopefully pressure support or something like that. So you just titrate it so you see a good, nice waveform. If your rise time is too fast, you'll see a bump in the early part of inspiration. So you reduce the rise time a little bit. And whether it's COVID or non-COVID, I guess it's the same, that your weaning should be more or less the same. Keep pressure support, keep a level of pressure support which produces adequate tidal volume of say about 300 or 400 ml. And also reduces the respiratory rate a little bit to about a reasonable respiratory rate. and just the right time so that you get a nice smooth square waveform in your pressure time curve without any bumps in the early part of inspiration. If there's a bump in the early part of inspiration or there's a very slow rise, then you need to adjust your rise time. But otherwise, you should be okay.
Okay, Amol, I think we'll stick to questions only about the graphics and asynchrony. So we can take this question from Dr. Karthikeyan. And one more question after that, only related to ventilator graphics. So he wants to know, Jiggy sir, premature cycling and double triggering happens because of the same reason.
Yes.
So is it that both asynchronies always happen simultaneously?
Yeah, so you're right. It's a good question. So we took the double triggering in the trigger asynchrony, but actually it is an early cycling, right? So if you have early cycling and it is coupled with a patient who has got a strong respiratory drive and generating high tidal volume, that's when you will get double triggering. So if the patient says doesn't have a very strong respiratory drive, he can still have delayed cycling. I mean, he can still have delayed cycling, but it may not have a double trigger. But if you have got delayed cycling, early cycling, if you got early cycling and a strong respiratory drive, you could get double triggering. So let me put it this way: the essential asynchrony is early cycling. If early cycling is coupled with a strong respiratory drive, you'll probably get double triggering. Does that answer your question?
Sir, and another question
was I clear, or should I explain it again?
No, I think that was okay, sir. Last question. Can you explain again about delayed triggering?
Yeah. So delayed triggering is when the patient delayed triggering or ineffective triggering or delayed cycling.
Yeah. It says delayed triggering. I presume she wants to know about trigger delay. Trigger delay, I think.
So, okay. So one more thing.
I'll read you the exact question, which is from Dr. Hina Mahiuddin. Maybe she can explain in detail by typing again. But she says, please explain delayed triggering graph again. So was there a graph which showed a delayed triggering? Because I didn't see one.
No, there wasn't delayed triggering. There's a delayed cycling and there is ineffective triggering. And sometimes you can have a problem because in some ventilators, the patient takes a breath, but there's a time lag between the patient taking a breath and the ventilator giving its breath, So that can actually also cause a little bit of asynchrony, and that you have to depend on the method of triggering. So like pressure triggering sometimes has a greater time lag. Flow triggering is more sensitive, so it's a little better. If you have NAVA, then the time lag between the neural inspiration and the diaphragm getting depolarized and the ventilator giving the breath is also reduced, so that may be a little better. So so you can get some problems because of that. So that in that case, the trigger sensitivity can sort of make a difference, and you can make it more sort of sensitive.
So Amol.
Yes, sir.
I think there are lots of questions. We can put Dr. Divatia's email ID in their box, and they can write to him directly, because there are many questions which are actually not related to
the topic.
Yeah. So I think, sir, she wanted to know about cycling only, delayed cycling.
So delayed cycling is, so again, if I can share my screen. Okay. So if you can see this, yeah, so here delayed cycle is that the patient is still inspiring, right? But the patient has finished exhaling, but the ventilator is still in inspiration. So a ventilator has not opened the expiratory valve. So now what is happening is the patient is exhaling, right? The patient himself is exhaling, but the expiratory valve has closed. So what that produces a bump in airway pressure in the late part of the inspiration. Have you understood this concept? So you are exhaling, you have started exhalation, right? but the ventilator has not opened the expiratory valve because that is delayed cycling. So the ventilator is still not opened the expiratory valve, but the patient has started exhaling. So now the patient is blowing against a closed expiratory valve, which produces this bump towards the end of inspiration, right? In the late inspiration. So that is what becomes in delayed cycling. So this is what you'll get in delayed cycling. Patient wants to exhale, but the expiratory valve is still closed. And so there is a small bump in pressure at the end of exhalation.
Thank you very much, sir. Amol, I think we'll let sir go and they can ask their questions directly to him on email.
Even for Dr. Nitin Karnik, we'll share this email address and the delegates can directly ask the questions.
Okay, thank you.
Thank you, sir.
Thank you very much, sir.
So, for the next talk about acute meningoencephalomyelitis, I would like to invite Dr. Bhuvan Krishna for this talk.
So Dr. Bhuna Krishna is Professor and Head Department of Critical Care Medicine at St. John's Medical College and Hospital in Bangalore. And we'll go to the talk on acute meningoencephalitis and we can have question and answers at the end of the talk.
Warm greetings to all. At the outset, I'd like to thank the organizing committee for this opportunity. Acute meningoencephalitis. What will be the key concepts that will be covered in this presentation? Acute meningoencephalitis, I will be covering mainly in adults. What is the definition, the etiology, the clinical presentation, the relevant history, the investigations, the treatment, and case discussions. What is acute meningoencephalitis? It is the inflammation of the brain parenchyma with neurological dysfunction. It has both infectious and autoimmune causes. The terms meningitis, encephalitis, and meningoencephalitis are very often interchangeably used, but there are very clear-cut definitions for each of these. Meningitis is nothing but the inflammation of the covering of the brain and of the spinal cord. So this is the covering of the spinal cord and the brain, which is the meninges. So it is the inflammation of the meninges, which is termed as meningitis. Encephalitis is the inflammation of the brain parenchyma alone, whereas meningoencephalitis means it is the inflammation of the meninges, that is the covering of the brain and the spinal cord, along with the brain parenchyma. The etiology for encephalitis is quite wide. There are infectious causes, host or para-infectious causes, which is also called as acute demyelinating encephalomyelitis, or autoimmune causes, which leads to about 20 to 30% of the causes for acute meningoencephalitis. Among the infectious causes, starting from viruses, most commonly herpes simplex virus, the Japanese encephalitis, of late the Nipah virus epidemics that we have been seeing, the rabies, measles, mumps, or varicella zoster viruses can cause acute meningoencephalitis. Among the bacteria, the common ones are Brucella, Bartonella, or Listeria. The Rickettsia, the spirochetes, or the more common in India, the Mycobacterium tuberculosis, or ribbon fungi can cause acute meningoencephalitis. When we talk about post or para-infectious acute demyelinating encephalomyelitis, it's more commonly after a viral prodromal or a viral infection, or after a post-vaccination. It is common to note patients, especially the children and the younger adults, can develop acute demyelinating encephalomyelitis. Of the autoimmune causes, it is about 20 to 30% of the cases of acute meningoencephalitis. It is quite a high number. The clinical presentation can be anywhere from days to weeks. Patient may be suffering from lethargy that can lead on to fever, headache, seizures, with presentation with altered sensorium, or they can present with just focal neurological deficits or psychiatric manifestations. Many a times, patients are extensively evaluated in the psychiatry department before they realize that the patient could be suffering from a meningoencephalitis. It's very important to take a relevant history, especially if the patient has suffered from a recent viral illness, or have they been in contact with people who are ill, those who are suffering from either varicella or from mumps or from measles, or has there been a travel history to an endemic area, like if they have traveled to a malaria endemic area, or contact with animals is very important, especially for history with respect to rabies, meningoencephalitis, or with brucellosis. Occupational history is very important. Vaccination, as post-vaccination, patients can develop acute demyelinating encephalomyelitis, or any ingestions of animal products that could be infected with brucella. In immunocompromised status, HIV can cause a wide range of opportunistic infections from viruses to fungi. Chemotherapy and cancer can lead to an autoimmune encephalitis. With respect to the animal contact history, it is important to know if the patient has traveled to any caves or has been in contact with bats, which can give us a clue about either rabies or Nipah meningoencephalitis. Birds, which can lead to cryptococcus or Japanese encephalitis. Cats can be a case for rabies or Coxiella or Toxoplasma gondii. Contact with dogs, very important for rabies. Rat or rat urine for leptospirosis. Dealing with ticks, rickettsia, or ingestion of raw milk can be a clue for brucellosis. Or if they have been into an endemic area where they're exposed to mosquitoes, which can give us a clue whether we are dealing with dengue, Japanese encephalitis, or malaria. The clinical signs can also give us a possible clue to the etiology. If there is acute meningoencephalitis along with hepatitis, Coxiella burnetii can be the etiology. If there is generalized lymphadenopathy, we can suspect HIV, CMV, or EBV virus, or tuberculosis, or histoplasmosis. If there is parotitis along with an acute meningoencephalitis, mumps can be the etiology. Rash, varicella zoster, measles, rubella, or even HIV infection or rickettsia. If the patient has respiratory findings in the form of a pneumonia or acute respiratory distress syndrome, we could suspect tuberculosis, influenza, mycoplasma, Nipah, or histoplasma virus. Acute demyelinating encephalomyelitis is nothing but an immune-mediated inflammation of the brain parenchyma. It affects both white and gray matter of the brain along with the spinal cord. Here we can see an image of the spinal cord showing intense hyperintensities, which shows demyelination of the spinal cord. In this, we can see lesions both in the gray and white matter, suggestive of acute demyelinating encephalomyelitis. Patients can present with polyfocal neurological deficits. It is usually a self-limiting disease. It affects mainly children and young adults, very commonly after a post-viral syndrome or after vaccination. As already mentioned, acute demyelinating encephalomyelitis affects both your white matter as well as the gray matter, which can be seen clearly in MRI T2 FLAIR images. Sometimes acute demyelinating encephalomyelitis can be treated and multiple sclerosis can be missed. The first time presentation of multiple sclerosis can have similar presentation as acute demyelinating encephalomyelitis. So what are the distinguishing features between the two? ADEM generally affects children less than 10 years. Multiple sclerosis mainly affects children more than 10 years. Encephalopathy is always present in ADEM. Multiple sclerosis, it may be absent. ADEM has polysymptomatic, that is, they have multiple neurological deficits. Whereas multiple sclerosis, there may be a single symptom. If there is optic neuritis in ADEM, it is usually bilateral, and in multiple sclerosis, it is unilateral. As already mentioned in the MRI, the lesions in ADEM are both cortical deep and gray matter lesions, whereas in multiple sclerosis, it's periventricular, especially callosal lesions. In CSF analysis, there is lymphocytosis in ADEM, whereas in multiple sclerosis, we can see elevated immunoglobulin, especially the IgG. When patients recover from ADEM, when we see follow-up MRI, there are no new lesions that are seen. But in multiple sclerosis, with recurrence of the disease, new lesions can be seen on follow-up MRI. Another commonly used term in acute meningoencephalitis is limbic encephalitis. So what is limbic encephalitis? Limbic encephalitis is inflammation of the limbic region, that is your thalamus, hypothalamus, frontal lobe, amygdala, olfactory bulb, and the hippocampus. Patients usually present with anterograde memory dysfunction, behavioral changes, and seizures. The common viruses that can cause limbic encephalitis are HSV, Anovvaricella zoster virus. It can also be seen in syphilis and Mycobacterium tuberculosis. What are the important investigations that needs to be done in acute meningoencephalitis? CSF, MRI, important blood tests, EEG, and ancillary tests for confirmation. So you must be wondering, why CSF before MRI? Most often patients coming with acute meningoencephalitis would have had a CT scan done at the time of admission. If CT scan does not show any signs of raised intracranial pressure, CSF analysis can be done right away in order to help us to come to a quick diagnosis, especially in case of infectious causes. So when do you need to do a neuroimaging before CSF analysis, especially when there are signs of raised intracranial pressure? So how do we get a clue? Any change in level of consciousness with moderate to severe impairment in consciousness. If there are focal neurological signs, if there is papilledema, any abnormal movements of the eyes, that is doll's eye movements, abnormal posturing, or relative bradycardia with hypertension, or in patients with known immunocompromised status, it is better to do an imaging like a CT scan before the CSF analysis can be attempted. This is quite an elaborate slide, but I think it's very important, and most of us are aware of the facts on the slides. So the CSF analysis, as we all know, when it is infection, be it viral, bacterial, fungal, or mycobacterial, there is pleocytosis. In bacterial, we know it is going to be neutrophilic pleocytosis. The pleocytosis in bacterial and in mycobacterial is more than 100, whereas in viral, it can range from 10 to 200. Fungal also, the cell counts are going to be high. In viral and fungal, it could be a mixed picture. And in mycobacterial, it's predominantly lymphocytic pleocytosis. When it comes to ADEM and autoimmune, the CSF cell counts can be normal or just marginally elevated, which is predominantly lymphocytes. The proteins are very much elevated in mycobacterial and bacterial infection of the brain and of the meninges. The glucose is very, very low in bacterial and mycobacterial or fungal infection, but it can be normal in viral, ADEM, and autoimmune. The most important test of the CSF analysis is PCR. That helps us to come to a diagnosis of whether it's viral, bacterial, fungal, or mycobacterial. When we have to make a diagnosis of ADEM or autoimmune, we will have to send it for antibody testing. For ADEM, we'll have to send it for anti-MOG antibody. And for autoimmune diagnosis, we'll have to send the anti-NMDA or the anti-VGKC antibody. The CSF PCR analysis, as we are all aware, the biofilm array panel is the only panel that has been FDA approved. The meningoencephalitis panel test, which is quite expensive, covers 14 pathogens that are commonly involved in CNS infections. That is 7 viruses, 6 bacteria, along with the cryptococcus. The sensitivity and specificity is more than 90%, but we can see a high false positive rate, especially with Streptococcus pneumoniae, where the false positivity rate is around 11.4%, and a 2.2% false negative rate, especially with HSV1 and 2. A small note on HSV CSF analysis: there could be absent lymphocytic pleocytosis. When we are doing the LP-CSF, there could be an increased opening pressures, and elevated CSF proteins may be also seen. Coming to the next investigation modality is neuroimaging. Neuroimaging, especially MRI, is very, very important. It is sensitive and specific and helps us to make a diagnosis based on the location, the pattern, and the characteristics of the abnormalities. For example, in herpes simplex encephalitis, you can see that in the left temporal lobe, there are hyperintensities, which is characteristic of herpes simplex meningoencephalitis. In autoimmune encephalitis, like in this case, where the limbus has been affected, as you can see, there are hyperintensities, which will give us a clue whether it is an autoimmune encephalitis. Very often in autoimmune encephalitis, the MRI can be normal in 70% of the patients. In ADEM, there could be multiple areas of demyelination. And when we go on to do the gadolinium scan, we can see there can be incomplete rings which can help us to come to a diagnosis of ADEM. The neuroimaging, especially the MRI, can also help us in prognostication in ADEM. There are two case studies that are shown in this imaging. The case 1, we can see there are hyperintensities in the cerebellum as well as in the brainstem. In the diffusion weighted image, it is clear these hyperintensities are seen. In ADC, we can see there is no blackening of the same regions. On follow-up, these patients have completely recovered from the demyelination. Whereas in case 2, there are hyperintensities seen in the brainstem. And in diffusion weighted image, we can see a hyperintense signal. In ADC, we can see a black region of the brainstem. On follow-up, you can see that this patient has not recovered from the demyelination and should be left with significant neurological deficits. So, in ADEM, the MRI, along with the diffusion weighted image and the ADC maps, can help us to prognosticate the recovery, the neurological recovery. The third important test is EEG, or the electroencephalogram. EEG helps us to make a diagnosis of whether there are ongoing seizures, and for the therapeutic monitoring when we are controlling seizures, for diagnosis of non-convulsive status epilepticus, and depending upon the region of the epileptiform discharges, we can come to the possible etiology. Like in this case, there is periodic lateral epileptiform discharges, which is called in short PLEDS. PLEDS is seen in 80% of the cases of HSV in the temporal lobe. So if you see these PLEDS on EEG, it can help us to come to a diagnosis of HSV. It is also, as I've mentioned, useful for the diagnosis of non-convulsive status, especially when the patients are not recovering despite treatment and control of seizures. There could be diffuse slowing with delta waves on the EEG, which can tell us that the patient is in deep or is suffering from irreversible brain injury. It can help us in prognostication. This is the EEG of status epilepticus. So sometimes patients will need 24 hours EEG monitoring to help us to control the seizure activity. This is a case of anti-NMDA receptor encephalitis, that is the autoimmune encephalitis, where we can see an extreme delta brush pattern, which is characteristic of anti-NMDA receptor encephalitis. The other important test that needs to be done to help us to come to a diagnosis is blood culture. especially in case of bacterial and fungal infection, nape of skin biopsy for rabies, serology of blood for rickettsia, varicella, or Japanese encephalitis. If still the diagnosis is unclear, we may need to go in for a brain biopsy. If there is peripheral eosinophilia, it is seen more commonly with fungal and parasitic infections. So what are the treatment? After we have secured the airway, breathing and circulation, we'll need to monitor the blood sugars and control raised ICP. We'll have to control seizures and go on to the specific treatment. In all cases, we will have to start empirical treatment with antibiotics, suspecting bacterial meningitis until the CSF reports are available. Acyclovir in a dose of 10 mg per kg every 8 hourly should be started as soon as a suspicion of acute meningoencephalitis is made, because morbidity and mortality is high with delayed treatment, especially with herpes simplex encephalitis. Mortality at 18 months is as high as 28%. So what are the predictors of poor outcome in HSV encephalitis? Age more than 30 years, low GCS, that is GCS less than 6 at presentation, and starting acyclovir 4 days after the onset of symptoms. So the sooner we start acyclovir in patients with acute meningoencephalitis, the better the outcome. The duration of HSV treatment is anywhere between 14 to 21 days. We should remember that there is a very high chance of relapse, so a repeat CSF should be done before completion of the course in order to take a decision whether we need to continue for another week of acyclovir or not. What is the role of steroids in HSV? Only in severe cases of vasogenic edema with mass effect, or when there is vasculitis, or when there is an occurrence of autoimmune encephalitis after HSV infection, which is commonly being recognized, especially with anti-NMDA antibodies, then only should corticosteroids be considered in HSV infection. What about other viral encephalitis? Varicella zoster encephalitis, the treatment is acyclovir and steroids. In HHV6 and cytomegalovirus infection, it is ganciclovir or foscarnet. In HIV infection, it's antiretroviral therapy. Other arboviral infections, there's no specific treatment. Ribavirin can be tried, interferon alpha, immunoglobulins, along with dexamethasone is the treatment. What about autoimmune encephalitis? Autoimmune encephalitis can be either due to paraneoplastic or due to autoimmune etiology. If it is paraneoplastic, it is usually due to antibodies to the intracellular neuronal proteins. If it is autoimmune, it is antibodies to the neuronal cell surface or the synaptic proteins. So the treatment in autoimmune encephalitis, if it is paraneoplastic, it is mainly tumor resection along with chemotherapy. For other causes of autoimmune encephalitis, it is mainly immunomodulator therapy in the form of methylprednisolone, where we'll need to give 1 gram per day, that is your pulse methylprednisolone. We'll have to consider immunoglobulins or plasma exchange, rituximab or cyclophosphamide. The dosage of steroids has to be around 20 to 30 mg per kg per day, max 1 gram per day for at least 3 to 5 days, and a prolonged tapering course of steroids over 4 to 6 weeks, otherwise the relapse of ADEM is high. Other drugs that can be covered if there is no response to high dose of steroids is immunoglobulin, a 2 grams per kg course over 2 days, or it can be spaced out over 5 days. If immunoglobulin therapy is not available, or if the family cannot afford, plasma exchange can be considered. If ADEM is refractory to steroids or immunoglobulin or plasma exchange, rituximab or cyclophosphamide can be considered. What is the prognosis for meningoencephalitis? The overall mortality is around 5 to 15%. With HSV, even with treatment, the mortality is about 10 to 15%. HSV can have prolonged neuropsychiatric manifestations. Up to 43 to 60% of the patients can be left with neuropsychiatric manifestations. In arboviral infections, the mortality is around 10 to 30%, but they can be left with severe neurological sequelae. Generally, with autoimmune meningoencephalitis, the mortality is much lower, but relapse is higher. Let's come to the first case discussion. These cases have been treated in our hospital. So I'd like to discuss the first case. A 30-year-old lady had delivered a baby 10 days before presentation to the hospital. It was a full-term, normal vaginal delivery with no complications in an outside hospital. She comes to the hospital with 3 days history of fever and headache, increased sleepiness, avoiding nursing of the baby, and sometimes aggressive behavior. What are your DDs and how will you evaluate? So our DDs that we considered were meningoencephalitis, acute meningoencephalitis. Although she is postpartum, we will have to think of treatable causes. Cortical venous thrombosis because she is postpartum, or it could be your PRES, that is your posterior reversible encephalopathy, stroke-like syndrome. So how did we evaluate? We took a good history, examination, went ahead to do a CT, MRI, along with an MRV to rule out CVT, and did a CSF analysis. We started off with empirical treatment, ceftriaxone in meningitic dose of 2 grams IVBD, along with vancomycin and acyclovir 10 mg per kg 3 times a day. Her reports came back as CSF had pleocytosis, which was mainly lymphocytes, 70% were lymphocytes. Glucose was near normal, that was 114 milligrams per deciliter, where the serum glucose was 180. Proteins were high, 86 milligrams per deciliter. We can see the MRI shows hyperintensities in the temporal lobe. Her CSF PCR came positive for HSV1 virus. Here is the case 2. A 17-year-old young boy who was on his study leave for 12th board exams had a short duration of febrile illness with running nose and mild GI symptoms. After 4 days of onset of fever, the mother noticed that he was unable to get up from bed, eat, and was sleeping most of the time. Then he threw multiple episodes of seizures and was brought to the hospital for further evaluation. What are the differential diagnoses in this patient? Yes, of course, it is meningoencephalitis. How do we evaluate? History, examination, CT and MRI, then going on to do the CSF analysis. The empirical treatment the patient received was ceftriaxone, along with vancomycin for bacterial meningitis cover, and HSV treatment with acyclovir 10 mg per kg 3 times a day. His report showed CSF showed 230 cells, 90% were lymphocytes. The glucose was again normal in this patient too, and proteins were also normal. The MRI findings showed hyperintensities in both gray and white matter. The CSF PCR was negative and all cultures were also negative. So what is the diagnosis in this case? In this patient, we treated him as acute demyelinating encephalomyelitis. A high dose of methylprednisolone was given, and the patient's sensorium improved over the next 10 days, and he completely recovered from the neurological deficits. To summarize, acute meningoencephalitis is inflammation of the brain parenchyma with severe neurological dysfunction. Patients classically present with fever, headache, seizures, and neurological dysfunction. The causes can be infectious, ADEM, autoimmune are the 3 most important causes for acute meningoencephalitis. We need to take a good history for clues for possible etiology, clinical examination, imaging in the form of CT going on to MRI, CSF analysis, and specific blood tests for confirmation of diagnosis. Empirical treatment should be started without delay. Along with antibiotics, acyclovir should be started in all cases until reports are available. Keep in mind the possibility of acute demyelinating encephalomyelitis or of autoimmune etiology, especially when the patients are not improving with the antibiotic and antiviral cover and when all other tests are negative. World Encephalitis Day is celebrated every year, and the celebration was started from 22nd February 2020. Because many people, especially in the Western world, believe in anti-vaccination. So the World Encephalitis Day is celebrated to debunk this anti-vaccination myths. The anti-vaccination is against mumps, measles, varicella, which are common causes for severe acute meningoencephalitis. If patients develop acute meningoencephalitis, they can be left with severe neurological sequelae. So it is important to vaccinate, especially children, from these viruses. Thank you.
Thank you, Dr. Bhuvan Krishna, for this very simple and lecture and I hope all the delegates must have understood the concept. We have a couple of questions. So one question is from Dr. Bhavana Singh. It's about what is the current evidence and indications for intrathecal antibiotics and what are the doses?
Hi, very good morning. So currently there is no evidence for, especially for acute meningoencephalitis, there's no evidence for intrathecal antibiotics. So if you see most of the time, if it is an infective etiology, you just our acyclovir or your antibacterial IV doses should suffice.
So many times we get the organisms which are not sensitive to the first and second line. The bugs are not sensitive to the first and second line antibiotics, and the third and fourth line that were available, they have very poor penetration in CSF.
So in those cases, I was purely talking about the community acquired infections. So probably intrathecal then would be indicated, especially if it's an iatrogenic and with patients who've undergone any kind of a surgery or interventions, then intrathecal or even intraventricular, if the patient has got an EVD or EVD drain, then intrathecal or intraventricular would be indicated. Otherwise, in a community acquired infection, there are no indications. For multi-drug resistant, then probably colistin, intrathecal or intraventricular. That's the only time I would say we would need.
So like at least in our hospital, we get a lot of patients even from community. They're coming with resistant bugs. Of course, not for the meningitis and encephalitis, but for the other infections. Now we have one more question. Question is again by Dr. Bhavana. Question: what is the pre-antibiotic dexamethasone dosage and indication?
Sorry, I didn't get that.
What is the dose and indication of pre-antibiotic dexamethasone?
Yeah, so if you have read the evidence is mainly that was seen in children that you start dexamethasone before the first dose of antibiotic is given. They found that, the neurological sequelae was less. But that has been translated even to the use in treating adult patients. So yes, if you're suspecting a bacterial, give off. If you have not given the dexamethasone before the antibiotics, it doesn't matter. We can still start to give it. But the issue is if we're suspecting if it is viral meningoencephalitis, then there is some drawbacks in starting steroids. But no harm that's why the CSF analysis is very important, so that we can get a quick diagnosis whether it's viral or bacterial. So we can take a call on stopping the steroids along with the antibiotics.
So empirically, would you recommend to start both
Yes.
and antibiotics?
Yes, probably. Yes. Maybe that's not put in the slide. Yeah, that is a usual practice. Start the steroids before the antibiotics or along with the antibiotics and the acyclovir, and then we can stop it.
We have one question from Dr. Rajesh Panda. What is the role of CSF procalcitonin in meningoencephalitis? Can we use it to differentiate the several infectious etiologies, bacterial from viral and fungal?
I'm sorry, I've never used CSF procalcitonin and have not come across that literature, so I don't think I would take that question.
Now, Dr. Pinky wanted to see that EEG graph which was showing the changes. She wanted to see that slide again. The EEG graph.
Should I show it or?
Possible for you? Share it?
Okay, let me just see.
Okay.
She will need to be made host again. She has to share her screen. Rohit.
So we'll take until that time. We'll take the next question. So this question is from Dr. Balaji. The question is on repeat CSF examination in case of herpes simplex. After completion of treatment course, what are the parameters that we're looking for in repeat CSF? Because the cell count might be normal after antiviral therapy and culture will take time.
So we will have to look at the CSF PCR again because we are looking at the antigen here. So it is advisable to get a negative report of CSF HSV PCR to tell that yes, because the chance of relapse is very high. So it's advisable to get a repeat CSF with cells normal along with PCR negative to take a decision on stopping the acyclovir.
Yeah, the question is about in the PCR video. It will be difficult to differentiate between a viral body which is non-viable and a viable virus.
Yeah, there is a chance that it's going to be detected on even but still we'll have to take it with a pinch of salt and take a call whether you want to continue it or not.
So, like in COVID, currently we use the CT
yes,
value as a cutoff.
Yes, exactly.
Yeah, there's one question by Dr. Vikas. Any updates on managing post-surgical meningitis with MDR organisms?
Sorry, I didn't get that question.
Any updates about management of post-surgical meningitis in patient with multi-drug resistant organisms?
Any update?
Yeah.
No, I haven't read any recent update on post-surgical.
So there are a couple of more. So in post-surgical meningitis, so many often when we call it the chemical meningitis because of the surgery.
Okay. Oh, for that treatment, no, I haven't read because I think the main the talk that I had focused on was a community-based, more of viral and autoimmune and acute demyelination, which we commonly see.
So one question by Dr. Rashmi. Madam, do you always need to add ampicillin to ceftriaxone and vancomycin for empirical therapy of elderly in case of meningoencephalitis for listeria?
If it is elderly and we don't usually do it because we have hardly seen any listeria meningitis. It's more often the ceftriaxone, vanco, and acyclovir that is commonly started.
This is empirical.
Yeah, empirical also we don't start with ampicillin because the incidence as such is very, very low.
And what is the duration of steroids in autoimmune encephalitis and edema?
So autoimmune encephalitis, it is a prolonged period. The neurology team usually advises to continue it for about 4 to 6 weeks. It is slow tapering because relapse is very high, especially with autoimmune. ADEM, it is usually short when the patient recovers completely from the neurological sequelae. The steroids can be start tapered. So it's about 2 weeks. The pulse dose is about 5 days. And then you can start change to 1 mg per kg of prednisolone. And after 2 weeks, the tapering of it.
I think one question will take about the frequency of encephalitis in COVID. and how the management is different from the routine community acquired encephalitis.
So if it is if it is due to the COVID virus itself, the treatment is going to be just supportive care, and some steroids have been advised. But most of the time that we have seen a couple of cases are post-COVID patients developing demyelination. We have seen a case of limbic encephalitis post-COVID. The patient received pulse dose steroids. There was no improvement. Went on to receive intravenous immunoglobulin. So that would be the treatment. So it is still supportive care along with steroids, no improvement, immunoglobulin therapy.
And are you getting post-COVID hemorrhagic encephalitis?
Hemorrhagic encephalitis.
Yes, hemorrhagic.
Sorry, I am not aware of hemorrhagic encephalitis. Yes, there are cases of hemorrhages in the brain due to the anticoagulation, but it is not an encephalitis. There is no inflammation of the brain due to the hemorrhage.
So the management will be like a IC bleed rather than an infection.
We have seen patients with punctate intracranial, intracerebral hemorrhages that's commonly noticed with no major neurological sequelae. Some patients develop large bleeds because of the anticoagulation.
So vaccine is one of the risk factors for this meningoencephalitis.
Yes, post-vaccination, yes.
So are there any post-COVID vaccine reports of meningoencephalitis?
Yes, there have been reports that have been mentioned here and there, but probably the numbers are too insignificant. Just like any other vaccine, COVID vaccine is also a risk factor for either GB syndrome or acute demyelinating encephalomyelitis. There are cases. But the
last question, I think.
Yes, sir. So what is the role of IVIG in encephalitis? I think this last question.
Yes, if it is an autoimmune or ADEM, then especially if you have the antibodies that are positive, so then it is good to consider if there's no improvement with methylprednisolone pulse dose, the next step is to consider intravenous immunoglobulin.
Yeah. So thank you, madam. Thank you for this excellent talk of.
You want to share the slide for the EEG?
Yes, if it is possible.
Yeah, I'll just do that. My slides are visible?
Yeah, yeah, we can see the slides.
The EEG one. Yeah, this is the one. I'm not sure which EEG. Is this the EEG? What was the question on EEG?
I'll go to the question again.
I think we just wanted to see what ECG changes are to be looked for.
Temporal lobe, you can see these plaques. These are periodic. So these are periodic epileptiform discharge. And it involves only the single lobe. If you take the reciprocal opposite side lobe, we are not seeing the discharges. So these are called plaques, which is characteristic of HSV, and HSV diagnosis can be made based on this EEG. The other is a slow wave, a generalized slowing or delta waves, which is suggestive of severe encephalopathy, which is a poor prognostic factor. And this is a status epilepticus, which is in generalized epileptiform discharges over the entire cerebrum. This is called as the brush pattern, brush delta pattern, which is seen in anti-NMDA receptor antibody encephalitis. That is the autoimmune encephalitis. These are rare instances. Most of the time, it's seizures that we can pick up, non-convulsive or status epilepticus in acute meningoencephalitis.
I think we'll stop here. Amol?
Yes, sir. So thank you, madam. Thank you for this wonderful talk. So the next talk is about Guillain-Barré syndrome, and for this next talk, I would like to invite Professor Dilip Karnad, who is Chief Intensivist and Senior ICU Consultant at Jupiter Hospital, Thane. So over to you, sir.
Yeah, thank you, Amol. I'm going to start sharing my screen. What I'm also going to do is I'm going to turn off my video in just in case, there are network issues. So,
Okay.
okay. So, let's start with the case, a 25-year-old male with paraparesis. So this is the case history. 25-year-old male was brought to the ICU with complaints of acute weakness in both lower limbs, which started a few hours earlier. There was history of diarrhea 1 week earlier, which subsided with treatment. On clinical examination, there was actually weakness in all 4 limbs. So although it looked like it was a case of paraparesis to start with, basically it was lower limb affection more than the upper limb. There was decrease in muscle tone, and the deep tendon reflexes were absent. Other neurological examination, including higher mental function, speech, cranial nerve examination, was normal. The spine was not tender to deep palpate. So the immediate questions are, what is the likely diagnosis in this patient, and what are the differential diagnoses? So coming to what are the differential diagnoses, basically we need to differentiate between these various causes. The first is junctions of the neuromuscular the disorders of the neuromuscular junction. These include myasthenia, botulism, and organophosphorus poisoning. So typically there is a pattern of involvement in these disorders. The ocular and pharyngeal muscles are more affected, and then that is followed by the respiratory muscles. And invariably, the reflexes are present and can be elicited in these patients. The next is anterior horn cell disorders. So poliomyelitis, West Nile virus infection. These are characterized by transient fasciculations in the muscles which are weak. Spinal cord disease, so acute transverse myelitis and maybe conditions like atlantoaxial dislocation, which would cause quadriparesis without any cranial nerve involvement. There is initial phase of spinal shock when the deep tendon reflexes are absent, but later on, since this is an upper motor neuron kind of a lesion, the reflexes will be brisk, the plantars will be extensors. Usually there is a sensory level and bladder will be inward. The other conditions which we need to think of are hypokalemic paralysis, which is very common. So in fact, if there are 5 patients who come to the casualty of any large hospital with a diagnosis of query GBS, at least one of them will turn out to be hypokalemic paralysis. So it's very common. We need to look for this. And again, here the deep tendon reflexes are elicitable and they are rarely absent. We have to also think, besides GBS, of other motor neuropathies like porphyria, diphtheria, or lead or thallium poisoning. And the last, of course, is critical illness polyneuropathy, which typically occurs in patients who have already been in the ICU. So this is a challenge which we have often faced when treating patients with COVID pneumonia. We intubate patients, put them on a ventilator, the COVID is treated, the RT-PCR becomes negative, and when it comes to weaning this patient after a couple of weeks, there is quadriparesis, and the question is this post-COVID GBS or is this critical illness neuropathy? So notably, most of these are going to be axonopathies in contrast to GBS, which in majority of cases is a demyelinating disorder. So before we go to discussing GBS itself, let's look at the time course. So there is an initial infection, which is often The history is elicitable in almost 50% of patients with GBS. This infection sets off an autoimmune process where you may get autoantibodies to certain gangliocytes. And then after a latent period of maybe anything from a week to 4 weeks, there is onset of symptomatic weakness. So the weakness progresses over the first 4 weeks. So this is something which is important. So when a patient comes, it's difficult to prognosticate as to whether it's going to progress or not, but it can progress over 4 weeks. Then there is a plateau phase which can last for several weeks to months. And then there is a recovery phase which can be very prolonged. It can even extend for a couple of years. And then any deficit which remains after a couple of years is going to result in a disability. So there's an excellent review of GBS published in the Lancet in 2016. And a lot of the information which I'm going to share in the next slides are going to be from this review. So to make a diagnosis of GBS in clinical practice, we need certain features. Okay, so one is progressive weakness in legs and arms, and sometimes initially it starts only in the legs, as in our patient. And the second is areflexia or decreased tendon reflexes in the weak limbs. So these are criteria which have to be there in a majority of patients before we can suspect or we can diagnose GBS. What are the additional symptoms which could be present? So the progressive phase, which is often 2 weeks, but can last for up to 4 weeks. It's very, very rare for the disease to progress beyond 4 weeks. So if it progresses beyond 4 weeks, then we need to bring in a diagnosis of whether this is a chronic inflammatory demyelinative polyneuropathy or CIDP, as against AIDP, which is synonymous as the GBS. The other is relative symmetry. So if there is asymmetry, we need to think of another diagnosis. And most of the times, another diagnosis would be disorders of the anterior horn cell. So in the past, poliomyelitis was a classic example of asymmetrical weakness. Sensory symptoms and signs are typically not present. They could, if they are present, they are very mild. Cranial nerve involvement is common. So almost 50% of patients will have bilateral facial weakness. So this is really important. Bilateral facial muscle weakness with difficulty in closing the eyes would be a very positive diagnostic feature in favor of GBS. Autonomic dysfunction is common in large number of patients, which may present as episodes of sweating. There could be urinary retention in the first week. But after the first week, it's very rare to have bladder involvement. They can have episodes of tachycardia, hypertension, and initially they can have pain in the affected, in the distribution of the affected nerves. So calf tenderness, calf pain is a common feature in patients of GBS in the lower limbs. There are some features which should raise a doubt about the diagnosis. So the first is if you get more than 50 cells on CSF examination in the patient, it would suggest more of some kind of inflammatory disease of the spinal cord or the anterior horn cells. Severe pulmonary dysfunction with little or no limb weakness at the onset. So that's again an unusual feature. Severe sensory signs also are unusual. Bladder bowel dysfunction at the onset is unusual. It happens after a few days. Fever, a sharp spinal cord sensory level, okay, asymmetric weakness which is persistent bladder and bowel dysfunction beyond 1 week. So all of these are signs which should raise a doubt about the diagnosis. And of course, as I said, the slow progress of the weakness over a period of more than 4 weeks should be more of CIDP, which had an acute onset. This is important because the treatment differs. So how will you confirm the diagnosis? So various tests. Some of these are to rule out other diagnoses which are similar to GBS in terms of presentation. So an ECG and serum electrolytes for hypokalemia, urine test for porphyria, CSF examination basically to rule out other infectious processes. So if you get increased cells, then that would rule out. The classic feature of GBS on CSF is cytoalbuminologic dissociation, less than 50 cells with raised proteins. But this is rare in the first week of the disease. So if you do it after the first week or normally after 10 days, then you get this in a significant number of patients. But then the whole idea is, we want to diagnose early, at which stage a normal CSF does not rule out diagnosis of GBS. So you can get some increase in cells, but not more than 50 cells. MRI of the brain and spine is often done. This is done to rule out post-infectious demyelinative syndrome. So in GBS, we expect a normal MRI. Antibody tests can be done, but these are not available everywhere, and negative antibodies does not rule out GBS. In most of the patients, the confirmatory test is the EMG nerve conduction studies test. So while GBS is a demyelinative disorder, there is also an axonal variant of GBS. So these are two varieties. One is called acute motor axonal neuropathy, or AMN. The other is acute sensory motor axonal neuropathy. Campylobacter jejuni infection of the GI tract is often a preceding event in more than 25% of these patients. And for some reason, this axonal variety is more common in Asians, maybe some kind of genetic variation. So it's apparently a very common form of GBS in China compared to rest of the world. The difference between this and the demyelinative variety, the limb weakness is much more severe, the course is more prolonged, and there is a poor prognosis because it does not respond as well to the standard treatment of plasma exchange or IV immunoglobulin. The antibodies against GM1 and GD1A gangliosides are a hallmark of this disease. In terms of treatment, the treatment is the same regardless of which of these two varieties. That means the axonal variety or the demyelinative variety of GBS. So what are the typical EMG nerve conduction findings? So if it is a demyelinative polyneuropathy, there is a decrease in the motor nerve conduction velocity. So how do you do that? So you stimulate the nerve. Let's say you are stimulating the median nerve at the elbow and then at the wrist. Okay. So there is an interval between the stimulus and the onset of the compound motor action potential. So this time difference when you stimulate from the two places, okay, is the latency. So this is called L. This is L1. This is L2. So the difference between the two tells us the time it takes for the impulse to travel from this point to this point. You can physically measure the distance, and then when you divide the distance by the time, it gives you the velocity of nerve conduction. So what do we get in demyelinative nerve disorders? First is there is decreased motor nerve conduction velocity, right? Second is there is prolonged distal motor latency. That means the time taken when you stimulate here to the onset of this compound motor action potential is significantly prolonged. Now, there is also something called increased F latency. So what is F latency? When you stimulate here, it's not as if the impulse only travels downwards to the muscle, right? You're stimulating the nerve in the middle. So the impulse will also travel upwards up to the anterior horn cell. And then from that place, it gets reflected back. Okay, so which is shown over here. So if you stimulate here, you will get one contraction because of this muscle contracting as it reaches, the impulse reaches here. Then you get a second contraction, which is the F wave, which is because of the impulse being reflected back from the anterior horn cell. So if you have a proximal lesion here, okay, then the F wave is delayed. So an increased F latency tells us that there is also a proximal block in many patients. You can get multifocal conduction blocks, and you get classically what is described as absence of the H reflex. So H reflex is the EMG equivalent of a deep tendon reflex. So when you stimulate the nerve here, the sensory nerves are also stimulated. So the fibers which carry impulse from the muscle spindle will also get stimulated. So that will go up, and then it will evoke what is like a deep tendon reflex. So there will be another contraction beyond this, which is called the H reflex. So that will be absent. So this just means that the deep tendon reflex will be absent when you clinically examine. So what happens in acute motor axonal neuropathy? So one is the compound motor action potential is reduced in amplitude. So when it is reduced, it means the number of fibers, intact fibers, which are conducting are less. There are no features of demyelination. Okay, that means these other features will not be there, the F latency and multiple conduction blocks. There is only a small decrease in the motor nerve conduction velocity. What it means is that there are some nerves which are damaged significantly, which will not conduct at all. In the remaining nerves, because the myelin sheath is intact, if they conduct, they will conduct with a normal velocity. So the nerve conduction velocity is not reduced by a large extent, but the number of nerve fibers conducting will be less, giving rise to a reduced compound muscle action potential. These abnormalities are most pronounced after 2 weeks from the start of illness. So in the first few days, you may not get any abnormalities, which again, it does not mean that it's not a neuropathy. So this is one of the most commonly used GBS disability scale. Okay, and an important point is the distance between grade 2 and grade 3. So grade 3 is able to walk 10 meters without help. Okay, and the grade 2 is able to walk, and this is unable to walk without help. So these are important differences from a treatment point of view. So what are the indications for ICU admission? So there are various ways. Now, why is this important? Because when a patient comes to the hospital, 2 points are important. One is that patients respond better if we treat them early. At the same time, we don't treat them if they are extremely mild. Only those who on this scale are not able to walk 10 meters on their own, they are the ones who need treatment, right? So a patient may not reach that stage at the time of admission, and he may reach that stage in the 3rd week, but the best results are if you treat them before 2 weeks. So it's kind of a paradoxical situation. So it's very important to identify who are the patients who are going to progress. So rapidly progressive weakness is an important sign. How do we assess respiratory compromise? So the commonly used one is this 20-30-40 rule. FVC of less than 20 ml per kg, maximum inspiratory pressure less than 30, and maximum expiratory pressure less than 40. So these all suggest weakness of the muscles. Impaired swallowing is an important reason for ICU admission because there's a high chance of aspiration. Severe autonomic dysfunction. And then there is this EGRIS score, which is often used in research studies, rarely used in clinical practice. Okay, so an EGRIS score, as the score increases, the risk of severe disease or mortality is worse. Okay, so what is the standard treatment of GBS? Patients with more than grade 2 need treatment. Okay, that means unable to walk more than 10 meters without support. So those with grade 0 or 1 don't actually need treatment, right? Or 2. The standard treatment is plasma exchange, and it is beneficial if this is done within the first 4 weeks from onset. The largest effect is seen when this is started within the first 2 weeks. So this is a major challenge, right? So somebody may be having a grade of 1 for the first 2 weeks and progresses to grade 2 and then grade 3 by the 3rd week. So maybe, this patient might have benefited from earlier treatment if we could have identified this patient is going to worsen. The standard treatment is 5 sessions of plasma exchange over 2 weeks, and total exchange of 5 plasma volumes, that is each being 40 ml per kg per session. Okay, so there is one major RCT which compared IV immunoglobulin versus plasma exchange, and they found that the results are similar. So there is no difference in the results of either IgG or plasma exchange, right? So this is also shown by Cochrane review. Is it okay to combine plasma exchange followed by IV IgG? So whatever evidence is there says that it is not better than any one alone. So we don't give the two together, right? We give just any one. What is the role of steroids? Steroids are not beneficial. If you look at old trials from the 70s and 80s, okay, they showed that there are some patients who do improve with steroids, but the percent was so small that they did not reach clinical significance or statistical significance. So then there is a hypothesis that maybe these were patients actually with CIDP who had an acute onset, and steroids are the drug of choice for CIDP. So maybe there are some patients with CIDP who in the first few days look like GBS, but actually it's a chronic demyelinative polyneuropathy. Okay, then there's some small studies which have given IV IgG plus methylprednisolone, so there's no benefit of adding methylprednisolone. Okay, and there's one pilot study which also added mycophenolate, which showed no real benefit. So let's get back to a patient. After 2 weeks, patient was not generating enough tidal volume, so electively intubated tracheostomy was done, initiated on ventilation. Gradually, after 4 months, the patient improved, was weaned off ventilator, cough and swallowing improved to 3 weeks later, and tracheostomy was decannulated. Patient gradually improved over the next few months, but still has bilateral foot drop and some proximal weakness. So this is a very typical course of patients. A lot of them, almost 85%, will reach the same functional status that they had before they became ill. That means they can join back to their original job. Okay, there are about 10% who may not be able to do their normal day-to-day activity, and the mortality is around 5%. Okay, so this is a very common question. What if a patient who has improved initially worsens after some time? So this is called treatment-related fluctuation. This is defining as worsening of at least 1 grade on the GBS disability score if it occurs within the first 8 weeks of treatment. So you treated once, patient improved, and within 8 weeks, the patient worsened again, right? Okay, so this is also called TRF. So TRF is supposed to occur in 8 to 16% of patients treated with either IV IgG or plasma exchange. It's not possible to predict which patient is going to be one of these 8 to 16%. There was an RCT in children where they gave 2 days of IV IgG versus 5 days of IV IgG. The total dose given was the same, but in one group it was given over 2 days versus 5 days. So here more of these treatment related fluctuation was seen in the 2-day group as compared to the 5 days. So the TRF should be treated with a repeat course of the original treatment. Okay, so if your patient has received IV IgG the first time, you give it again if there is worsening within the first 8 weeks. Why this 8-week cutoff? If the patient deteriorates after 8 weeks, okay, then or if there is a second treatment is given, patient improves, and then after a couple of weeks patient worsens again for a third time, then this is more likely to be CIDP, in which case then plasma exchange is not going to work. The treatment is either IV IgG and or steroids. So some controversies or dilemmas about management of GBS. So there is this excellent article in the Journal of Neurology, Neurosurgery and Psychiatry, and it's deals with all the practical questions which we face. Start of treatment, that's the time window. Treatment should be initiated as soon as possible to prevent further damage. Okay, so it should be started, IVIGG started after 2 weeks, or plasma exchange after 4 weeks is less likely to give a good response, right? What do we do with mild forms? Considering that mild patients could progress later on, okay, do we need to treat them? So if they have additional features like autonomic dysfunction, bulbar weakness, or facial weakness, then these are the patients we should treat, even though the motor weakness is mild. There may be variants like typically Miller-Fisher syndrome. Okay, so not all of these should be treated with IVIGG. In children, IVIGG is preferred over plasma exchange. Okay, what about repeat treatment or change of treatment? So there's not enough evidence to suggest that switching from IVIGG to plasma exchange, okay, is effective if the patient does not respond to the initial treatment. Okay, so the patient has received plasma exchange first, and after 4 to 6 weeks there is no response. So is there point in giving IVIGG? There's not enough evidence. Other way around, patient has received IVIGG. Should this be followed up with plasma exchange? Logically, this should be avoided because all the immunoglobulins which you have given, which are still in the circulation, will be removed by the plasma exchange, right? So the role of a second course of IVIGG is being investigated. And we've already discussed about TRS, right? So this in short is about GBS and its management. And rather than talk about the standard treatment, I have just briefly covered the standard treatment and gone a little more practical, to discuss the challenges in the management of GBS. Thank you.
Thank you, sir, for this wonderful talk about Guillain-Barré syndrome. We'll wait for the questions from the delegates. Can you circulate the questions here, Rohit? I think the students
we are waiting for the questions, sir.
Yeah.
Okay, so I think questions are a little slow in coming. Everybody knows everything about GBS. So just one or two points while we are waiting for questions. The first is that, if you are seeing maybe 15 or 20 patients of GBS in a year, at least one of them is going to be a case of porphyria. So it's very important to keep, to do the test for porphyria. Even if you think a patient is classical GBS. So, what happens typically is that we treat them as GBS, and then maybe, there are certain things which are common in GBS also. For example, hyponatremia can occur in patients of GBS, right? But it's more common in patients with acute intermittent porphyria. And we had a young patient who came with classical GBS. In the second week, had autonomic dysfunction with tachycardia, hypertension, a little drop in sodium, and end of the second week, this patient had a seizure. Okay, so seizures are not a hallmark of GBS. So then, when you look at the classical presentation of acute intermittent porphyria, it's like neuropathy, abdominal pain, autonomic dysfunction, and seizure. Yeah, so if you diagnose this early, a lot of drugs which we give for patients in the ICU, like sedatives, antihypertensives, can actually worsen porphyria. So it's very important to diagnose early, and the moment you stop using these drugs, patients rapidly recover. It's the
Okay.
same for hypokalemia. A lot of patients actually come with hypokalemic paralysis, and it's only after 24 hours, you realize that this patient has hypokalemia. The potassium may be like 2.9 to start with, and you say that, okay, this may be because of some other reason. Next day it drops to 2, and then you say, oh, then, this can't be incidental finding.
We have a question from Dr. Pratik. How to,
Yeah.
the question is when to do plasma exchange after IVI?
So, as I said, there is no evidence that plasma exchange helps after IVIGG. In fact, if you do it too early, it will remove the IVIGG which you have given. So, what is recommended is if your patient worsens after initial improvement with IVIGG, you repeat a course of IVIGG. So, you don't switch over to the other treatment. You repeat the same treatment if your patient has received IVIGG. On the other hand, if the first treatment was plasma exchange, then you can follow it up with either plasma exchange or IVIG.
So we repeat that whole 2 gram per kg dose after 7 days.
Yes.
And yeah, and you said about the timeline for 2 weeks for IVIG, no role after 2 weeks, and 4 weeks for plasmapheresis.
Yeah. So this is what is the recommendation, but then most of the times, even if a patient comes after that, we end up giving IVIGG more for the convenience. So if you see the original study, where the RCT or IVIGG versus plasma exchange. So even if you gave it later, it helped, but the maximum benefit was if you gave it within the first 2 weeks. So it's not that you don't give it, do it, but then the earlier the better.
The second question is Dr. Deepika. The question, please repeat ENMG. I think she wants to see the ENMG slide.
The EMG now conduction slide.
I think so. ENMG.
Okay. So let me see if I can share the screen. Okay. So basically you stimulate the nerve, the median nerve at the elbow, and you see after what latency or how much is the interval between the stimulus and the muscle contraction. Then you stimulate it again just above the wrist, and you see after what is the interval between the stimulus and the muscle contraction. Okay, so the difference between this and this will give you the time it takes for the impulse to reach from the elbow to the wrist. And you can measure with a tape in centimeters the distance from the first stimulus point to the second stimulus point. So when you divide the distance by the difference in the time, it gives you the nerve conduction velocity as so many centimeters per second, right? And this is about the other features that are happening. So whenever the number of nerves which are functioning are less, okay, so if you get muscle weakness, it means that if the 80% of the nerves are not functioning, then there's going to be significant muscle weakness. So as the number of intact nerves conducting becomes less, the amplitude of the motor action potential is going to become less, right? So the latency is the time between this stimulus and the muscle contracting. So when myelinated nerves, the presence of myelin makes them conduct fast. So if there's demyelination, then the time taken to conduct from the wrist to the muscle is going to be prolonged. So this is called prolonged distal motor latency. The other is increased F wave. So F wave is when you stimulate a nerve here in the middle. It's not that impulse will only go down, it will also go up. And once it reaches the anterior horn cell, it gets reflected downwards. Okay. And when it comes, it will the muscle will contract a second time, which is shown here, right? So this is the F wave. So an F wave is absent if there is a proximal lesion. So if there is a radiculopathy, okay, this conduction may be normal, but the F wave will be lost. So in patients with classical GBS, you get both. You get impairment in forward conduction as well as loss of the F wave, right? Coming to axonal neuropathy, if 80% of the axons are damaged, okay, 20% of axons in the nerve are intact. But because the myelin is intact, the conduction velocity of this nerve is going to remain normal, although the compound motor action potential amplitude is going to be reduced. So this is the difference between demyelinative and motor axonal neuropathies. I hope that answers the question.
I hope that answers the question. And even about the what happens to F wave when the lesion is proximal.
Yeah, so if the lesion is proximal, the F wave will be absent.
So one more question about plasma exchange versus immunoglobulin. What do you use more?
Well, we use immunoglobulins more because it's more convenient, less risk of infection related to the line staying in for so many days. You don't need necessarily, an access and plasma, transfusions and so on. Theoretically, there is a possibility of trolley because of the blood products which you use and so on. So all those would be minimized with IV immunoglobulin therapy. The only adverse effects we see with IV immunoglobulin therapy are that they will contain some kind of sugar, to stabilize the product. And this sugar which is there, which may be maltose or whatever, can cause tubular dysfunction. So a lot of patients after the third dose or fourth dose start getting polyuria. So if you don't carefully monitor the urine output, they can get hypovolemic, they can have a little bit of hypotension. You think it's autonomic dysfunction, but actually it's because of the IV immunoglobulin. So we need to carefully monitor the urine output in all these patients.
Like osmotic diarrhea, like mannitol?
To some extent, it is osmotic diuretic, but also to some extent, it causes tubular dysfunction. So it's not like you stop it and the polyuria goes away. It can last for 5-6 days more, even after the last dose, if you monitor them carefully.
Okay. So we have one more question from Dr. Rajesh Panda. The question is, sir, you mentioned the choice of treatment in CIDP is steroid. How do you know or differentiate AIDP from acute onset CIDP? As steroids, we don't give in AIDP.
Correct. So very good question. So clinical examination, there is one feature which is supposed to be a hallmark of CIDP. Okay. So one is that if your patient has had history of GBS in the past, 5 years back, 10 years back, then the possibility is this is CIDP. The other is when you palpate the nerves. Okay. So you palpate the ulnar nerve at the elbow. Thickening of nerves is supposed to be a hallmark of CIDP. And if you do a biopsy of the nerve, then you get what is called as an onion bulb appearance. That means the myelin, which is normally only one layer of cells or myelin cell, will be multiple layers, giving rise to what is called as an onion bulb appearance. So which causes thickening of the nerves. But then when a patient comes the first time, it's very difficult to differentiate whether it is acute or chronic. So we often diagnose it only when this patient gets TRF, so patient improves, then worsens again. It's only then that we can suspect that it may be CIDP.
So we'll take a couple of questions. We have some 2-3 minutes left. So one of the delegate has asked about the treatment of Miller-Fisher variant of GBS.
Yeah, so Miller-Fisher variant responds well to IV immunoglobulin or plasma exchange. The question is whether we need to treat it or not. So it depends on the extent of the disability. So if the patient has very significant ataxia and all, then it's worth doing it. So in mild forms, again, it's not necessary to treat it. There's no definite criteria like for GBS, where it says if it is more than grade 2, only then you treat it. So.
And one more question: which type of paralysis is common in GB syndrome? Is it ascending or descending?
Uh, most of the times it is ascending, but it's not a general rule that it has to be ascending. It could also happen the other way around. So often ascending, but not necessarily descending is not GBS. That is not the case. Descending also can occur in GBS.
One question regarding the IVIG in TRF. So the question is, the recent practice change update published in April 2021 suggests against the use of repeating IVIG in TRF, as it exposes patient to adverse effects without additional benefit.
Yeah, so if your patient does not respond to one course of IV-IgG, whether you should give a second course. So the answer to this we don't know, right? So there is apparently an RCT which is going on in Europe, where patients who don't respond to the first course are being given a second course to find out. So as of now, if your patient does not respond to one course of treatment, then generally we don't give a second course unless the patient improves and worsens. So for TRF, we give a second course, but failure to respond to one treatment is not, as of now, an indication to give a second course.
So there are a couple of questions regarding this 20, 30, 40 rule and the need of intubation. Should we intubate prophylactically or should we wait?
No. So the answer is this is not a rule to intubate a patient. These are the patients who should be observed closely in an ICU. So if you are seeing a patient who is on the floors, then do this to see whether this patient needs to be shifted to the ICU or not.
And are we getting post-COVID vaccination GBS?
We've not seen any, but then yes, there are reports. So like the previous speaker said, any viral infection can result in GBS, and similarly any vaccine can also result in GBS. So it can happen after either COVID or after COVID vaccination, but whether it is more than with other vaccines, I don't think there is any data to suggest that as yet.
So I think we had covered most of the questions. So thank you, sir. Thank you for this very lucid talk about GBS.
Okay, thank you.
So after this GBS talk, now we have a next talk about community-acquired pneumonia. And for this talk, I would like to invite Dr. Asif Hegde, who is a consultant in medicine and critical care at PD Hinduja Hospital. And his area of interest are ICU infections, fluids, and electrolytes. And Hegde sir will be talking about community-acquired infection, that is pneumonia.
Community-acquired pneumonia. We begin with this case. This is a 36-year-old male with no comorbidities. We presented to the ER with fever, body ache, cough with expectoration for 5 days, and progressive breathlessness for 2 days. On examination, he was confused, dyspneic, febrile, tachypneic, tachycardic, and hypotensive. His saturation 90% and a rebreathing mass is 15 liters per minute. He had crepitations and bronchial breathing on the lower side of his chest on the right side. Rest of the examination is unremarkable, and the X-ray was suggestive of a right lobe pneumonia. There's no doubt about the diagnosis in this case. So how do you define a community-acquired pneumonia? Community-acquired pneumonia is defined as inflammation and consolidation of the lung tissue due to infectious agents. So pneumonia which develops outside the hospital is considered as a community-acquired pneumonia. Even if it develops within 48 hours after admission, it is considered to be a CAP. And severe CAP is defined as a CAP requiring supportive care within a critical care environment. What is the pathophysiology of CAP? Community-acquired pneumonia develops when the lung defenses are overwhelmed by a pathogen which is either inhaled or aspirated. So it's more likely if the pathogen is more virulent, or if your host defenses are impaired, or the inhaled load of the organism is quite high. So how do you make a clinical diagnosis of community-acquired pneumonia? A diagnosis of CAP rests on a triad of there has to be evidence of infection, like there should be fever, chills, or leukocytosis. There should be signs of symptoms localized to respiratory symptom, cough, increased sputum, shortness of breath, chest pain, or abnormal lung examination, and there should be a new or changed infill rate. So combination of these three makes you diagnose pneumonia, community acquired pneumonia, but a new or changed infill rate is not always reliable. Why? Because it may be normal. A chest X-ray normal if the patient is quite dehydrated. It might be normal in neutropenic patients, and sometimes if a retrocardiac pneumonia, the PA film may miss a retrocardiac pneumonia, so lateral chest X-ray is also preferable. Also, it must be understand that no X-ray pattern is diagnosed with any particular microbiological etiology. Just looking at the X-ray, it's almost impossible to diagnose the etiology of a pneumonia. That should be kept in mind. And nowadays, quite often, of course, rather than lateral X-ray, many of us, because in this COVID era, are doing HRCT, which is probably a little more sensitive in picking up pneumonias which might be missed on a X-ray chest. Remember that in elderly patients, confusion might be the only presenting symptom. Quite often, they don't have all the other evidence of pneumonia. So, in a elderly patient who comes with confusion, there must be a very, very low threshold for suspecting a pneumonia. So, what is the differential diagnosis of community acquired pneumonia? So, you have conditions which cause an abnormal chest radiograph and can mimic a pneumonia. For like example, congestive heart failure, especially if precipitated by a viral syndrome, aspiration pneumonia, lung infarction following an embolism, acute exacerbation of pulmonary fibrosis, acute exacerbation of bronchiectasis, acute eosinophilic pneumonia, hypersensitivity pneumonitis, pulmonary vasculitis, and rarely in our country, cocaine-induced lung injury. Sometimes you might have symptoms of cough and fever and breathlessness with a normal chest radiogram, which can be seen in acute exacerbation of COPD, influenza without a pneumonia, acute bronchitis, pertussis, and asthma. How do you grade the severity? How do you sort of triage? How do you decide who needs close attention? There's several scoring systems. The most popular of them, of course, is the Curve 65, where you look at evidence of confusion, a high urea, a high respiratory rate, or a low blood pressure, and the age more than 65 years. So if he's got more than even any one of these criteria makes him at increased risk of requiring ICU admission, and two or more makes him at high risk of mortality. So anything above two is probably dangerous, associated with definitely a need for ICU admission and certainly a higher risk of mortality. This is the most popular score, but the one recommended by the ATS and the IDSA are their criteria for CAP. They have the several minor criteria and two major criteria. So tachypnea, hypoxia, multilobar infiltrates, confusion, uremia, leukopenia, or thrombocytopenia, hypothermia, and hypotension. So any of these are the minor criteria, and major criteria are of course invasive mechanical ventilation or the need for vasopressors. So for ICU admission, the criteria means any major criteria. Of course, anybody requiring vasopressors or mechanical ventilation has to be in the ICU, or a patient with any three of the minor criteria qualifies an ICU admission. But recently we have this quick SOFA, and studies have shown that the quick SOFA probably is as, if not superior, at least definitely equivalent to the Curve 65 in respect to the prognostication of ICU admission. Therefore, the quick SOFA is a very simple score, which you all know about. Any two of tachypnea, augmentation of hypotension is enough to justify a higher probably ICU admission, and probably also means the patients are at risk of a higher mortality. How do you investigate a patient with a severe CAP? Of course, first thing is radiology. We've already talked about X-ray chest and its limitations. We talked that sometimes you might do an HRCT, but also ultrasound can be used in the diagnosis of COP. In fact, one study showed that ultrasound might be useful in the diagnosis and management. It has a good sensitivity and specificity. It is portable and fast, does not use radiation, therefore can be used in pregnant women at the bedside. It is easily reproducible, and it can also detect complications like pleural effusion with or without septations. But of course, the limitations are that there's a slow learning curve. It requires a bit of experience, and there's an interoperable operator variability. So other than radiology, other tests that you need to do, of course, are the routine lab tests, your blood counts, your renal function test, liver function test, etc. But you always would do pre-treatment blood cultures in every patient admitted with a severe CAP, and you would do a pre-treatment sputum or endotracheal aspirate examination for Gramscian culture. You might also do so-called urinary antigen tests especially for pneumococci. In our country, the urinary antigen for Legionella may not be very useful because the species which is picked up by the urinary antigen test is not very prevalent in our country, so that may not be very useful in our country. But certainly, a urinary antigen for pneumococci might be useful. Any patient who comes with a severe pneumonia, it might be worthwhile doing an HIV because sometimes you are surprised. So the urinary antigen, the advantage of urinary antigen is that it is very rapidly done. It is simple and reasonably specific. And it will pick up pneumococcal pneumonia even after antibiotic therapy has been started, in which case sputum culture and blood cultures may come negative. It shows a sensitivity of about 50 to 80% and a specificity of 90%. So a negative urinary antigen does not rule out pneumonia, but a positive antigen is very diagnostic of a pneumococcal pneumonia. And of course, in patients who are more sick, the sensitivity increases. So it might be a useful test in sicker patients, especially in ones who have received antibiotics, because it may help you de-escalate your antibiotics. Also, the fact that a respiratory culture is negative does not mean a respiratory culture has no value. If on a gram stain or on culture you don't see Staph aureus or gram-negative bacilli in good quality specimens, that is strong evidence against the presence of these pathogens. It will help you in the de-escalation of your antibiotics. So does every patient with a severe CAP need a BAL? Not really. Only the patients are in immunocompromised patients with CAP, which I will talk about later, or for patients with CAP in whom the therapy has failed. And another important thing is the role of molecular diagnostics in CAP. Of course, this is the COVID era. We know that COVID and other viral infections can cause severe, pneumonias. And now, in fact, it's been recognized that viral infections are probably a very, very common cause of severe CAP. And using diagnostics to diagnose a viral pneumonia might help you not only to stop unnecessary antibiotics and might help you use appropriate viral therapy, but so can definitely help, especially in antibiotic stewardship, and help the diagnosis. So PCRs are available now to diagnose respiratory pathogens, and the commercially available PCRs are multiplex PCR, which detect most important respiratory viruses as well as the atypical bacteria. And like I said, that nowadays, especially COVID and H1N1, up to 40% of severe pneumonias may be because of respiratory viruses. And you, of course, you can test any of the respiratory samples, either nasopharyngeal samples, sputum, airway aspirates, or BAL. The limitation, of course, that a positive PCR does not exclude bacterial colonization. A positive PCR may just reflect colonization or infection, and of course, an expensive test. So quite often, people resort to empiric therapy, especially for H1N1. Of course, for COVID, nobody does empiric therapy. You do a PCR, but maybe for the other viruses, people resort to quite often to empiric therapy. Though it is desirable to do a PCR to definitely diagnose if the patient has an H1N1 or something of that sort. So this is the BioFire respiratory panel, which covers a multiplex PCR, which covers a host of organisms, including COVID. But like I said, it's expensive. But then if you do this, at least it will tell you that this is likely to be a severe viral pneumonia, but help you stop expensive antibiotics. So this is the respiratory panel. You must not confuse this with the pneumonia panel. The pneumonia panel really is more for nosocomial pneumonia. May not be that useful in a community acquired pneumonia because it does not cover the H1N1 and the COVID. So the pneumonia panel is more for actually for a VAP, and actually the respiratory panel is more for a community acquired pneumonia. So that's what you should remember. How would you treat a severe community acquired pneumonia? The etiology of community acquired pneumonia, whether it is ambulatory, hospitalized, or a severe, is almost always is a streptococcus pneumonia. The commonest etiology, not almost always, but the commonest etiology for a pneumonia is a streptococcus pneumonia. Now, we are worried about severe pneumonias admitted to ICU. In there, the other common etiologies are viruses becoming more and more prevalent nowadays, H1N1, H3N1, or COVID. Then, of course, you have H influenza, Legionella, gram-negative bacilli, and the Staphylococcus aureus. So, when you're treating them, basically you need to cover the common likely organisms. So, what is recommended for the antibody treatment of severe CAP is a combination of a third-generation cephalosporin, either cefotaxime or ceftriaxone, along with a macrolide. If for some reason you're reluctant to use a macrolide because if you're worried about the risk of QT prolongation or cardiac side effects, you might use a respiratory fluoroquinolone. There's a bit of a controversy about a respiratory fluoroquinolone in our country because sometimes TB can masquerade as a community acquired pneumonia. So if you're going to use a respiratory fluoroquinolone, you have to do all the tests possible to rule out TB, a gene expert, sputum smear for AFB and culture also. So you make sure you're ruling out TB before using a respiratory fluoroquinolone. Otherwise, there is no reason not to use a fluoroquinolone if macrolides are not, indicated. Sometimes you can even use a drug like doxycycline or minocycline instead of a macrolide or a fluoroquinolone. And of course, if you're suspecting a viral pneumonia, you will have to use either oseltamivir or remdesivir as well. The severe pneumonia, especially the ones requiring oxygen. Now, sometimes in severe special concern, sometimes you might consider pseudomonas might be consideration, especially in patients with structural lung disease, patients who have been steroids more than 20 milligram of prednisolone, patients with COPD, patients who received antibiotics in the recent past. Their pseudomonas might be a likely organism. So here you have to use anti-pneumococcal, anti-pseudomonal metolactin like piptazole, cefepime, imipenem, or meropenem. So any of the anti-pseudomonal antibiotics along with either cipro or levofloxacin, but like I said, the same concentration, you need to rule out TB. Alternatively, you can use the beta-lactam along with an aminoglycoside and a macrolide. So what about this patient? This patient is with a severe pneumonia, cavity pneumonia following a bout of severe influenza. When you have a cavity pneumonia with hemoptysis following a bout of severe influenza, what you need to think about really is staphylococcal pneumonia. And now more and more community-acquired MRSA pneumonia is becoming common. So you really need to think about this entity, especially if somebody gets a pneumonia following following an episode of influenza. But the diagnosis is usually straightforward because the sputum usually shows gram-positive cocci. Blood cultures and sputum culture also is positive, but it's likely to be an emerging problem. And if you're considering CA-MRSA, it's probably better to add linezolid because many of these pneumonias, whether MRSA or MSSA, have a gene called a PBL gene, which causes a lot of virulence. It releases a lot of toxin. It can cause virulence. So linezolid is probably better at toxin suppression as compared to vancomycin. So if you're suspecting CA-MRSA or any MSSA or whatever, it's probably better to use linezolid because that will also suppress toxin production. This is another case where you use a diabetic farmer from Ratnagiri with a severe pneumonia. In this situation, when there are the risk factors, they're from a coastal area, there are diabetics, or other risk factors, you also think about milioidosis, which is becoming fairly common, especially from the coastal belt, from the paddy growing fields, Goa, Maharashtra, the coastal belt, Karnataka, etc. You need to think about milioidosis as well. So when do you think about the other pathogens? What are the risk factors for pseudomonas? Like I told you already, structural lung disease, bronchiectasis, COPD, steroids, previous antibiotic therapy, and enteral tube feeding. For other gram-negative bacilli like Klebsiella, etc., it is diabetes mellitus, decreased functional status, any other comorbidities or chronic aspiration. For staph, I've already talked about, CAMRS especially. For strep pneumonia, it is smoking, COPD, low socioeconomic status, alcoholism, dementia, CCF, and HIV, of course. Drug-resistant streptococcus pneumoniae is alcoholism and use of beta-lactams in the 3 months before the episode. Legionella, it is chronic steroid use, hematological malignancy, humid weather, male sex, smoking, diabetes, cancer. So thinking about depending on the risk factors, you might modify your therapy accordingly, but by and large, the standard treatment really, like I said, would be a tergium cephalosporin plus either a macrolide or a respiratory fluoroquinolone in most situations. But sometimes when you think about unusual organisms, you need to change the drug treatment. Especially bacteremic pneumococcal pneumonia, it has been shown that antibiotic combinations, have a low mortality in a single therapy. And this is the greatest differences are for critically ill patients, especially if the combination includes a macrolide. So though macrolides, even if the macrolide is resistant to the pneumococcus, the outcome has supposed to be better when a macrolide has been combined with the ceftriaxone or cefotaxime. That probably means it's more the immune modulatory effect, which is the key factor rather than the antibacterial action. As you remember, pneumococcus is a drug that causes a lot of inflammation. So anything that dampens the inflammatory response might be useful. So in one study, in fact, severely ill patients received a macrolide. The mortality is 25% compared to 46% in those getting a quinolone along with the cephalosporin. Also, you must remember that virulence is not resistance. Quite often, just because a patient has a very severe pneumonia, proven streptococcal pneumonia, people use drugs like piptazole. Now, remember, piperazine tazobactam is useful if the mechanism of resistance is the production of beta-lactamase. In resistant pneumonia, which is not very common in our country anyways, fortunately so far. So most pneumonia in our country still remains sensitive to penicillin. But if we are worried about resistant pneumonia, remember the mechanism of resistance is modified target site. In this situation, piperazine tazobactam is no better than penicillin. So actually, Piptazo is inferior to ceftriaxone for resistant pneumococcal pneumonia. Remember that. So basically, don't just use a high antibiotic purely because you're worried about resistance. If you want to use a BLI, actually cephalosporin-based BLI like cefoperazone, sulbactam, or cefepime, tazobactam might be better than a Piptazo because piperacillin is as good as using penicillin. But if you're using a cephalosporin is a higher affinity for the penicillin binding site and might be a little better in patients with a resistant pneumonia because the mechanism of resistance there is modified target site. Now the case is continued. This is patient was very breathless. He was given a trial of BiPAP, FI to almost 100%, and all this is a BiPAP setting. And the ABG seemed to be okay. So people quite often, just because the ABG is okay, continue with BiPAP. They don't look at the patient. They don't look at how the patient's breathing effort is, how the heart rate, BP, etc. They only look at the ABG. The ABG is okay. The patient they continue with the BiPAP trial, and as expected, after 2 hours, the patient had respiratory distress and was intubated, and positive pressure ventilation was commenced. So the question, of course, is that does NIV have a role in severe CAP? What is the current evidence for the use of NIV and HFNC in management of CAP? It can be given in extremely vigilant monitoring in those who do not require immediate intubation. This is especially beneficial in patients who have COPD and hypercapnic respiratory failure, but it's important to identify failure of NIV because several studies have shown that prolonged NIV before intubation, a failing NIV trial and prolonged intubation associate poor outcomes, especially as you can already, all of us now have the COVID experience, where clearly delaying intubation sometimes worsens outcomes. HFNC seems to be more effective than conventional oxygen therapy. Again, I think a lot of us now have experience from COVID and is non-inferior to NIV. So in low-risk hypoxic patients, HFNC might prevent intubation compared to conventional oxygen. Again, COVID has further pressed this point. So the Florari study, as you know, which compared HFNC with NIV with standard oxygen, clearly, though there was no difference in the need for intubation in all groups, there was significant difference in favor of HFNC in terms of 90-day mortality. So this seemed to suggest that HFNC is better than either NIV or just standard oxygen therapy. But a recent meta-analysis showed that HFNC is well tolerated, but there is no difference in intubation or mortality compared to usual care. But though the precise role of HFNC is controversial, all of us have now gained more experience with HFNC, especially in the COVID setting, and clearly patients are much more comfortable with HFNC. So all of us will probably give a trial of HFNC in patients with hypoxemic respiratory failure. If they're hypercapnic, obviously you would use NIV. So basically, the thing is that you can use a cautious trial of either HFNC or NIV in patients with respiratory distress, but they need to be watched very, very closely. That is a really key. And if you find that they're not improving over time, don't persist with a failing trial of HFNC or NIV. Intubate them in time. Cut your losses. Intubate. You don't like NIV and HFNC so much that you don't recognize it is failing and don't intubate in time. So that really is the key. You could try NIV or HFNC, but prompt recognition is very, very important of a failing trial. So if you're going to ventilate these patients, obviously you're going to use lung protective ventilation, you're going to do tidal volumes, but because this is a pneumonia, which is unlikely to be very, symmetrical, high trial levels of peat may do harm than good. And unlikely, again, the recruitment maneuvers may be useful in these patients. So basically, you might try positioning, but unlikely high levels of PEEP and recruitment will be useful. But you could try using, keeping the good lung down, etc., to improve hypoxemia, and you use low tidal volumes in this patient. These are the strategies that you would use in ventilation. What are the other options of patients with severe community acquired pneumonia? Obviously, antibiotics. You would obviously treat them if they're in septic shock, like the standard principles of management of septic shock, nothing different. Of course, doctrine alpha has now been given up. Ventilation, I've talked about, a bit about corticosteroids. Before that, I'll come to what about pleural effusions in severe community acquired pneumonia? Now, any patient with a severe community acquired pneumonia with a pleural effusion, which is more than 15 centimeters in height on a lateral chest radiograph, you undergo thoracocentesis, and you need to analyze it for gram stain culture, etc. Also, you need to decide whether the patient requires intercostal drain or not. So, on the basis of pleural fluid analysis, you need to know whether it's an empyema requiring ICD. So, if the pH is less than 7.2, glucose is low, LDH is high, high protein count, or a very high WBC count, CRP high, all these things will make you think this patient is likely to have an empyema. It means that this patient is likely to need a intercostal drain. So it's important that you don't ignore a pleural fluid, especially if the patient is not getting quickly better or if the pleural fluid is significant inside. What about steroids for a severe CAP? It was a little controversial, but now the issue seems to be resolved. Like I told you, pneumonia is a condition that causes a lot of inflammation. So clearly, steroids will help in this situation, and Now, recommendations are to use corticosteroids for 5 to 7 days only at a dose of less than 400 milligram of hydrocortisone equivalent. Of course, for COVID, we know about dexamethasone and the recovery trial. How much time does it take for the patient to develop clinical stability in CAP? Now, because how do you say when you decide the patient is not recovering, responding to your treatment? Most studies seem to suggest that clinical stability, as defined by a decline in the heart rate, stabilization of the blood pressure, decline in the respiratory rate, and improvement in oxygenation saturation, would take up to 3 days. So, before deciding the patient is not responding to your therapy, you should probably need to wait for up to 3 days. Of course, if the patient is deteriorating quickly, you might have to intervene even quickly, but otherwise, you must understand that it might take up to 3 days for the patient to respond to therapy. And what is the optimal duration of antibiotic therapy? Though there are not too many studies in, community-acquired pneumonia, but of course, this landmark study for VAP clearly showed that 8 days of therapy was as good as 15 days. In fact, when you prolong therapy, the risk of reinfection with resistant organisms was higher. So, for all practical purposes, probably most people would give antibiotics for up to 7, at the most 10 days, but mostly up to 7 days of antibiotic therapy is reasonable for pneumonia. Of course, the clue is that the quicker the patient gets better, probably the shorter the duration of antibiotic therapy that is needed. So if they get better very quickly, even 5 to 7 days is enough, but maybe with a little time, you can go up to 10 days. So if the patient is not responding, 3 or 4 days have passed, the patient continues to have fever and blood pressure is remaining unstable. What are the things? What do you think about? What are the causes of a non-responding pneumonia? Well, the causes, of course, first is that the organism is probably correct, but the antibiotic that is chosen is inappropriate, or the dosing is not proper, or of course the organism is resistant to your selected antibiotic. Sometimes the dosing may be improper because the patient is morbidly obese or has fluid overload and all the drug is being diluted in the fluids. Antibiotics have not been administered for whatever administrative reasons, unlikely to be a common cause. Correct organism and correct antibiotic, but infection is loculated. That is probably a very common reason. Whenever you have a non-responding pneumonia where you think you've given the right antibiotic, always think of an empyema like I talked about, because then this might require an intercostal drainage and even sometimes surgery. Another important cause is to rule out obstructions causing the pneumonia, like a lung cancer or a foreign body. These are two important causes you need to think about. Sometimes the identification of the causative organism may be wrong because you're not sending the adequate sample or a proper sample, and sometimes you have identified the wrong organism. A therapy has been directed towards the wrong organism, especially in patients who come from the community and already received antibiotics. Sometimes you pick up the wrong organism. Sometimes this pneumonia might be a pneumonia mimic. It might be a non-infectious cause like a lung infarction, eosinophilic pneumonia, or vasculitis, and so on and so forth. Sometimes you always need to think about drug-induced fever, especially the patient is otherwise getting better. Other all parameters improving. The patient only seems to be having continuous fever. Think of a drug fever, especially if the patient is on cephalosporins. And of course, sometimes the patient may also have another unrecognized concurrent infection like a central line or a urinary tract infection, which might be lack of need cause for non-response therapy. Of course, after you treated the patient, it's very important to also prevent a recurrence of CAP. So, influenza vaccine is recommended for any patient who has been admitted with CAP, and also pneumococcal vaccination is recommended for the prevention of invasive pneumococcal disease in adults. Obviously, anybody who comes to the CAP and who smokes has to be recommended to stop smoking. Very briefly at the end about pneumonia in the immunocompromised patient. Now, you must understand that immunocompromised patients are different. Why are they different? Because whereas in the community-acquired pneumonia in immunocompetent patient, might be possible to predict the number of organisms that can cause pneumonia. It's a limited range of organisms. It's most often easy to predict which organism has caused the pneumonia, likely to cause pneumonia in this patient. But in the immunocompromised patient, the host of organisms, there can be any organism can cause pneumonia. It could be a bacteria, it could be a fungus, it could be a virus, it could be mycobacterium, both mycobacterium tuberculosis and non-tuberculosis, and it could be nocardia. So, it's very, very difficult just clinically or just from the X-ray to decide what is the likely cause of community-acquired pneumonia in the immunosuppressed patients. So, for diagnosing a pulmonary infiltrates in immunocompromised patients, you must understand X-ray is not sensitive enough in the immunocompromised patients. So, in immunocompromised patients who comes with respiratory symptoms, it's almost mandated to get a CT scan done because sometimes you may miss findings on an X-ray. Similarly, for patients who come with immunocompromised patients who come with neurological manifestations, you have to do an MRI. So, remember this, that because ordinary imaging may not be sensitive enough, and CT scan is most sensitive and also guides subsequent invasive testing. Sputum examination is insensitive in the immunocompromised patients. But of course, if it is positive for some organism, it is okay. But quite often it's insensitive. So for the immunocompromised patient with a pneumonia, BAL remains the procedure of choice. So remember two things: CT scan more sensitive than X-rays, and BAL more sensitive than sputum examination because pick up organisms like pneumocystis, CMV, mycobacteria are much more easily detected with BAL. Also, though the sensitivity for aspergillus on the BAL is not very, it's not very sensitive. It's clearly superior to sputum or endotracheal aspirates, and also you can use the BAL galactum and it will help you diagnose, aspergillus pneumonia. Sometimes, if the infiltrates are diffuse, you might do a transbronchial biopsy, and sometimes, if you want to diagnose non-infectious causes of pulmonary infiltrates, you need to do a transbronchial biopsy. If there are focal lesions, you can do a CT-guided needle biopsy. Sometimes you are stuck; you don't get any diagnosis at all. Patient not doing well at all. Some people have considered doing an open lung biopsy, but of course, open lung biopsy has a very high complication rate, particularly in the neutropenic and bone marrow transplant recipients. And actually, studies have shown that even after doing an open lung biopsy, the significant alteration in management outcome is not really that much. So therefore, open lung biopsy is not done very commonly, but of course, sometimes really, really difficult cases when you're really stuck, you can be considered. But maybe a VATS might be a safer alternative rather than an open lung biopsy in these such patients who have pleural, subpleural, or diffuse lung infiltrates. That might be an alternative in open lung biopsy. Of course, you also need to do non-pulmonary adjunctive tests which help you in your immunocompromised patients. You can do a blood culture. Urine fluid lesion are not very common not very important in our country, but of course you can still do a pneumococcal antigen, CMV, PCR, antigenemia, serum galactomannan, BDG, and serum cryptococcal antigen will help you in the diagnosis of pneumonia in the immunocompromised patient. Thank you, and of course, if there are questions, I'll be happy to answer them.
Thank you, sir. Thank you for this excellent talk about community acquired pneumonia. We have a couple of questions from the delegates. So the first question is about the use of Tamiflu. So the question is from Dr. Ajit Vishwanath. Is there any actual benefit of Tamiflu? The recent Cochrane review has questioned the efficacy and side effects of the drug. And what is it indicated in community acquired pneumonia?
No, I agree that maybe, like all antiviral drugs, even remdesivir, I think the earlier you give it, the better. So I agree that probably Tamiflu is much more effective given on day 1 or day 2 of illness, like for any anti-infective agent. So by the time they have developed a pneumonia, obviously they've been 5 or 6 days down the illness, so it's unlikely that oseltamivir works. But having said that, when you have a viral pneumonia which is proven to be influenza A or B, influenza A, especially on a PCR, I think it becomes very difficult for us to not give oseltamivir. Though I agree that it may not be very effective in practice by time because the number of days that have passed since the infection began. But I think it becomes once I made a diagnosis of a influenza pneumonia, it becomes a little difficult not to give oseltamivir. And though I agree the Cochrane review has said no, but I would still probably in a viral pneumonia continue oseltamivir because it's like remdesivir for COVID. I mean, everybody says the same thing. That remdesivir given very early might have benefit. The later you give it, probably the efficacy is not so great. But practically, I think it becomes difficult not to give it. So scientifically, maybe you're right.
Another question is about community acquired MRSA. So what is the role of IVIG in severe community acquired pneumonia? And also, what is the duration of therapy in a community acquired MRSA pneumonia?
You need to do blood cultures, obviously, because if the blood culture is positive, then you need to give therapy for a much longer duration, minimum 14 days, and then you need to roll things like endocarditis and metastatic infections, etc. But I suppose the same argument would probably hold even for MRSA. Probably 14 days should be enough, provided, like I said, he has no endocarditis and no metastatic infections and no bacteremia. But the IVIG has been used for toxin production in patients with necrotizing fasciitis. Even that is a debatable indication. I think for community acquired pneumonia with the CA-MRSA, by and large, just giving the right antibiotic, like I said, main thing is they become very virulent if they have the PVL gene. So if they really have a bad virulent pneumonia, you need to assume that this is a PVL gene and give something suppresses toxin production. So if it's an MRSA, linezolid is probably better. If it is MSSA, and clindamycin is sensitive, even clindamycin is good enough because clindamycin also suppresses toxin production. So anything that's when actions are ready to S, so minocycline, clindamycin, if they're sensitive, or linezolid will be the agents of choice. I really don't think I would use IVIG, of course, unless it's a really, really virulent PVL producing gene, the patient is really not responding to antibiotics. Maybe as a desperate measure, you can use it for necrotizing fasciitis and toxic shock syndrome. But that's what you call it's a experimental indication. People use it in desperate circumstances, not been proven to be beyond doubt, not mandatory, but people try it in desperate circumstances.
So one question is from Dr. Shraddha. A dual anti-pseudomonal cover, is it needed when the risk factors are present, but not on pressors or peribicin?
Pseudomonas, this whole thing about dual antibiotic therapy in the non-neutropenic patient now has been clarified. In non-neutropenic patients, we don't need dual cover for Pseudomonas. Even if giving one effective anti-pseudomonal agent, especially if you're giving a drug like meropenem or piptazo, you really don't need to combine with an amino glycoside. Even in the neutropenic patient now, by and large, people are questioning whether you need to give dual antibiotic therapy. So, except for colistin sensitive pneumonia, where MDR Pseudomonas, that's a different issue. We're using polymyxin, but for the other Pseudomonas, we are sensitive to a carbapenem or a piperazine, tazobactam, or to a third cephalosporin. You really don't need to use combination with an amino glycoside. It only increase the risk of nephrotoxicity without any additional benefit. Clearly, in the immunocompetent and the non-neutropenic, but I think that might be applicable even to the neutropenic population.
And sir, what is the role of inhaled antibiotics in severe community-acquired pneumonia?
Community-acquired pneumonia, I really don't think it's a pneumonia. So you obviously inhaled antibiotics we're going to give to this are just only going to go into the airway. I really don't think, except in the setting of maybe bronchiectasis and all that, but I don't think there's any indication for inhaled antibiotics unless you're seeing on the ventilator. But your standard antibiotics work. The whole reason for giving inhaled antibiotics is that the patient has a resistant pneumonia, where the only drug that is sensitive is the polymyxin, and polymyxin doesn't achieve good enough levels in the lung, which is why you're forced to use a inhaled antibiotic. When you have IV antibiotics which achieve reasonable levels in the lung, you probably don't need to use inhaled antibiotics. So most of the standard antibiotics that you're using for a community-acquired pneumonia have adequate levels in the lung. So you really don't need to use inhaled antibiotics.
We have a question from Dr. Anand Nikaje. The question is clinical lab and radiological criteria to stop antibiotics.
No, certainly not radiological. Radiological resolution always takes a long time, so you certainly can't wait for radiological resolution. I would go by clinical. Like I told you, if it gets better, the quicker it gets better, the quicker I would stop. So if it got better in 2 days, I'll probably give antibiotics only 5 to 6 days. Some organisms like Pseudomonas, the recommendation is to give it for 14 days. In those situations, I might use a CRP rather than PCT. PCT purely from cost consideration rather than PCT, I would do a CRP maybe to make me a little more confident in stopping antibiotics. But even if it's Pseudomonas, if the patient has got better in 2 days, I would probably stop in 7 days. It's only in people who take a little time to get better, where you're a little worried about stopping antibiotics quickly. There you might use the guidance of biomarkers like CRP or PCT. But X-ray certainly not the question. X-ray is certainly only to pick up reasons for non-response, not for guiding stopping therapy.
One question I would like to ask about the role of bronchoscopy, as we always speak about the role of bronchoscopy in community-acquired pneumonia. So
like I told you, in community-acquired pneumonia, by and large, there is no role for bronchoscopy because most of the time the organisms, you can predict the organisms. It's only the immunocompromised patients where you don't know what it can be. It can be things like, if you get a proper sputum sample, etc., there really is no role to do a bronchoscopy. It's only in the immunocompromised where BAL is mandatory. You might have to do it in a community-acquired pneumonia if the patient for some reason is not getting better. Then you have to think maybe he incidentally has had some, unusual infection, unusual organism, or you need to rule out a obstruction of foreign body or a tumor which is causing non-response. Otherwise, only thing, of course, in community-acquired pneumonia, like I said, everybody needs to do an HIV just to make sure he is truly immunocompetent. But otherwise, there's a very limited role for bronchoscopy in a community-acquired pneumonia in the immunocompetent person.
Yeah. So we have one question about post-pneumonia lung fibrosis and the role of antifibrotic agents. And also we have one question about a post-COVID patient treated a month back who presented with breathlessness, CT suggestive of multiple cavity lesions bilaterally, BAL showing Acinetobacter. Is it usual to see cavity lesions post-COVID, and what is your experience?
No, no. I mean, when you have a cavity in the COVID, first like was your main worry really is about COVID associated pulmonary aspergillosis. So you need to rule out the multiple cavity lesions. It could be COVID associated pulmonary aspergillosis, but any necrotizing pneumonia can cause cavity. So it could be staph, it could be aspergillus, it could be Klebsiella. There's no reason why any pneumonia cannot be necrotizing, especially gram negative or like I said, even staph aureus. So ultimately, of course, you need to be very sure you're not missing pulmonary aspergillosis, but any of these can cause and Acinetobacter has been the number one organism in most ICUs causing VAP in the COVID ICUs, not in the regular ICUs, but in most COVID ICUs, I think all of us have seen Acinetobacter as number one organism. So I don't see any reason not to. But like I said, but still, when you have a cavity pneumonia in a COVID setting, always make sure you're not missing pulmonary aspergillosis. That's one thing you need to be sure about. And of course, TB, anything is possible. So you probably need to do a ball in this situation. You need to send it for every possible thing for TB, gene expert, galactomannan, everything else. And obviously, all that is negative, then of course it's clear that the organism is Acinetobacter is really the true pathogen.
So we have one question about what is the clear indication of using steroids in bacterial pneumonia?
No, like I said, if it is Streptococcus pneumonia, there is no question that you need to use steroids because Streptococcus pneumonia is the one pneumonia that causes inflammation. So there is no question that you need to use steroids. Other pneumonias, if you know it's a Klebsiella or a Pseudomonas pneumonia, there maybe you should not be using steroids because they don't produce so much inflammation and they probably cause more immunosuppression. So till you're not sure of the organism, you might in a severe community acquired pneumonia, not in the routine community acquired pneumonia. Somebody in severe community acquired pneumonia is in the ICU where you suspect Streptococcus pneumonia is the primary organism, then you need to use steroids. For viral pneumonia, for H1N1, there really is no role for steroids. But for COVID, of course, we all know about the recovery study and DAXA and all that. So these two situations, there is evidence for steroids. So all other non-pneumococcal bacteremia, bacterial pneumonia, and for H1N1, probably no role for routine use of steroids.
And sir, when will you cover for anaerobic organisms in community acquired pneumonia?
Anaerobics, by and large, don't cause pneumonias. They by and large cause a lung abscess. So I would probably not really jump to anaerobes in the usual run-of-the-mill pneumonia. They usually tend to produce, lung abscesses, maybe empyema, but more lung abscesses. So I would cover for anaerobes in the lung abscess, but they would not generally reach the ICU. So, and in any case, so I would not probably routinely cover anaerobes in a community-acquired pneumonia. Somebody has had a history of having some lot of dental caries and a lot of abscesses and all that. Maybe that's a rare situation. I may think about it, but by and large, I wouldn't.
Amol, one question from Dr. Nikal J. Clinical lab or radiological criteria to stop antibiotics?
So we covered this question.
Was covered. Oh,
already covered.
Okay.
Somebody asked if blood culture is negative but sputum positive for GNB and CAP, treated or not, and then what about the patient who has ceftriaxone? So it all depends on how the patient is doing, because quite often what happens is that many of times we get patients with community pneumonia who come from the community. Almost everybody's already got some antibiotic, either augmentin or azithromycin or whatever, or a third cephalosporin, and then they come to us. So now if you send a sputum culture, you're not sure whether this organism you're getting on the sputum or from the throat is just a overgrowth selected out because of the patient receiving antibiotics, but it is a true pathogen. So if the patient is already on ceftriaxone and is doing well, and there's no other risk factors for a gram negative, like I said, like alcoholism or immunocompromise or comorbidities, I would probably continue with ceftriaxone AZ. This is one situation where maybe urinary antigen also might help you, because urinary antigen shows that it is positive for strep pneumonia, then it possibly means that the organism was strep pneumonia, whatever the sputum shows. But clearly the patient has some risk factors, is not doing well on ceftriaxone AZ, then you would switch. But don't automatically switch in a patient who are doing well purely because the sputum grew GNB, because quite often, like I said, this is an overgrowth, a selection of gram negative in patients who have already received antibiotics. So quite often this happens. So somebody is asking the role of steroid in severe CAP is not in septic shock. So like I said, in severe CAP, even if it's not in septic shock, probably even if it's just hypoxic, they would probably recommend using but I said probably predominantly actually it should be only for pneumococcal pneumonia, though they say CAP, but I think I would be a little reluctant about using steroids in patients who have a pseudomonas pneumonia or something else. It's mainly really for the inflammation in pneumococcal pneumonia. So like I said, except for pneumococcal pneumonia and maybe for the COVID, of course, I would not use steroids. But sometimes you don't know, because the majority of severe CAPs are bacterial CAPs are strep pneumonia. We are recommending steroids for everybody. But if you have an alternative diagnosis, clearly pseudomonas, somebody who got lung disease and all that, you probably don't need to give steroids. Community acquired pneumonia with the Cryptococcus pneumonia, even if it's just severely hypoxic, but humanity stable, I would still give steroids.
I think we had covered almost all the questions asked to the delegate.
Thank you.
Thank you, sir. Thank you for giving me the talk about community acquired pneumonia. Thank you.
Thank you.
So after this session, we have a next talk about arterial blood gas analysis, and I would like to invite Professor Diwatia for the next talk about AB.
Of arterial blood gas analysis. Now, before we start, let's remember that in the blood gas report, when you see a blood gas report, of all the parameters that you see, there are only 3 parameters which are actually measured, and these are the pH, the PaO2, and the PCO2 measured by electrodes, and all the other parameters are actually calculated by algorithms or formulae. And we do blood gases for 2 main indications. One is for the oxygenation and ventilation status of the patient, and the other is the interpretation of the acid-base status. And in this talk, we will focus only on the interpretation of the acid-base status because that is more challenging and probably more difficult. When analyzing any report, remember that while there are normal ranges for the pH, PCO2, and the bicarbonate, for the purpose of analyzing a report, we will use 7.40 is the normal pH, 40 millimeters of mercury is a normal PCO2, and 24 millimoles per liter is a normal bicarbonate level. Right? Okay. Now, the first step is to decide whether there's acidosis or alkalosis. Some examiners will ask you what is the difference between acidemia and acidosis, or alkalosis and alkalemia. And anemia and acidemia is the pH status of the blood. So if the pH of the blood is acidic, it's an acidemia. If the pH of the blood is alkalotic, it's an alkalemia. And the process which causes acidemia or alkalemia is called acidosis or alkalosis. Small distinction, but some people may get asked this question. So if the pH is less than 7.4, we'll call it an acidosis or acidemia. If it's more than 7.4, we'll call it alkalosis. So let's say we've got a blood gas where the pH is 7.3, PCO2 is 60, and bicarbonate is 30. So this patient has a pH which is 7.3, which is acidosis. So this patient has an acidosis. That's the first step. Next step to decide whether it's a respiratory or a metabolic acidosis. Now, we all know that the acid-base status in the blood is regulated by 2 main organ systems. One is the respiratory component, which is the ventilation, and so washing out of CO2 causes a respiratory alkalosis. Retention of CO2 causes respiratory acidosis. And the other is a metabolic component, which is largely controlled by the kidneys. And the kidneys either retain bicarbonate to produce an alkalosis, or they eliminate bicarbonate to produce an acidosis, right? And the renal component takes time to develop because the kidneys have to develop all these enzymes and mechanisms and activate various pumps and metabolic processes to regulate the bicarbonate. So if the PCO2 is less than 40, we call it a respiratory alkalosis. If it's more than 40, we call it a respiratory acidosis. The metabolic component, if the bicarbonate is less than 24, we call it as a metabolic acidosis. If it's more than 24, we call it as a metabolic alkalosis. So in this patient who's got a pH of 7.3, which we said is acidotic, the PCO2 is 60, so this is a respiratory acidosis, and the bicarbonate is 30, which is a metabolic alkalosis. This patient has two acid-base disorders, a respiratory acidosis and a metabolic alkalosis. Now, when you have two disorders, in the third step, we decide which of these is the primary disturbance. And the answer is that disturbance, which is in the same direction of the pH, is the primary disturbance. So let's say, for example, you've got a disturbance where there is an alkalosis, and there's a respiratory alkalosis and a metabolic acidosis. The respiratory alkalosis is the primary component because it's in the same direction as the pH. On the other hand, if you've got a report where the pH is acidotic, you've got a respiratory alkalosis and a metabolic acidosis, it is a metabolic acidosis, which is the primary component because it is in the same direction as the pH. Now, in the example that we are looking at, the pH is 7.3 acidotic, PCO2 60 respiratory acidosis, bicarbonate 30, metabolic alkalosis, right? So here the respiratory acidosis is in the same direction as the pH. So this patient has a primary respiratory acidosis along with a metabolic alkalosis. So in the body, what happens is when there is one primary disturbance, or in this example, a respiratory acidosis, the other component will move in the opposite direction to minimize the impact of the primary disturbance on the pH, and this is called compensation. So if there is a primary respiratory acidosis, the kidneys will start retaining bicarbonate to create a metabolic acidosis, which will minimize the impact of the respiratory acidosis on the pH. So the body defends the pH. The aim of the compensating mechanism is not to normalize the pH, it is to bring the pH towards normal, but not normal. Okay, so it only minimizes the impact of the primary disturbance on the pH, and this is a very important thing which you need to keep in mind. So it never completely corrects, it partially corrects the acid-base disturbance caused by the primary disorder. So now if you've got a primary respiratory acidosis, which means a high CO2, you have a compensatory metabolic alkalosis with a high bicarbonate. If you've got a primary metabolic acidosis, you've got a compensatory respiratory alkalosis. If you've got a primary respiratory alkalosis, you've got a compensating metabolic acidosis. And again, if you've got a primary metabolic alkalosis, you'll have compensating respiratory acidosis. Right now, the body regulates these using certain rules, and what we have to see is whether the compensation that is occurring is as per the rules or not. Right, so that is the fourth step. That is to see whether the compensation that is occurring is as per the rules. If you've got a primary respiratory component, we know now that the metabolic component, that is a bicarbonate, compensates by moving in the opposite direction. Now, please remember, very important, that the compensation for a respiratory disorder takes place by the kidneys, and the kidneys take time for the compensating mechanism to develop, like I mentioned earlier. In other words, if the respiratory disturbance has been in presence for a short time, or it's been an acute respiratory disturbance, the compensation by the kidneys is not complete. Right? So the change in bicarbonate is not fully developed, and therefore it is incomplete. If the respiratory disturbance has been present for a sufficient time for the kidneys to compensate, in other words, more than 24 hours, or what we call as a chronic respiratory disturbance, the kidneys have full compensatory mechanisms developed. So when you look at a respiratory component, primary respiratory component, you need to decide either by the history or by looking at the blood gas, whether this is a acute respiratory disorder or a chronic respiratory disorder. All right. So remember, for a respiratory component, metabolic change is compensatory. So now, how do we know that the respiratory disturbance is acute? By looking at the blood gas. Now, if it is an acute respiratory disturbance, a 10 change in CO2 will produce a 0.1 change in pH, right? And if there is an acute respiratory disturbance, a 10 change in CO2 produces a 1 molecule change in bicarbonate. So in an acute respiratory disturbance, a 10 change in CO2 results in a 1 change in bicarbonate. If the disturbance is chronic, right, and it's been in existence for more than 24 hours, then a pH for every 10 change in CO2, the pH changes by less than 0.1. In an acute, it changes by 0.1, but in a chronic, it changes by less than 0.1 for every 10 change in CO2. And when there is a chronic respiratory disturbance, there is a 3 to 4 molecular change in bicarbonate for every 10 change in PCO2. Okay, so let's look at our example. So here you've got a pH which is 7.3, PCO2 is 60, and the bicarbonate is 30. Now the PCO2 is 60, so it's gone up from 40 to 60. There's a change in 20. A change in 20 should produce a 20 change in pH, a 0.2 change in pH. So this 20 change in PCO2 should make the pH 7.20. If it was an acute change, but the pH is 7.3. In other words, the change is much less than expected, right? So the change in pH is only 7.1. So the pH is higher than predicted for this PCO2, and therefore this makes it as a chronic respiratory change. Now, if the respiratory acidosis is chronic, then you will expect the bicarbonate to change by 3 to 4 milliequivalents for every 10 change in CO2. The CO2 has gone up by 20. You will expect the bicarbonate to change by 6 or 8, right? So you will expect the bicarbonate level to be 24 plus 6 or 24 plus 8, that's 30 to 32. Now, we see that our bicarbonate level is as predicted by the formula, and that means it's following the rules for compensation, and therefore this is a compensated respiratory acidosis. Even though the pH is not normal, it has come toward normal. This, and because the bicarbonate level follows the rule for compensation, we call this as a primary respiratory acidosis, with this which is compensated by the metabolic alkalosis. All right. Now, that is a rule for respiratory if the respiratory component is primary. If the metabolic component is primary, we don't have to worry about acute and chronic because the CO2 responds very rapidly to changes in the metabolic status. The moment there is an acidosis, you will get the CO2 hyperventilating. So the CO2 response is extremely rapid. You don't have to worry about acute or chronic primary metabolic component. So if the primary event component is metabolic, right, then the respiratory change is compensatory. And as a rule of the thumb, if you don't want to remember formulae, one change in CO2 produces a one change in bicarbonate. Right? But for this, there is a formula which you need to remember, and this is called the Winter's formula. This is the formula for metabolic acidosis, and this is the formula for metabolic alkalosis. So you need to remember this formula, and you need to just keep this in mind. And it's there in your books, and it's there in some of your apps, but you must know this formula. This is called the Winter's formula. Okay. So let's say you got this blood gas with a pH of 7.3, that's acidotic, PCO is 35, that's respiratory alkalosis, and bicarbonate is 18, that's a metabolic acidosis, right? So this, the primary component here is metabolic because that is in the same direction as the pH. Now, for a metabolic change, which is primary, what is the expected CO2 for a bicarbonate of 18? So bicarbonate 18 change by 6. So the CO2 rule of thumb should change by 6. So it should be 40 minus 6, that's about 34. So it's roughly what is predicted by the rule of thumb. But when you put it in Winter's formula, 1.5 into 18 plus 8, so you get 33 to 37 is the predicted CO2, and our value is exactly as predicted. And therefore, again, this compensation is as expected. So this patient has a primary metabolic acidosis, which is compensated by a respiratory alkalosis. Why do we go into all this detail about whether it's compensated or not compensated or whatever? Because if the compensation is as per the calculation, this patient has a single acid-base disorder. If the compensation is less than or more than the calculated value, then this patient has an additional or a dual or a multiple acid-base disorder. So for example, in this patient, let's say the PCO2 was 42, right? Now we've calculated and we found that the PCO2 should have been at the most 37. But if it is 42, it means there's an additional respiratory acidosis. And then we have to figure out why this patient has an additional respiratory acidosis. Maybe it is because of sedation, maybe the patient is exhausted, or whatever it may be. But it has uncovered an additional respiratory acidosis in addition to the existing metabolic acidosis. Right? So that's the importance of checking for compensation. Okay, now if the patient has a metabolic acidosis, we have got one more step, which is a sixth step, which is to check the anion gap. Now the anion gap, which is the difference between the sodium minus chloride plus bicarbonate. Normally it should be 12. A wide anion gap suggests that there are unmeasured anions which are present in the body. And these are commonly sulfates, phosphates, lactates, and sulfates and phosphates are products of metabolism and normally excreted by the kidneys, but they could accumulate, for example, in renal failure. You could get lactates going up because of anaerobic metabolism, shock, hypoxia, or whatever. So you would not be measuring these, but they would raise the anion gap, they would widen the anion gap. And so if the anion gap is more than 12, it is we call it a wide anion gap acidosis. And this mnemonic called mud piles gives you some of the causes of a wide anion gap acidosis. For example, methanol, uremia, diabetic ketoacidosis, paraldehyde, isoniazid, lactate, ethanol or ethylene glycol, salicylate. So these are all substances which accumulate and cause a metabolic acidosis with a wide anion gap. If the anion gap is less than 12, we call it as a non-gap or a non-anion gap acidosis. And this is commonly due to loss of bicarbonate, for example, in diarrhea, or hyperchloremic acidosis due to excessive administration of large volumes of normal saline. Very important, always adjust the anion gap value for the serum albumin. And for every 1 gram fall in albumin below 4, you add 2.5 to the anion gap. So for example, let's say you had a patient whose anion gap was 10, right? You just calculate the anion gap and it was 10. And you would say this is a non-anion gap acidosis. But if his albumin is 2, so albumin of 2 is 2 below 4. So you have to add 5 to this anion gap of 10. And this anion gap now actually corrected anion gap becomes 15, which is a wide anion gap acidosis. So always adjust the anion gap for the serum albumin level. Okay, so these are the 6 steps which are very basic steps which you must be able to do for all patients, and you're almost through with both the patient and your examination if you ever get a blood gas. There is one more step which is a scoring step or a gold medal winning step, which you should know this step just for the sake of knowledge, if not for anything else, is does the change in anion gap explain the change in bicarbonate, right? So in other words, let's say you've got an anion gap which is something about 12. Now that should normally equal the change in bicarbonate. In other words, the delta bicarbonate should equal the delta anion gap if that is the only problem, right? So for example, if the anion gap is 20, that means that the delta anion gap is 8. Ordinarily, this means that even the bicarbonate should have changed by 8, so the bicarbonate should be 16, right? Suppose the bicarbonate is 20. It means there's an additional source of bicarbonate coming from somewhere. So not only is there a wide anion gap acidosis, but there's additional metabolic alkalosis, which is giving you additional bicarbonate. If the bicarbonate, say, was instead of 16 was 12, it means there's an additional acidosis, which is usually a non-anion gap acidosis. So this, in a patient with a metabolic acidosis, looking at the delta gap can help you decide whether there's an additional metabolic alkalosis or an additional normal anion gap metabolic acidosis, right? So, and if you want to be mathematical, you can put in a formula like this, that bicarbonate plus gap minus 12 should be equal to 24. If it is more than 24, there's an additional hidden metabolic alkalosis. If it is less than 24, or hidden non-gap acidosis. So let's say, for example, you've got this diabetic who's got diabetic ketoacidosis with an anion gap of 23, right? And the bicarbonate is 18. So now anion gap is 23, right? That means it's changed by 11. And bicarbonate is 18, which has changed by 6, only by 6. That means there's an additional metabolic alkalosis. And why? Maybe this patient has got some sodium bicarbonate in the treatment of his acidosis. And that's why you're getting an additional metabolic alkalosis. So again, you have to figure out the reason, but it tells you that there is a hidden metabolic alkalosis, right? And that's because the change in bicarbonate is less than that predicted by the change in anion gap. This is an alcoholic with a 2-week history of diarrhea, an anion gap of 17 and a bicarbonate of 10, right? So now this is again less than 24, which suggests that this is a hidden metabolic acidosis. So this is an alcoholic ketoacidosis, but he also got a hidden non-anion gap metabolic acidosis. So the delta gap is bicarbonate is 14, which is much more than the delta gap of 5, right? So, and this is because of bicarbonate loss, a non-anion gap acidosis due to diarrhea. So this helps you uncover a few more things, right? And just like you have a delta gap, you've got a delta ratio, which is the change in anion gap divided by the decrease in bicarbonate. And if it is 1, it suggests that the change in anion gap predicts the change in bicarbonate. If it is less than 1, it suggests a greater fall. That means an additional metabolic acidosis, often due to renal failure. If it is more than 2, it suggests a lesser fall in bicarbonate than expected and is due to an additional metabolic alkalosis. But just like you have a urine anion, blood anion gap, you've got a urine anion gap, and I won't go into details. This is probably beyond the scope of this talk. And it's mainly because of looking at hidden cations which are excreted in urine. That's ammonium, which is increased when there is a metabolic acidosis. And it helps you to distinguish diarrhea, acidosis due to diarrhea from a renal tubular acidosis. So always remember, do a stepwise analysis. Don't jump 7 steps. Remember them: acidosis or alkalosis, which is the primary. If for a respiratory disturbance, determine whether it's acute or chronic. For any respiratory disorder, determine the compensation is okay. Assess compensation for a metabolic disturbance. If there's a metabolic disturbance, decide what the anion gap is present if it's a metabolic acidosis, and then do other steps to decide whether there are additional disturbances in addition to a wide anion gap acidosis. So I think what we'll do now is we'll try and analyze some blood gases in the live session. So thank you very much for. Okay. Can you hear me and see my screen?
Yes, sir. Yes, sir.
Okay. So we'll do some simple and then some slightly difficult blood gases for analysis. Okay, so this is a 30-year-old female with a sudden onset of dyspnea. There's no cough or chest pain, vitals normal, respiratory is 26. And here you can see that the pH is 7.52, by carbon dioxide 30, and the bicarbonate's 22. So what do you think this is? Okay, so bicarbonate 7.52 makes this an alkalosis, PCO2 of 30. So this is a respiratory alkalosis and a metabolic acidosis. Primary disorder is respiratory alkalosis because it's the same direction as the pH. Whenever there's a respiratory component, you need to ask whether it's acute or chronic. So the pH has changed by 10, right? From 7.40 to 7.52. So about a little more than 0.1, right? The CO2 has changed by 10 and the pH has changed by roughly 0.1. So it's probably an acute respiratory alkalosis. Renal compensation for acute respiratory alkalosis, the bicarbonate decreases by 1 for every 10. So it should decrease by 1. Expected 23, observed 22, more or less okay. So this is a acute respiratory alkalosis. Now you have to figure out what is the reason for this, why she's got this. Maybe she's got an anxiety attack or a panic attack or something. Maybe we need to figure out why she's got acute respiratory alkalosis. But as far as the blood gas is concerned, this is an acute respiratory alkalosis. Okay. So this is a patient with hemorrhagic shock. Hypotensive, pH 7.3. So if you can type your diagnosis on the chat. Right? So 7.3 makes it a acidosis. A PCO2 of 32 makes it a respiratory alkalosis. Bicarbonate 16 is a metabolic acidosis. So the primary component is a metabolic acidosis, and the anion gap that we have checked is 20. Right. So this is now if you put in the Winter's formula, then you will see that the CO2 is as predicted. Therefore, this is a pure metabolic acidosis. And the anion gap, and how much is the anion gap? Anion gap, assuming that the albumin is normal, is 8, right? And the bicarbonate is also changed by 8. So the change in anion gap explains the change in bicarbonate. There's no additional component. And we now can see that the lactate is accounting for almost all of that increase in anion gap. So this is a lactic acidosis, right? Okay. And lactic acidosis due to hemorrhagic shock. So we'll talk a little bit about lactic acidosis. Okay, so we know that lactate is formed when from glucose. So glucose normally goes into oxidative phosphorylation and produces 38 millimoles of ATP under aerobic conditions. However, if oxygen is inadequate, then pyruvate does not enter the Krebs cycle, and it in fact gets metabolized to lactate, and that's when lactate sort of gets formed, right? And when lactate is formed, you don't get 38 moles, you only get 2 moles of ATP, which is being formed. So when you have any tissue hypoxia, then you can get lactate production, and that is a very common sort of situation in intensive care where you get lactic acidosis, where the oxygen delivery is inadequate for the consumption of the required of the tissues. Okay. Now you can also get aerobic lactate production when the entire aerobic pathway is so accelerated that you start getting a little more lactate which is produced when some of the pyruvate gets diverted towards lactate. So overall, if your glycolysis is heavily stimulated, you will also get some more lactate production, and that is aerobic lactate production, which you get, say, for example, when you exercise or when you're giving adrenaline. right? So when you give adrenaline for as an infusion, you can stimulate glycolysis and you will also get an increase in lactate. The important thing is both pyruvate and lactate production is increased, and so you will get a normal ratio of pyruvate to lactate. Okay. Now, in sepsis, why do we get hyperlactatemia in sepsis? It is usually not necessarily because of anaerobic metabolism. It could be because of acceleration of glycolysis, which you get in sepsis, and the decreased activity of pyruvate dehydrogenase and mitochondrial dysfunction. So the pyruvate does not enter the Krebs cycle and therefore gets converted to lactate because of the problem with the enzyme in sepsis, okay, which takes pyruvate into the Krebs cycle. Or you've got mitochondrial failure, right? So the tissues cannot utilize this oxygen, and therefore this moves in the reverse direction, and you get excessive formation of lactate. So even though your blood pressure, your cardiac output may be high, because of inactivity of the enzyme or mitochondrial dysfunction, you can get it. Or you can have massive lactate production in the gut, right? And that causes the lactate to rise in the gut. And or you could have decreased utilization of lactate. The liver may not metabolize the lactate, or the muscles may not be able to utilize the lactate, and so you get this thing. So in other words, a high lactate level is a balance between increased production and decreased clearance from the liver, especially from the liver. So even with liver failure, you will get a high lactate, even with aerobic metabolism. You can get increased production very commonly with anaerobic metabolism, like in this hemorrhagic shock that we said, or it could also be under aerobic conditions because of excessive production, accelerated glycolysis with adrenaline, or by inhibition of the pyruvate dehydrogenase enzyme. So always don't jump to conclusions when you see a high lactate that it is only because of anaerobic metabolism. And we all know that serial measurements of lactate are better than a single measurement of lactate. Now, please remember that lactate is a marker. Lactic acidosis is not a disease. Lactic acidosis is a sign of a disease, is a sign of a bad thing going on. And this was very nicely shown in this trial, which was done many years ago. They gave dichloroacetate, which actually breaks down lactate. So you can clear the lactate by giving dichloroacetate. So in patients who had a shock and a high lactate level, they gave half of them dichloroacetate, the others got placebo. The lactate levels were very high to start with, so they were very sick patients. Lactate levels came down in a large number of patients. 66% of the lactate levels came down. The lactate levels didn't come down in most of the placebo patients, but the mortality was higher in the patients who got dichloroacetate. So in other words, bringing the lactate levels did not change the mortality. In fact, if you did something to get the lactate levels down, you treated the problem and got the lactate levels down, you're probably better off in doing that. So always when you see a metabolic or a lactic acidosis, treat the cause. Even if it's a diabetic ketoacidosis, treat the cause. Don't jump to correct the pH, or don't jump to correct the lactate level. Treat the cause. If the acidosis is very severe and causing problems, you can consider a sodium bicarbonate infusion or dialysis, right? And soda bicarb may be useful if the acidosis is not associated with tissue hypoxia. So first correct the tissue hypoxia, treat the cause. If you're still having a acidosis, then maybe you can give bicarbonate as a temporizing measure. Okay, so that's the bottom line when you deal with a metabolic acidosis. Okay, let's take this next case. This is an elderly man, known case of congestive heart failure. He's on loop diuretics. He comes to you, he's disoriented. And this is the blood gas. pH is 7.55, PCO2 is 48, and bicarbonate is 36. Sodium 130, potassium 3, and chlorides 86. So what does this patient have? So the pH is 36. Sorry. The bicarbonate is 36 millimoles. The pH is alkalotic. So this patient has a metabolic alkalosis. Is it primary respiratory or metabolic? So the respiratory component is actually acidotic at pH PCO 48, and the bicarbonate is 36. That's the alkalotic component in the same direction as the pH. So it's a primary metabolic alkalosis. Now, is this metabolic alkalosis compensated? In other words, is the CO2 of 48 as predicted for a bicarbonate of 36, right? So, and if you put it in Winter's formula, the expected CO2 is 0.7 into 36 is the Winter's formula for metabolic alkalosis, and the expected PCO2 is 46 plus or minus 1.5. So it's as predicted. That means this is a compensated metabolic alkalosis. There is no respiratory component. So this is a metabolic alkalosis. Okay. Now the question is, why does this patient with heart failure on a diuretic have a metabolic alkalosis? And when you look at alkalosis, metabolic alkalosis, there are you can have alkalosis because of loss of hydrogen from the kidney, and that's usually because of diuretics or in chronic hypercapnia when the as a compensation for chronic hypercapnia when the hydrogen is thrown out so as to produce and bicarbonate is retained, or you can have loss of hydrogen from the GI tract by vomiting, by nasogastric suction, or in rare conditions like a villus adenoma or a vipoma, the watery diarrhea, hydrochlorhydria syndrome. Okay? Or you can have alkali administration when someone is given excessive alkali. So you could get it from sodium bicarbonate administration. The citrate which is there in the blood or the acetate which is there in TPN gets metabolized to bicarbonate, and that can eventually cause a metabolic alkalosis. So you can give it some antacids or stuff like that. Or you could get in conditions where there's excessive mineralocorticoid activity, where the hydrogen is thrown out and the bicarbonate is retained, like in primary aldosteronism, Cushing syndrome, Bartels syndrome, licorice intoxication, and so on. Right. So these are the causes, important causes of metabolic alkalosis, loss of hydrogen ions either from the kidney or from the GI tract, or excessive alkali administration, and sometimes because of excessive mineralocorticoid activity. Now, once you have a cause that initiates this alkalosis, you need something which maintains that alkalosis, right? And that has, because the kidneys would otherwise actually eliminate the extra bicarb, but something prevents the kidney from eliminating the extra bicarb, and that is because of hypovolemia, chloride depletion, and hypokalemia. So these three things very commonly accompany a metabolic acidosis are in fact the reasons why there is an inciting cause and the alkalosis being maintained. And usually these are the maintaining sort of factors, that is metabolic which maintain the metabolic alkalosis, that's hypovolemia, chloride depletion, and hypokalemia. Okay. And the treatment is, most of the metabolic alkalosis are saline responsive. So both the hypovolemia and the hypochloremia, along with potassium, can correct most of the alkalosis. But those which are saline unresponsive are usually due to a mineralocorticoid problem, right? And they are saline unresponsive. If you give normal saline, you will not be able to correct the metabolic alkalosis. And for them, you have to do other things, including giving aldosterone antagonists like spironolactone and amiloride. Right? So this is very briefly to give you a snapshot into the causes and management of metabolic alkalosis. If it's very refractory or associated with seizures, you can actually have to give an acid, which could be arginine or ammonium chloride, or very rarely even hydrochloric acid. I mean, I've never had occasion to do any of these things, but that's been described in the books. Okay, so now here's one more case. This is a 45-year-old male admitted with acute intestinal obstruction, 3 days duration, and oliguria. Okay, so pH 7.2. Bicarbonate 10. So there's a severe metabolic component over here. Right, sodium 131, potassium 6.6. That's on the higher side. Chlorides are 98. So what is the pH is acidemia, right? So there's a pH is 7.2. That's acidemia or acidosis. Primary respiratory metabolic. It's a metabolic is a primary component because the bicarbonate of 10 is the same direction as the pH. Is it compensated? So the expected PCO2 for a bicarbonate of 10 is 23 plus or minus 2, and it's 25. So there is no respiratory component. So it's a pure, well-compensated metabolic acidosis. Then you look at the anion gap, and the anion gap is high. So the anion gap is 23. Right? So this is a high anion gap acidosis. Now we go to the next step. Does the change in bicarbonate explain the change in anion gap, or does the change in anion gap explain the change in bicarbonate? Okay, so the bicarbonate has changed by 14, right? The bicarbonate has changed by 14, and the anion gap has changed by 11, right? So that means Okay, did you get that? The bicarbonate has changed by, the bicarbonate has changed by 14. The anion gap has changed only by 11. That means the bicarbonate has fallen by more than has been predicted by the anion gap, which means there is an additional non-anion gap metabolic acidosis, right? So you have to figure out what is the cause of that. And if you see the delta ratio, the anion gap, the ratio is 0.76, and a ratio of less than 1 in acidosis is often associated with renal failure. So this is a acidosis due to renal failure, and there is an additional non-gap acidosis. It may be because of loss of bicarbonate into the gut in intestinal obstruction, right? So there is a so this is the sort of complete picture which you get. So if you had said metabolic acidosis would have been correct, but because of this step, you also found an additional non-anion gap acidosis, which you can explain because bicarbonate is probably leaking into the gut. And the renal failure is, we know that this delta ratio less than 1 is often associated with renal failure, and that also explains the high potassium level. This is a 42-year-old diabetic who's probably a juvenile, so insulin-dependent diabetic, history of dysuria, so she got urinary tract infection. And this is a pH is 7.23, PCO2 25, bicarbonate 12. So this patient has so the pH is 7.23, so that's an acidemia, primary metabolic, compensated. You can see that the PCO2 is expected to be 25, 23 plus minus 2, so there is no respiratory component, and the anion gap is 23. So this is a high anion gap acidosis, right? Now anion gap is gone up by 11, right? Anion gap has gone up by 11, and the bicarbonate is 12. So the bicarbonate has gone down by 12. So it's almost exactly predicted. So the change in bicarbonate almost equals the change in anion gap. And if you take the ratio, it is exactly almost equal to 1. And therefore, there is no additional cause of acidosis. This is a pure high anion gap metabolic acidosis, and probably due to diabetic ketoacidosis. Okay. Okay. Now, the last few slides, we've been seeing blood gases and we're making one diagnosis, right? So we are saying this is metabolic acidosis. This is high anion gap with something else. But in a patient who's in the ICU, the whole course of acid-base disturbance can be quite dynamic. So this is just a case. Again, this is not our case. It's taken from some literature. So this is a patient who's got CCF with digoxin and Lasix, and now she gets pneumonia. And when you do an initial blood gas on admission to the emergency room, the pH is 7.59, little hypoxic, CO2 31. So there is a respiratory alkalosis. There is also a metabolic alkalosis, right? Because the bicarbonate is 29. So this patient has a combined respiratory and a metabolic alkalosis. And how do you explain it? Well, the metabolic could be to the diuretic use. She's using Lasix for CCF. And the respiratory is due to hyperventilation because she's got a pneumonia. So in fact, she's profoundly alkalotic. The pH is almost 7.6. So this lady has now come in with CCF and a metabolic alkalosis, probably due to the Lasix use. And she's hyperventilating because of the pneumonia. And she's also got a respiratory alkalosis, right? So she's got a combined respiratory and metabolic alkalosis. So she gets antibiotics, but she continues to worsen, right? And now she's probably exhausted. CO2 has gone up to 48. She's also become hypoxic. Now the CO2 is 48, so she's got a respiratory acidosis. And she's probably got a metabolic alkalosis, which is still there. That's why her pH is now normal, right? Now, okay, so she gets intubated, continues to get antibiotics, then she goes into shock. Her BP becomes 80/60. So now her pH is 7.24. She's got an acidosis. The PCO2 is 38. That's normal or a mild respiratory alkalosis. The bicarbonate is 16. So she's now got a metabolic acidosis. So she started a respiratory and a metabolic alkalosis. Now she's got a metabolic acidosis with a bicarbonate of 16. The anion gap is 23. So here she's got a wide anion gap acidosis. Now, for this bicarbonate of 16, for a bicarbonate of 16, you would expect the PCO2 to be in the range of 30, but the PCO2 is 38. right? So in other words, she's got a wide anion gap acidosis as well as a respiratory acidosis. And this respiratory acidosis probably because of our ventilator settings, we've sort of thought of PCO2 is okay, but now she's not, the body is not compensating. Now you have taken over a ventilation. So now you have allowed a CO2 of 38, but had she been ventilating normally, this would have been little more than the CO2 that is expected for us. You would have expected a CO2 of around 30, but it's actually 38. So in fact, her acidosis is a little more than what would have happened had she been breathing on her own. And this sepsis, this metabolic acidosis is probably because of lactic acidosis due to sepsis. Okay, so now she's now going to a respiratory and a metabolic acidosis. And the lactate is 8, so there is a lactic acidosis. Right. So now you monitor her cardiac output, you find, and you do an echo, and you find that there is hypokinesia. So you give a bit of dobutamine, and she improves. And now you find that the pH is 7.34, PCO2 is 38, and the bicarbonates are 20. So now the acidosis seems to be improving. The metabolic acidosis is improving, but the bicarbonate has increased from 16 to 20. The pH has come up. The PCO2 is still the same. Right? She gets better. You restart her Lasix because she's unable to feed her for some reason. You give her TPN and oxygenation improves. But now you find the pH is 7.55. The bicarbonate CO2 is 44. So in fact, there's a respiratory acidosis. And now she's again got a metabolic alkalosis. And now you want to figure out why she's got a metabolic alkalosis, because no, you just restarted the Lasix. So that earlier metabolic acidosis cannot suddenly become a respiratory, metabolic alkalosis just because of 1 day of Lasix, right? Now the expected CO2 is more or less as you predicted. Okay, so that's not a big issue, but you need to figure out why this patient's got a severe metabolic alkalosis. You think it is because of Lasix, so you discontinue the Lasix, you try and get the bicarbonate out by giving acetazolamide, but as alkalosis continues to worsen, and 48 hours later, the pH is even worse, 7.60. The PCO2 is now 46, and the bicarbonate is 44. Severe metabolic acidosis. Expected CO2 is as predicted, so there's no added respiratory component, and now you need to figure out why this patient is getting further more and more alkalotic. And in those days, there is acetate in the TPN solution, which is added to this thing, and that is a source of bicarbonate. The bicarbonate could also be retained due to hypovolemia, which perpetuates and maintains the alkalosis. So this patient was in that book, the TPN was put off, enteral feeds were given, little volume was given guardedly, potassium chloride was given, and the alkalosis resolved. So this is just to say that, in a given patient, the acid-base changes can be quite dynamic, and sometimes unexpected things can happen. You just need to keep your eyes and ears open and follow the trends and make sure you look after the patient thoroughly. Okay, I think I'll just stop over here. If there are any questions, we'll take questions. Thank you.
Thank you, sir. That was quite comprehensive overview and explanations of the acid-base balance disorders in the ICU. We've got a couple of questions. One is, how do I see the validity of my blood gas?
Okay, so I'll share my screen again. Okay, now, in the old days, when the machines were not well calibrated and you had to do all these sorts of calibrations and so on, then, we had to check whether your blood gas was a correct reading or whether there was any problem. And if you want to check the validity of your blood gas, then this is what you do. You have to look at your Henderson-Hasselbalch equation. Now, let's say I've got this blood gas of pH 7.3, CO2 60, and bicarbonate 30. I want to know, is this a valid report? Now, as per the equation, the hydrogen ion should be 24 into CO2 upon bicarbonate. So when you rearrange it, hydrogen ion into bicarbonate upon CO2 should be equal to 24. So if you feed in all the values of hydrogen ion concentration, bicarbonate, and CO2, you should get 24. Now we are using the pH, which is the negative log of the hydrogen ion concentration. So you have to convert your pH to the hydrogen ion concentration. Now, a simple way of doing it, for pH values between 7.2 and 7.5, you deduct the last two digits of the pH, that's 20, 30, 40, and 50 from 80. right? So if it's 7, so if the pH is 7.20, you deduct 20 from 80. So 80 minus 20 is 60. So that 60 is your hydrogen ion concentration. So in this example, the pH is 7.3, so 7.30. So I'll deduct 30 from 80, so I'll get 50. So my hydrogen ion concentration is 50, my bicarbonate is 30, and I divide it by 60, I get 25, which is more or less 24 plus minus 2. So this is a valid report. So you can test the validity of your report by putting your values into this equation. And remember, you have to convert your pH into hydrogen ion concentration. Does that answer your question?
Yes, sir. I think should be. Then Dr. Rashmi Shravan, she asks, can you explain high anion gap and normal anion gap combined acidosis in the context of renal failure, and also delta bicarb and delta anion gap in decay?
Okay, so I'll have to go over that slide again, or I'll just tell you. So, you have now metabolic acidosis is usually the result of a problem, right? It's the result of a problem. And it is also complicated by some therapies that you get. So, uh, uh, so let's say you've got a patient who is diabetic and who's got diarrhea, an infectious diarrhea, and therefore has got renal failure. So this patient will have a high anion gap because of diabetes, if he's got diabetic ketoacidosis, or he could be having high anion gap because of renal failure, right? So that's a classical high anion gap acidosis which you will have. You will have a high anion gap, metabolic acidosis or HAGMA. Now, because this patient has diarrhea, he may also be losing bicarbonate, which will contribute a little more to the acidosis, and that will be a non-anion gap acidosis or a NAGMA. So in this patient with renal failure, you will have a HAGMA plus a NAGMA. Okay. How do you know? So now in a high anion gap acidosis, you could also have an additional non-anion gap acidosis, or you could have a alkalosis, right? And how do you know that? You look at your anion gap, the change in anion gap, which is your delta gap, and you look at a change in bicarbonate, which is your delta bicarbonate. Okay. Now, the normal anion gap, anion gap is 12. Your normal bicarbonate is 24. Let's say you had an acidosis and you got an anion gap, the change anion gap. So some anions were added and your anion gap came from 12 to 22. In other words, 10 anions were added, right? That's why anion gap has changed by 10. So from 22 minus 12 is 10. So 10 is a change in anion gap. Now, ordinarily, all the anions which have been added and are causing the acidosis should cause the similar change in bicarbonate. So bicarbonate should also fall by 10. So bicarbonate should become, from 24, it should become 14. So 10 change in anion gap should produce a 10 change in bicarbonate. Okay. Now suppose the bicarbonate, suppose the bicarbonate is not 14. Suppose the bicarbonate is 10. It means there is a further loss of 4 bicarbonate from this patient, which is not explained by the addition of anions as per the anion gap. So that change in bicarbonate, that further fall in bicarbonate, it has to be because of loss of bicarbonate, which produces a non-anion gap acidosis. And that is because of diarrhea. So in other words, in addition to your high anion gap acidosis, which is contributed by the addition of anions, you could also be losing bicarbonate, maybe through diarrhea, which is causing an additional non-anion gap acidosis. That is why you have to look at a change in anion gap and a change in bicarbonate. If they are equal, it is a high anion gap acidosis, and the entire drop in bicarbonate can be explained by the addition of those anions. If the bicarbonate falls more than what is the addition of anions, then there is an additional non-ion gap acidosis. On the other hand, if instead of 14, the bicarbonate was 18, it means that the change in bicarbonate is less than that which is predicted by the anion gap. So the anion gap should have caused the bicarbonates come down to 14, right? But there are 4 additional bicarbonates. If the bicarbonate is 18, there are 4 additional bicarbonates. And those bicarbonates have come from metabolic alkalosis, which is present in addition to your anions. So there's 4 more bicarbonates are present than can be explained by anions. And that is because someone has given additional bicarbonate. Whether it's from a body process, say because a patient has CCF and he also on a diuretic, or someone has given bicarbonate in an attempt to treat deacidosis, that's a different matter. But it means there is an alkalosis or additional bicarbonate beyond what can be explained by the by the change in anion gap. And that is why you have to try and see whether a change in bicarbonate is explained by the change in anion gap. And if not, then there's either if there are more bicarbonates than predicted, then it means an additional metabolic alkalosis. If there are less bicarbonates than predicted by a change in anion gap, it's an additional non-gap acidosis. Does that answer your question?
Yes, I think that should. I think. Okay, I can't see any more questions.
There's one question about ABG validity, report validity.
Sir is covered that. Sir is covered that. Yeah. Yeah, I think. Yeah, we run out of questions, sir. Yeah.
And run out of time also, right?
Okay. Thank you so much, sir. So, yeah. So we move on to our next speaker. Again, this is a reminder. All the delegates who have been registered for this conference can get the benefit of buying 2 books at a very, very subsidized cost from the platform. If you can pre-book the books. So one is the infectious disease in critical care, and the other is the BRITE course book. And you can pre-book the infectious disease course book here, and the book will be delivered by post in 2 to 3 weeks time. The BRITE book also you can book here online at a very subsidized cost. So I encourage all of you to take that benefit. Okay, so moving on, and it's a great pleasure to invite Dr. Srinivas Samavedan, who's a dear friend. He is the head of the intensive care department at Virinchi Hospital at Hyderabad. Again, he's he's been the secretary of Indian Society of Critical Care Medicine. He's also the examiner for most of the critical care examinations. He will be speaking on upper GI bleed. Over to you, Srinivas.
Good morning and welcome to this BRITE session for the benefit of students appearing for various critical care exit exams. It's a fantastic effort, and I remember being part of this program last year, which was my last outstation travel before COVID struck us. The topic given to me for discussion in the next 25 minutes or so is upper GI bleed. So let's take a case scenario of a patient who's a 46-year-old male with a known case of cirrhosis of liver due to chronic alcohol intake, and he presents with acute onset hematemesis followed by loss of consciousness. The relatives reveal that he had blood-stained vomiting overnight and might have lost some blood through the vomitus. He was previously admitted 2 weeks prior today for massive ascites requiring aspiration and paracentesis, and was detected to have esophageal varices for which ligation was done. That's the background for this patient. In the ICU, this patient is unconscious with a GCS of 8, E2, M3, and V3. His pupils are isochoric and reacting to light. He is pale. He has tachycardia at 115 but is regular. Is hypotensive at 70 over 36 millimeters of mercury. His respiratory rate is high, and he's hypoxic with saturation of 85% on room air. On auscultation, his chest reveals decreased air entry at the both bases. Abdomen is warm, tense, and distended. Laboratory investigations reveal a total leukocyte count of 13,000 per cubic millimeter, predominantly polymorphonuclear leukocytosis with an INR of 3.5 with a prothrombin time of 22 seconds. Thrombocytopenia was also noted with a platelet count of 40,000 per cubic millimeter. His liver functions show a total bilirubin of 6.2 and an alkaline phosphatase of 208, an ALT of 72 and an AST of 88. Albumin is 1.4. His blood sugar is low at 40 milligrams per deciliter, and his renal function with a creatinine of 2 appears to be deranged as well. During the past admission, his creatinine was 1.3. At this point, his ammonia was 88 micrograms per deciliter. So what would your initial approach be for the management of this particular patient? As with all patients who have hemorrhagic manifestations, be it trauma or obstetric hemorrhage, a large bore cannula is secured, which means 18 gauge or larger. Some people prefer a central venous line, but remember that central venous line is always not possible and is probably inferior to a 16 gauge cannula for rapid access and resuscitation. He was hypoxic on presentation, so we give him supplemental oxygen by nasal cannula. And if there is a worsening in the mentation or respiration, we need to consider elective intubation to prevent aspiration. As we all know, his GCS was poor, so he's a prime candidate for aspiration and for airway protection. Hypotension and active bleed should be treated as per the established transfusion guidelines of your institute and by all the societies for gastroenterology and emergency medicine. Avoid over-resuscitation or vigorous resuscitation with saline or over-transfusion in patients with possible variceal bleed, as it can precipitate recurrent variceal hemorrhage and worsen or precipitate ascites or extravascular fluid collection. As per the National Institute of Clinical Excellence, fresh frozen plasma for coagulopathy and platelets for thrombocytopenia or platelet dysfunction is recommended. The risk assessment strategy is a two-step process where you assess the varices and the severity of the variceal bleed. The variceal assessment is done by the presence of established varices, with risk factors for portal hypertension such as proven cirrhosis and chronic liver disease, which this patient has, radiological evidence of a dilated portal vein and splenomegaly, and biochemical findings of hyperammonemia and hypoalbuminemia. The severity assessment is done by the Blushford score and the Rockall score, which we will review shortly. And endoscopy should be done within 24 hours of admission in patients who have a higher risk score. So this is the Blushford score, which predicts the need for endoscopic therapy and is based on readily available clinical and lab data to minimize the delay in prioritizing patients who need endoscopy. So the markers which are used to measure the Blushford score are blood urea, hemoglobin, systolic blood pressure, and common clinical parameters. So based on that, you get a score of up to 2 to 6 in for blood urea, 1 to 6 for hemoglobin, 1 to 3 for systolic blood pressure, and melena, syncope, hepatic disease, and cardiac failure have other scoring systems. So based on this, you can identify anybody who has a score of more than 6 is a patient for immediate endoscopy. The other Rockall score is something that is measured after endoscopy. So you look at the age of the patient, you look at whether the patient has shock, you look at the comorbidities and endoscopic signs of bleeding, and and what is your diagnosis. And based on that, you score the patient. So those who have a higher Rockall score will have prolonged hospital stay and a higher in-hospital mortality. Another score that is commonly used for the scoring of these patients who have a GI bleed is the AIMS 65 score, which looks at albumin, INR, mental status, systolic blood pressure, and age of the patient. If the albumin is less than 3 grams and INR greater than 1.5, altered mental status, systolic blood pressure of 90 millimeters mercury or less, and age more than 65. These are the criteria scored in the AIM 65 score. And if there are 4 risk factors like our patient, there is a 15% chance of in-hospital mortality. If all the 5 risk factors are present, there is a 25% chance of in-hospital mortality. So how do you initially evaluate and manage a patient with upper GI bleed? So first you need to identify whether the source of the bleed is from an upper GI or a lower GI. In this particular patient, there is no controversy. He's had varices in the past, so you can assume this blood from the varices, but you need to make this difference in de novo patients who presents to your ICU or to your emergency room. So hematemesis is almost certainly due to upper GI source and very rarely due to a lower GI source. Melena is most often due to upper GI source, although it can happen with lower GI in some small percentage of patients. Massive GI, upper GI bleed can also cause hematochezia, but whereas lower GI sources are usually present with hematochezia. Blood streak stools are rare with upper GI bleed, and it's almost certainly if you have a blood streak stool, it's from the lower GI. Occult blood is possible with either bleeds. Most commonly, it is the upper GI. So this patient presented to us with a low systolic blood pressure and altered mentation, so he's probably in shock. So the next question that's usually asked in most exams when patients with a blood loss present in shock is how do you classify shock? This classic classification taken from trauma studies and trauma training equates the class of shock with the amount of blood loss and the amount of fluid you require for resuscitation and the type of fluid you require for resuscitation. So if you lose up to 750 ml of blood, you would have about 15% loss of blood volume with tachycardia, but preserved urine output and normal mental status, and only crystalloids are required. Taking it all the way to the class 4 shock where more than 2 liters of blood, which is 40% of the blood volume, is lost, where there is mentation obtunded, and you need to give crystalloids and blood for these patients. Having known this patient and having scheduled him for endoscopy, what investigations would you order? Needless to say, we look at the complete blood count to look at the hemoglobin, the platelets, and what form of leukocytosis he has, liver function tests, serum chemistries that include sodium and potassium, coagulation profile, the ECG, the elderly especially, and cardiac enzymes, because hypotension can trigger myocardial ischemia, a peripheral smear to see whether there are any evidence of hemolysis or evidence of toxic granules, and blood urea nitrogen to creatinine ratio and urea to creatinine ratio to differentiate whether the urea rise is due to GI bleed or due to renal hypoperfusion. What options do you have to avail to stop the upper GI bleed? We have intravenous proton pump inhibitors. We have prokinetic agents like macrolides, like erythromycin given at a dose of 3 milligram per kg prior to endoscopy. But be careful about giving this to this particular patient, an elderly man who's hypoxic, hypothermic, and acidotic, and having coronary artery disease is not the right candidate for giving a drug which can prolong the QT interval. Vasoactive medications like somatostatin, 250 mics per hour, octreotide, 50 mics bolus followed by 50 mics per hour infusion, terlipressin, 2 milligrams every 4 hours during the first 4 hours, followed by 1 milligram every 4 hours. Cirrhotic patients benefit with the use of prophylactic antibiotics, a second or third generation cephalosporin would suffice. There is no role for tranexamic acid or recombinant factor 7A in the treatment of upper GI bleeding. Endoscopy should be carried out within 24 hours of presentation to determine the cause and initiate early therapeutic interventions. And endoscopic options for variceal bleeding include band ligation, sclerotherapy, Sengstake and Blakemore or the balloon tamponade, and self-extending metal stent for the esophagus if the extensive varices are noted. Endoscopic therapies for non-variceal upper GI bleed comprise therapy or injection of adrenaline into and around the point of bleeding, thermal treatment, and mechanical adjuncts like endoclip or hemospray or hemoclips. After endoscopy, you need to look after this patient as well. So how do you look after this patient after endoscopy? Terlipressin is a drug we can use. It's a synthetic analog of vasopressin that has a longer biological activity and significantly fewer side effects. And it is recommended to continue until the certainty of hemostasis or up to 5 days at a dose of 1 to 2 milligrams IV every 4 hours. Non-selective beta blockers, within 6 weeks, the risk of rebleeding is about 15 to 30%. So recent guidelines recommend the use of propranolol or nadolol for secondary prevention of variceal bleeding with carvedilol as an alternative. In patients, variceal band ligation should be offered, and patients should be scheduled for elective repeat endoscopy 2 to 4 weeks after the variceal hemorrhage until the eradication of varices. And a transfusion trigger of 7 to 8 grams per deciliter is recommended for the transfusion of these patients. So I'll just share with you a video of the insertion of the Sengsteken Blakemore tube, which is a life-saving device. If you can learn how to put it, it's fairly simple, although a little bit of caution is needed in inflating the tube. You need to take an informed consent for doing this because it's an invasive procedure. Patients would require intubation, and the equipment you need for this would be a saline bottle of a liter or 2 liter bottle, a xylocaine, syringes, a sphygmomanometer, a Sengsteken Blakemore tube, the kidney tray, and 3-way connectors. Before you insert it, you need to test the balloon. There are two ports, as you can see. The white one fills the gastric balloon, which is now being inflated and has a capacity of about 200 ml of air. The red one inflates the esophageal balloon, which can take up to 60 ml of air, but you generally inflate 25 to 30 ml of air for the tamponade effect. So this is how it is tested for any leaks, and then you insert the tube after thorough lubrication. Because it's a bigger tube, you could traumatize the nasal passages, and this is how it is introduced through like a nasogastric tube. You introduce it and you start aspirating it. And once you know that the tip of the tube is in the stomach, you can look at ultrasound also, and you can see the position of the tube. And then you inflate the gastric balloon first. You aspirate and see what's coming out. Gastric contents or blood would be what you would get. You inflate the gastric balloon, put a 3-way connector, inflate it, and then fix it. Inflation of air 20 to 50 ml for checking the position, and then inflate furthermore once the position is confirmed. Lock it and retract the tube back so that the traction is held at the gastroesophageal junction. Then you inflate the gastric balloon, followed by the esophageal balloon. The esophageal balloon, you insert about 15 to 20 mils of air and then test the pressure in that by connecting it to a manometer. So that's how it looks like. So you pull it back and wedge it against the gastroesophageal junction, and then you check the position again. This is a temporary measure. If the bleeding stops, then you check. You need not inflate the esophageal balloon in all patients. If the gastric balloon is sufficient to stop the bleeding, that means the patient is bleeding from gastroesophageal varices. And you check the pressure by disconnecting the mercury bulb and connecting it to the port, the 3-way cannula, and you should be able to see the mercury rise. 20 to 45 millimeters of mercury is what rises. So you can see the mercury bulb, the column rising on the sphygmomanometer. This is a very simple way of checking the pressure, but you don't remove the nasogastric tube, you retain the nasogastric tube as well. Although you can aspirate, but you don't do it through the Sengsteken tube for the fear of dislodging it. If a patient is mechanically ventilated, orogastric tube can be inserted, and you apply the traction connecting the saline bottle as the weight we put for skin traction. And a chest X-ray is recommended to look at the position of the balloon. So what is the role of interventional radiology in the management of upper GI bleed? Mainly two: transjugular intrahepatic portosystemic shunt, that is TIPS, and balloon occluded retrograde transvenous obliteration. The aim of TIPS is to reduce the portal pressure by creating a portosystemic shunt across the liver parenchyma, but it is contraindicated in primary prevention and those patients who have hepatopulmonary syndrome. and in child cirrhosis as well. The BRTO is a relatively newer radiological technique used for the management of gastric varices with large gastrosystemic shunts, mainly gastrorenal shunts, with the aim to obliterate the varices and their feeding shunts. Is there a role for non-selective beta blockers in the presence of varices and varicose bleed? Yes, carvedilol, nadolol, and propranolol have all been used in the doses which are being shown on the screen, but careful monitoring of blood pressure and heart rate and ECGs in elderly individuals are recommended with the use of these beta blockers. After the bleeding has stopped, after it was stopped once, and if the patient bleeds again, what do? Again, you go for the non-selective beta blockers, do an endoscopy, do variceal ligation, which may be superior to sclerotherapy, and repeat it every week to every 4 weeks. And you should consider these patients for portocaval shunt surgery or transjugular intrahepatic portosystemic shunt. So that, friends, in brief, is about the management of upper GI bleed, which usually is presented in most exams. And I wish you all the best for your exams for the future. Be safe and see you again.
So, do we have any questions?
So I can't see any questions here in the chat box. Okay, so till we get some questions, Dr. Srinivas, so the role of resuscitation while the patient is being, awaiting the scopy. Uh, can you shed some light on that?
Yes. So any patient with hemorrhagic shock.
Srinivas, you're muted. You're muted.
No, my mic is unmuted on my system. I think the administrator has to.
Srinivas, you're not audible properly.
Audible, sir.
Can you hear me now?
Yes, sir.
But Sheil is not able to hear me actually.
Neil, we can hear Dr. Srinivas. The voice is little low, but we can hear him.
Yeah, go on, Srinivas.
The resuscitation remains the same as any hemorrhagic shock. The 1:1:1 rule or the 1:1:2 rule for resuscitation, especially for these patients, has to be considered, especially since they are coagulopathic and thrombocytopenic most of the time. So these patients have a higher chance of transfusion associated circulatory overload from several points of view. One, they may have a hepatopulmonary syndrome. They usually are hypoalbuminemic and they have compromised renal function. So it is also important to monitor their hemodynamic status. If the patient is invasively ventilated, any of the dynamic tools may suffice to look at the hemodynamic tools. But all this has to be done while organizing for an endoscopy.
Okay, we have a question in the chat box. It says, how frequently do we need to deflate the esophageal and the gastric tubes?
Yeah, so the gastric balloon need not be deflated very frequently, but at least every 12 hours we need to look at the gastric balloon after releasing the traction. Otherwise, this tube will slip out. Whereas the esophageal balloon may have to be deflated every 6 hours to ensure that it does not necrose. The chances of esophageal necrosis following balloon tamponade It is especially higher in those patients who have previously undergone variceal sclerotherapy for the esophageal varices. So, if that's precisely the reason why first the gastric balloon is inflated, and then if that stops the bleeding, you don't inflate the esophageal balloon at all. But if that doesn't stop the bleeding, that's the time when you inflate the esophageal balloon with monitoring of the manometric pressure. But you need to deflate it every 6 hours and leave it off for an hour or so, and then re-inflate it to prevent necrosis of the esophagus.
So, Srinivas, with this Sandsticker Blackmore tube, you don't have a port for aspiration above the gastric balloon, right?
No, sir.
So, how do you know that the bleeding has stopped?
So,
if it's esophageal part of the varices that is bleeding.
So, with the hemodynamic instability of the patient, if it continues, if the patient is actually bleeding from the esophagus, it would regurgitate. So if the patient is actually it is welling out of the oral cavity, that means the esophageal varices are bleeding.
Then you inflate the esophageal balloon.
Yeah.
And so most patients will be intubated, right?
It is advisable now in the current recommendation for the use of the SB tube. It is recommended that all patients who are candidates for the SB tube should be intubated to prevent to minimize the risk of aspiration.
Dr. Srinivas, this tube doesn't have a lumen inside for you can't use it like a RT, right? You have to
You can use it as an RT, but the thing is that is more used for aspiration to see what is there in the stomach contents. You can't use it as a feeding. You can use it. It has a opening at the end which can be used for aspiration, and you can use it for feeding. But the purpose of that lumen is actually to aspirate the gastric contents and see what is in it.
So you recommend putting a separate Raj tube?
Yeah, orogastric tube preferably. Yeah.
So there will be there is a tube available, isn't it? 4 lumen, which has got a.
That's the Minnesota tube. It's a quad lumen tube which has 4 lumens, one for aspiration and one for enteral nutrition.
There is another question of role of pantoprazole infusion.
Yeah, so pantoprazole infusion, see, the hypothesis from most of the endoscopy societies and gastroenterology societies is that the most common cause of a GI bleed, even in a proven cirrhotic, is ulcer bleed. It's not a variceal bleed. That's the first point. Second, it is also possible that both the diseases are concurrently running. That means somebody is bleeding from the varices, and because of the mucosal ischemia, some ulcer is also bleeding. So it makes sense before an endoscopic therapy has been given to the patient, pantoprazole infusion is run on patients with any GI bleed. However, in patients who have non-variceal upper GI bleed, it is recommended that an infusion of pantoprazole be run for at least 48 hours and not later than 96 hours. At the end of 96 hours, you need to be reviewing the need for a pantoprazole infusion in all patients who have got this modality. But a note of caution, pantoprazole is also an azole. So it has got a lot of interactions with some of the other drugs which you use in the intensive care unit, like amiodarone, for example, macrolides, for example, quinolones, for example, and it also has a potential for triggering arrhythmias. So in an elderly hypoxic hypotensive patient with ECG changes, you should be more careful when you are running a pantoprazole infusion.
Dr. Srinivas, when you are giving pantoprazole infusion, do you frequently monitor gastric pH?
No, I haven't done it so far.
I don't think it is recommended also, is it?
It won't make a difference to the management because here it is the mucosal pH which we are looking at, not the intragastric pH.
So there's the next question. How long do we use PPI or octreotide infusions to be continued in ACS patients with dual antiplatelets upper GI bleed?
So if the patient has an ongoing acute coronary syndrome, it is understood that you are going to take him for a intervention. So 24 hours after the intervention is when you should be continuing the octreotide infusion if you are attempting a definitive therapy. However, if the patient is for a conservative management and ongoing ischemia, you may have to prefer octreotide in preference to somatostatin. So the other question I can see on the panel on the chat box is, do we need to start broad spectrum antibiotics in all patients with upper GI bleed, especially in cirrhosis? It is a debatable point, but it is recommended since you are intubating these patients and you are doing endoscopic procedures and there is a lot of injection therapy that's going on. It makes sense in having some kind of prophylactic antibiotic going on in these patients, but you should stick to the definition of prophylaxis. If you have actually finished the procedure, the bleed is under control, after 24 hours, you need to review your antibiotic prescription. How long can we keep the Sengstake and Blakemore tube in the scenario of massive GI bleed? Until you can offer definitive therapy, which is endoscopy. If the center does not have endoscopic facility, as soon as the patient is hemodynamically stable and is in a position to be transferred across to the nearest endoscopy capable center, you need to send them across, because the standard of care for GI bleed is no longer conservative, it is intervention based. And of course, you can't keep the esophageal balloon at a time inflated for longer than 6 hours, as I've already mentioned. Do you recommend putting nasogastric tube in patients with suspected varices where there can be delay? See, if the patient is dropping his blood pressure or he's not maintaining his hemoglobin, it makes sense for you to understand what quantum of blood loss which he is having. So probably yes, you would need a nasogastric tube, but some of the gastroenterologists would be upset if you try to poke a nasogastric tube into somebody who's already bleeding.
Right. I don't see any more questions. Thank you, Srinivas. We will take a short 10 minutes break before we start the next session. Next session is by Dr. Dilip Karnar, who will be speaking on preeclampsia. So uh, take a quick 10 minutes break and we will join back at 20 past 2. So we have a 10 minutes break. Rohit, you can keep the timer on so that we know the delegates would know when to come back.
Okay, sir.
Thank you.
Rohit, can we play those study material and those things, the presentation?
Okay, sir.
Okay, sir. Okay.
Yeah. So keep that on a loop and contact Dr. Papadia also, because his talk was supposed to be at 4, isn't it? So
Yes, sir.
yeah, so it'll be much earlier than that. So maybe we need to
Okay,
take.
sir.
And you
Okay,
got
sir.
Dr. Rahul Pandit's video?
Yes, sir.
All right, great. See you in 10 minutes.
Hello. So welcome back for the final section of the day. For this, I would like to invite Dr. Dilip Karnad. We know Dr. Dilip Karnad is a senior professor and head critical care department of critical care medicine at Jupiter Hospital. And he will be speaking on eclampsia and cerebrovenous thrombosis. Over to you, sir. Rohit, I think sir is muted yet. Rohit,
Sir, we are requested to.
Yes, sir.
I think sir is muted yet.
Sir, I will
I'm not.
call.
Yeah, I'm not able to see his screen.
I'm just now here. He was there. I saw him just now.
Yes, sir, he's there, sir. He's logged in, but his screen is not seen yet.
Okay.
Yeah. Um, Over to you, sir. Yeah.
So shall I start?
Yeah, sir. You can go ahead.
I'm just trying to share the screen.
Yes, sir.
Can you see it?
Not yet, sir.
Okay, just.
Yes, now we can.
Yeah, okay. So okay, so we'll start with the obstetric critical care case. This is a 24-year-old primiparous woman who had a normal antenatal history. She was shifted to ICU for sudden onset of convulsions at 36 weeks of pregnancy. The past medical history was uneventful, and on examination, she was in a post-ictal state but was conscious oriented, followed commands, did not have any focal neurological deficit. The only notable examination finding was a blood pressure of 170 by 110 millimeters of mercury. The rest of the examination was unremarkable. So basically, what is your diagnosis? What investigations will you do in this patient? So that's the routine labs which we got for this patient. Hemoglobin was 11. The platelets were 150,000, which is just at the lower limit of normal range. There was leukocytosis. BU and creatinine were elevated. It's important to realize that even a normal creatinine in a pregnant patient towards term can be actually high for that patient, because as the pregnancy progresses, the GFR increases and the serum creatinine is actually at the lower limit of normal or sometimes even below that. This patient also had a mildly elevated bilirubin with liver enzymes also being elevated around 8 times the upper limit of normal. The partial thromboplastin time, the APTT was prolonged, but the PT was normal. Uric acid was raised, and the CT brain was done because of the seizure, and we'll discuss that later. So what is the most likely diagnosis, and can you list the differential diagnosis for this patient? So this would be a sort of comprehensive list of the diagnosis. So typically we think of two groups of disorders. One is disorders which are specific for pregnancy, which happen only in pregnancy. And the other is medical disorders which can happen in pregnant as well as non-pregnant women. Many of them may be pre-existing, some of them may appear for the first time. So the first diagnosis in this patient would be eclampsia. Eclampsia is basically preeclampsia plus seizure. So because of hypertension and seizure, this patient would be diagnosed as eclampsia. The other is epilepsy. So epilepsy is one of those which is unrelated to pregnancy. Seizures could be due to metabolic derangements or due to CNS infection. Intracranial vascular lesions, for example, intracranial bleed. So that could happen as a result of hypertension, and it's an important cause which has to be ruled out. So that's the reason for doing the CT scan. Similarly, it could be either cortical venous thrombosis or cerebral venous sinus thrombosis. Unrelated could be a brain tumor. And lastly, this patient could be having pre-existing SLE, which was not diagnosed, but which can flare up in some patients during pregnancy. So the hypertension and seizure could be a manifestation of SLE. So there are these two publications of critical illness in pregnancy, part 1 and part 2. They are a good review of almost all the conditions which you can encounter in pregnancy, which are significant. And most importantly, in part 1, there is this 5-step approach to a critically ill pregnant patient. So if you sort of go over this in any pregnant patient coming to the ICU, it will make it reasonably easy to manage the patient and ensure that you don't miss out anything. So the first step is like, is this a medical disorder or an obstetric disorder? So the reason is because many obstetric disorders mimic medical disorders. To give you a couple of examples, so in this patient, if this patient has thrombocytopenia, marginally raised creatinine, hypertension, and seizure, urine shows proteinuria. This could be preeclampsia or eclampsia. At the same time, it could also be SLE. All the things which I told you also occur in a patient with SLE with flare of the disease, right? That's important because the treatment of these two is completely different. Specific treatment of many medical disorders will help in improving the patient's condition. Only notably, drug of choice may differ in pregnancy. The on the other hand, if it's an obstetric disorder like preeclampsia or eclampsia, then this problem can actually be an indication for urgent delivery, right? So urgent deliveries help in many obstetric disorders, but there are only a handful of medical disorders where urgent delivery is needed. The next thing is there multiple organ failure? So almost all patients will have 2 or 3 organs failing. So kidney injury, thrombocytopenia, coagulopathy are the commonest. So which you can see all 3 were there in our patient. A prolonged APTT, platelets of 1,50,000, creat was raised, liver enzymes were elevated. So that's important. The next is there risk to the mother or the fetus in the pregnancy being continued? That's the next question. Then fourth step is to ask yourself, is delivery to be hastened? And if yes, then whether it's a vaginal delivery or whether it's a cesarean section. And then the next corollary to that is what type of anesthesia would be preferred, right? And if it's decided to go in for a delivery, then we need to optimize this patient before delivery. So these 5 steps would be very useful. So let's continue with this patient. So if we look at this patient as a patient who has hypertension with seizures, what are the various hypertensive disorders that are seen in pregnancy? So first is chronic hypertension. So this is hypertension that exists before the pregnancy occurred. Then there is gestational hypertension. Gestational hypertension is hypertension that develops during pregnancy. Okay, but there is no proteinuria or organ dysfunction. So if your patient has only hypertension, which was not there before the patient conceived, that is gestational hypertension. Next is preeclampsia. So preeclampsia is a normal BP before 20 weeks of pregnancy and hypertension after 20 weeks of pregnancy. So the question is, what if your patient had hypertension in the 12th week of pregnancy? So this would be classified as gestational hypertension. Preeclampsia specifically is new onset hypertension after 20 weeks. That does not mean that gestational hypertension or chronic hypertension patient cannot get preeclampsia, right? But you diagnose preeclampsia only after 20 weeks. And the differentiating feature between chronic or gestational hypertension and preeclampsia is the presence of proteinuria, which is more than 300 milligrams per day. So next question is like, what are the criteria for severe preeclampsia? So this is a definition from the American College of Obstetrics and Gynecology Task Force. So systolic BP more than 160 or diastolic pressure more than 110 on 2 occasions at least 4 hours apart. Okay. And when the patient is not on any antihypertensive therapy. Then the presence of thrombocytopenia. So even 140/90 with thrombocytopenia would be classified as severe preeclampsia. So hypertension more than 160, 110 by itself is a single criterion which classifies the hypertension as preeclampsia. Then impaired liver function tests, which our patient had, progressive renal insufficiency, serum creatinine concentration more than 1.1. Okay, that's because as I discussed with you, creatinine drops during normal pregnancy, or a doubling of serum creatinine in the absence of other renal disease, pulmonary edema, and cerebral or visual disturbances. And lastly, preeclampsia plus seizures is defined as eclampsia. So if we look at the pathophysiology of hypertension in pregnancy, these are various statistics which are there that 22% of hypertensive patients encountered in pregnancy have chronic hypertension. The rest will have gestational hypertension. Hypertension is closely associated with placental dysfunction by mechanisms which are still not very clear. Both hypertension as well as the placental dysfunction give rise to release of certain toxic cytokines or other endogenous compounds, which will mediate tissue damage, which leads to the proteinuria. And this usually happens after 20 weeks. So in the placenta, there can be various complications like placental infarction, retroplacental bleed, or placental abruption. So these are encountered commonly in hypertensive patients. Because of the severe hypertension itself, you can get various complications like intracranial hemorrhage, left ventricular failure, or hypertensive encephalopathy. And lastly, because of the tissue dysfunction as well as changes related to hypertension, you can get organ dysfunction. So in the kidneys, you get proteinuria, acute tubular necrosis. In some severe cases, acute cortical necrosis. In CNS, you can get cerebral edema, which is often seen on a scan as PRESS or posterior reversible edema syndrome. Okay, there is you can get seizures, cortical blindness, you can get retinal changes on examination of the fundus, liver dysfunction, coagulation, abnormalities, and in a few patients, respiratory involvement with ARDS. What level of blood pressure should be treated? So basically, if the blood pressure exceeds 160 by 110, there is a risk of intracranial hemorrhage or left ventricular failure. So any BP more than 160 by 110 has to be treated. At the same time, this hypertension is supposed to be an adaptive change to placental insufficiency. So because there's decreased perfusion of the placenta, the BP rises in order to increase the placental perfusion or the uterine perfusion. So if you bring the BP much below 140/90, then that increases the fetal risk. So there is a risk of intrauterine growth restriction or stillbirth. So the aim is to keep the BP between 160 and 140 systolic and 110 and 90 diastolic. Does the maternal risk of complications decrease if the BP is controlled? So the answer is that only the risk of intracranial hemorrhage decreases. Okay, so even if the BP is well controlled, this does not decrease the risk of the patient developing preeclampsia. That means organ dysfunction in addition to the hypertension, right? So remember, controlled or uncontrolled BP does not change the course of hypertension in pregnancy to the extent that it does not reduce the risk of the patient getting preeclampsia with involvement of the liver or thrombocytopenia or renal dysfunction. What are the drugs that are used for treatment of hypertension in pregnancy? So if we look at the outpatient treatment, this is not directly relevant to critical care, but these are the common drugs which are safe to use in pregnancy: methyl-dopa, labetalol, hydralazine, and nifedipine. Certain drugs are contraindicated, so angiotensin receptor blockers and renin inhibitors and ACE inhibitors are contraindicated because in the first half of pregnancy, they can cause increased risk of cardiovascular and CNS abnormalities. If given in the second half of pregnancy, they affect fetal renal dysfunction and cause oligohydramnios. What are the drugs used for emergency treatment of hypertension in pregnancy? So the most commonly used drug is labetalol. It's to be given as a bolus of 10 to 20 milligrams IV. And you can repeat this every 15 to 20 minutes as needed. Okay. And once you get the BP into the target range, then an infusion is continued at 1 to 2 milligrams per minute. So this is considered as the first line agent in pregnancy. It's contraindicated in patients with asthma or congestive heart failure. The other drug which is frequently used injectable is hydralazine. And nifedipine is often given as an oral or a sublingual medication to bring down the BP acutely. Other drugs which can be used are nicardipine, which is not freely available. Nitroglycerin can be used, but its role in reducing hypertension is more limited as compared to labetalol. And lastly, nitroprusside, although it can be used, has a potential of causing cyanide toxicity in the fetus with prolonged use. So it's best to avoid nitroprusside. So discuss the laboratory findings in this patient. So we've already looked at the findings on day 1. Just want to point out a few things in this patient. Let's look at serum uric acid. So in normal pregnancy, there is increase in the total body water. And as a result, the serum uric acid level falls. So most patients, pregnant patients with normal pregnancy have hypouricemia. Okay. It's only in patients who get preeclampsia that they start getting proteinuria. They may have edema, but they have relative hypovolemia. And therefore the uric acid starts rising. So uric acid is a very useful test to differentiate whether a hypertensive patient is chronic hypertension or whether this patient is now progressing towards preeclampsia. If you look at what happened to this patient on day 2, the hemoglobin had dropped from 11 to 8.5. Okay, and this is in the absence of any external blood loss. So obviously, if the hemoglobin drops, what it means is that this patient now has probably hemolysis. So we need to do some tests to confirm whether there is hemolysis. One is to do the LDH levels, and the other is to look at a peripheral smear to see if there are schistocytes or fragmented RBCs. The platelet count has dropped further to 76,000, and the creatinine has started increasing further. Similarly, the liver enzymes are going up further. The coagulation tests, now the PT-INR also has started increasing, right? So what we can see is that this patient's organ dysfunction is gradually now increasing. So this basically tells us that although the blood pressure is controlled because of our IV infusion of antihypertensive medications, it's not enough to say that the BP is good and the patient is not having seizures. We also need to look at all these changes which are taking place. So what is the diagnosis? One is worsening preeclampsia. Second is maybe this patient is just starting to get into the HELP syndrome, that is hemolysis causing drop in hemoglobin, low platelets, and elevated liver enzymes. So one important question is, if a patient comes with preeclampsia but has not had seizures, okay, so then how do we know whether a patient is going to get seizures or not? So typically, these are the risk factors for a seizure. So if a patient has BP more than 160 by 110, if the proteinuria is massive, that is more than 5 grams, if the creatinine is raised, okay, the rest are kind of diagnostic for the preeclampsia. So let's look at what is lower down. So patients who have headache. Okay, so headache would probably imply that this patient is now having cerebral edema. Scotomata. So scotomata means now this is a manifestation of PRES. Since it involves the occipital lobes more, a lot of patients will have visual symptoms. Epigastric pain is a manifestation of liver dysfunction, which is common in these patients. We don't see them in liver dysfunction in non-pregnant patients. Okay, and patients who are obese and have diabetes along with the preeclampsia are at higher risk of seizures. Can we prevent seizures in patients with severe preeclampsia? So there is this large RCT called the MACPIE trial published in the Lancet almost 20 years back, where 10,000 women were randomized into receiving either Maxulf or placebo, and just see what the protocol said, that you treat the patient for 24 hours, right? This 24 hours is basically to optimize the patient for delivery. So what it means is every patient with severe preeclampsia who's admitted, you start them on magnesium infusion, stabilize them, you get up to 24 hours to stabilize, and then go in for an urgent delivery. Okay, so there was a significant reduction in the number of seizures as well as in the mortality, and the number needed to treat, okay, in countries which had a high perinatal mortality rate was much less. That means if a patient is delivering in a very good healthcare setup, okay, then the risk of seizures was less. But even in patients who are delivering, or in other way around, in patients who are delivering in a less than optimal healthcare setup, the benefit was much more if we give magnesium sulfate either as infusion or intramuscular injections. if in case a woman does get seizures with preeclampsia, what is the treatment? So there is this other RCT which was also published in the Lancet, and this was patients who had already had eclampsia and one seizure. Okay, so they were randomized to receive either magnesium sulfate or diazepam or phenytoin. Okay, so there were three groups here. So magnesium sulfate versus diazepam was one group, arm of the trial. Magnesium versus phenytoin was the other arm of the trial. And you can see that in both the arms, the recurrence of seizure was almost 50% of what it was in the other arm. So compared to diazepam as well as phenytoin, giving Maxulf reduced the risk of seizures by 50%. Okay, so how is magnesium sulfate to be administered? So you give a loading dose of 4 to 6 grams over 20 minutes. After that, you follow it up with 1 to 2 grams per hour for 24 hours after the last seizure. If the seizures recur while on infusion, you can give another dose of 2 to 4 grams as a bolus over 10 minutes. There is also an intramuscular regime where you give 10 grams in 5 ml in each butter, and then repeat 5 grams IM every 4 hours. We can monitor the therapeutic levels of the levels of magnesium. And the therapeutic level is 2 to 4 millimoles per liter. Right? Clinical examination, we must look for the ankle jerk and the patellar jerk. So the patellar reflex must be elicitable. The ankle jerk may be absent. So if the patellar jerk is also absent, it means that now you are going above the therapeutic level. Later on, if in very high doses, you also get respiratory depression and arrhythmias. So on the right, there is a table which tells you what are the clinical signs which you get at various levels, right? So remember, the therapeutic level is up to 4, right? And what we are looking at here is that, at 3.5 to 5, the patellar jerk will become absent. At 5 to 6.5, there is respiratory weakness. Above 7.5, there are arrhythmias. Above 12.5, you get cardiac arrest. So in case a patient does have high magnesium, what's the way to treat it? So the antidote is to give 10 ml of 10% calcium gluconate IV. This is specifically useful if the patient has cardiac arrhythmias. So the next question is there a risk to the mother and fetus if pregnancy is continued? So remember, many obstetric disorders improve rapidly after delivery, and that urgent delivery may be life-saving, including in patients with severe preeclampsia and eclampsia. Even if we decide to stabilize the patient for 24 hours, sometimes delivery is required urgently because of fetal distress. Okay, so the risk of urgent delivery to the mother should be balanced against the risk of delaying delivery to the fetus. Okay, and yeah, so the question is, which are the disorders where maternal outcome improves with delivery? So these are a few of them: severe preeclampsia with organ failure, eclampsia, acute fatty liver of pregnancy, HELP syndrome, placental abruption. So these are all obstetric disorders where urgent delivery definitely helps in sort of restricting the progression of the underlying disorder. Other is status epilepticus. In patients with a cardiac arrest, if you don't get, after 24 weeks, if you don't get return of circulation within a certain span of time, then an urgent cesarean section as a part of the CPR also helps. Then severe chorioamnionitis, right? There are other disorders where assisted vaginal delivery is indicated, and that's a list there. So next question is, if patient has to be delivered, is it by vaginal delivery or cesarean section? Okay. So various studies have shown that in critically ill obstetric patients, more than 70% of the deliveries are by cesarean section, right? There is an increased risk of complications with GA in pregnancy, but also neuraxial anesthesia will have its own problems like hypotension, hematoma. So in a patient who is already in shock or has coagulopathy, this is not always possible. That's the reason why GA is preferred, in spite of an increased risk of intubation failure, crowding of the upper airway, and the increased risk of aspiration. So next is optimization of organ functions in time for delivery. So these are some of the steps, so some patients may need endotracheal intubation for airway protection, mechanical seizures, vomiting, respiratory depression, hemodynamic management, seizure control, correction of thrombocytopenia and coagulation. It's good to give the 2 doses of betamethasone or dexamethasone 12 hours apart. This is used to hasten the fetal lung maturity. Any issues relevant in postpartum. So, we need to assess the patient postpartum for abdominal or vaginal bleeding. There could be sepsis, that is puerperal or post-abortal sepsis. Some patients, the obstetrician may have to re-explore the patient for some indications which are listed here. Then there's care of the breast. So this is required to prevent breast abscesses. Obstetric decision is about RH isoimmunization. Medications like Maxulf will have to be continued for at least 24 to 48 hours after delivery. Then DVT prophylaxis and sometimes the use of oxytocin to make the uterus contract. There is an increased thrombotic risk in postpartum period. So the risk of DVT-PE needs to be assessed. Cerebral venous thrombosis could occur. And the last postpartum issue which we may see is if a patient has come in severe antepartum hemorrhage and shock, and you resuscitate the patient is delivered, everything looks good for the next 48 hours. And suddenly there is hypotension, polyuria, hypoglycemia. This could be the acute onset of postpartum pituitary necrosis or Sheehan syndrome. So next couple of slides on cerebral venous thrombosis. So this is a condition which closely mimics eclampsia in the sense that it causes seizures. Okay, and pregnancy and the reason why this occurs is pregnancy and postpartum period is a hypercoagulable state associated with increased clotting factor levels, decrease in protein S level, and inhibited fibrinolytic system. Other factors that increase risk of cerebral venous thrombosis are dehydration during labor and puerperium, maternal age, hyperemesis, again causing dehydration. Interestingly, delivery by cesarean section or presence of preeclampsia also predispose. We think of preeclampsia as a coagulation disorder with increased risk of bleeding, but after delivery, it seems to increase the risk of thrombotic episodes as well. Medical disorders include SLE and antiphospholipid syndrome. Almost 80% of patients with cerebral venous thrombosis, it occurs in the puerperium rather than during the pregnancy itself. And that's the various symptoms which are common: headache, seizures, weakness, papilledema, altered consciousness. In some patients, they only have what is wrongly labeled as benign intracranial hypertension. So if a patient in the postpartum period is labeled as benign intracranial hypertension, very important to rule out intracranial sinus thrombosis. Diagnosis is made by imaging. Contrast CT scan is useful, or MRI or CT venography or cerebral angiography is diagnostic. In terms of treatment, we need to anticoagulate these patients even though they have hemorrhagic infarcts. In those who have a poor level of or GCS less than 8, these patients require in situ thrombolysis done by a interventional neuroradiologist advancing a catheter into the thrombosed superior sagittal sinus and infusion of urokinase in the thrombus itself. Then they also need anticonvulsants, anti-cerebral edema treatment, and as a last resort, decompressive craniotomy. I'm just going to show you some images. So On the left hand side, image A and C are contrast CT scan from a normal person. B and D are the corresponding sections from patients with SSS thrombosis. So you can see filling defects in the upper part of the superior sagittal sinus in picture B. In picture D, the arrow which is there, the black arrow, it's pointing to a classical sign called the empty delta sign. So if you see the picture C, the posterior part of the superior sagittal sinus is filled with contrast. So it looks like a solid white triangle. Whereas on the right side, the margins of the sinus are enhanced by contrast, but the lumen of the sinus is a filling defect which is appearing black. So that's called the empty delta sign. On the right hand side, picture A are of patients with deep cerebral vein thrombosis. So this causes infarctions in the thalamus and the basal ganglia of both sides, which are better seen on picture B, right? And the pictures at the bottom are of a patient showing hemorrhagic venous infarcts, which are often bilateral. So these are images which are quite classical of patients with cerebral venous thrombosis. So that in short is about managing patients with the preeclampsia, hypertensive disorders of pregnancy, and patients with the cerebral venous thrombosis. Thank you.
Thank you, sir, for an excellent talk. We will wait for a few moments for the questions. All the delegates are requested to put their questions on the chat box. Sir, till we have questions from the delegates, can you elaborate a bit on heart failure in pregnancy during the peripartum?
Yeah, okay. So patients can come with heart failure during the peripartum period for variety of reasons. One is some kind of pre-existing heart disease which worsens during pregnancy. So the blood volume keeps on getting expanded during the course of pregnancy. And at the same time, there is also systemic vasodilatation because of the large uterine bed. So kind of compensates, the preload is increased and the afterload is decreased. So this is well compensated. But immediately after delivery, when the uterus empties, so the uterine circulation is now cut off. Suddenly there is an increase in the afterload. And this high preload can now precipitate cardiac failure in a patient who had pre-existing well-compromised cardiac illness. So that is one of the reasons why these patients can develop heart failure in the immediate postpartum period. Later on, many of the patients can actually develop peripartum cardiomyopathy. And this can happen up to like 3 to 6 months postpartum as well. But most of the times it is in the initial few weeks. And it's basically a generalized left ventricular dysfunction, which is seen on echocardiography. And there are some studies now which suggest that these patients should be treated with bromocriptine because it's been implicated in the pathogenesis of this. So, yeah.
Is readily available?
Yeah, bromocriptine is quite readily. It's used by neurologists. So.
I can't see any questions. Sir, till then there are few we know that there is a risk of stroke either in terms of ischemia or bleed, but there are some reversible press syndromes also.
Correct, yeah. So press is basically cerebral edema, and for some reason it occurs in the posterior parts in selected patients. So maybe it's just a variation of hypertensive encephalopathy, where you get cerebral edema. So severe hypertension associated with edema. That's why if you see the diagnosis of severe preeclampsia, there is a lot of weight given to visual symptoms. So these visual symptoms, some of them are because of retinal changes, but a lot of them are related to edema in the occipital lobe, in the posterior part of the brain. So which can cause blurring of vision, which can cause scotomata and so on. So it's it's a reversible thing, as the name itself tells you. So you don't need to treat it, you treat the cause, and the edema disappears over the next couple of days.
Right, sir. We've got a few questions. Though we are worried about the use of anti-epileptics in the pregnancy period, if seizures are, or if there is status epilepticus, what is the modality of treatment apart from magnesium? Which is the best way to treat?
Yeah, so good question. So as I said, the first thing is we use magnesium to prevent a seizure if a patient has not yet had a seizure. The second is if a patient does get a seizure on magnesium infusion, then the recommendation is to give a bolus of 2 grams of magnesium in addition to what is already going on. If the patient still gets another seizure, then we treat it like any other status epilepticus. So we can give this patient phenytoin as well as benzodiazepine. The concern is with giving benzodiazepine before the baby is delivered, because there's a risk that the baby may have respiratory depression if you give benzodiazepine just prior to delivery.
Right. Your thought about mannitol, sir?
Yeah, so if the cerebral edema is very severe for whatever reason, either as part of intracranial hemorrhage as a consequence of hypertension, or if the patient has cerebral venous sinus thrombosis causing raised intracranial pressure, compression of the ventricles, then definitely mannitol is used to reduce cerebral edema. Whether mannitol will help in Press syndrome is not anything which is confirmed, because most of these patients will, although they have edema, they may not necessarily have raised intracranial pressure to the extent that it compromises either cerebral circulation or there is a risk of brain herniation or something. So Press that way is a relatively benign thing, that it causes a lot of symptoms and signs, but it's not like it compromises circulation or there's a risk of herniation of the brain. So I would not give mannitol just for the presence of Press.
Right, sir. We have one. No, we had there, since there was somebody. Dr. Pinky Saha wants to know about bromocriptine and heart failure.
Yeah, so bromocriptine has been shown in some studies to help in patients with the peripartum cardiomyopathy.
Yeah.
So basically, other than that, it's just treatment of, it's like managing any heart failure. But this seems to be helping because there may be some improvement in patients who are treated with bromocriptine.
And one of the differential always comes is about the pituitary apoplexy, sir. Any incidents of, like, is it very common or not so common?
No, it's not so common, but I mentioned that it's one of those things which we can, in my last slide on postpartum complications which can occur. In those who have had severe shock, either antepartum or postpartum hemorrhage, and have been resuscitated from that and are recovering, typically 2-3 days down the line, if you find recurrence of hypotension, especially in combination with hypoglycemia, or bradycardia, so that suggests that this patient is likely to be having Sheehan syndrome or postpartum pituitary necrosis. So the hypoglycemia is related to the adrenal insufficiency, and the bradycardia may be related to the thyroid insufficiency, which will happen, once the pituitary gets infarcted. So
Okay, so one Dr. Arnab Chaudhary wants that he had a young patient postpart had rapid onset altered sensorium with coma. MRI showed extensive brainstem infarct with ectatic vertebral artery. Um, Subsequently, like the APLA was positive with pregnancy, uneventful due to this role of therapeutic heparin in such patients, like APLA-like syndromes.
Yeah, basically it's very likely that this whether this patient had arterial infarcts or whether they were venous infarcts. So if it's venous infarcts, there is a more definite role for heparin. Even in patients with as long as there's no hemorrhagic transformation, it's worth giving heparin to patients because APLA is ultimately a prothrombotic state. And if you don't anticoagulate, there could be thrombosis elsewhere, like a APLA crisis or something like that. So I would definitely anticoagulate a patient who has APLA. The previous question or the question before that is, should this patient have been screened beforehand? You don't screen everybody for antiphospholipid syndrome. Only those who have had previous thrombotic episodes, but a lot of patients who have had previous pregnancy losses, it's because of subclinical APLA or lupus anticoagulant or something. So many obstetricians who treat patients with a bad obstetric history get these tests done either before the patient conceives or even during the antepartum period.
Right, sir. And one final question: role of thrombolysis in ischemic stroke.
Yeah. So if it's a big stroke, then there is a definite role for thrombolysis. So just because the patient is pregnant, it doesn't mean that you don't thrombolize the patient. So it's worth thrombolizing a patient in stroke. The question is whether we do it IV or whether it is intra-arterial. So the risk of any hemorrhage is much more when you do IV thrombolysis. So if you have a setup where you have a interventional neuroradiologist who can do a in situ thrombolysis, intra-arterial thrombolysis, then that would probably be the preferred way of thrombolysis, because the dose which is used for intra-arterial thrombolysis is roughly 1/4 or 1/5 of the IV dose which is given. So the systemic effects are much less. This is specifically if it is close to full-term pregnancy.
Right. Role of MR venography for cerebrovenous thrombosis in the setting of raised creat and risk of contrast.
Yeah, they can do an MR venography even without giving contrast. Just looking at the blood flow. So that is not as good as giving with the contrast, but this would be something which is commonly done if the creatinine is raised.
Are there any different transfusion triggers in pregnancy for C-section?
Transfusion triggers, no, it's the same.
Okay, and sir, last question. One is pulmonary embolism in pregnancy, VQ scan versus CTPA. What is the preference?
CTPA.
Okay, I think that's about it, sir.
Okay.
Great. Thank you so much, sir. It's been an excellent session and quite informative. If there are any further questions, then I'll get back to you on the chat box.
Okay, thank you.
Thank you so much, sir. So we move on. Before we move on to the next session, I would like to remind that all the delegates can take the advantage of pre-booking the infectious diseases in critical care textbook, as well as the case-based review book in critical care medicine at a discounted rate. So for the next talk, I would I take great pleasure in inviting Dr. Farhad Kapadia. He is a senior consultant at Hinduja Hospital, and we've always, um, heard him with great enthusiasm. He will be speaking on the controversies in septic shock and as well as the controversies in fluid management in septic shock. I invite Dr. Farad Kapadia, please. Over to you, sir.
Yeah, I'll just share the screen. 1 second. Yeah, is it on the screen?
Yes, sir, we can see you.
Okay, right. The way I plan to do this, because it's slightly long, so of course we are ahead of time, is I'll finish the fluids part first. I'll take questions on that. Then I'll finish the controversies part, take questions on that. And if there's any time left, we can just look at the controversies which have arisen or in terms of sepsis or been resolved in the COVID era. Okay.
Sounds good.
So I think this is the same talk I gave last time, and it's just slightly updated. The bulk of the talk is going to focus on fluids. So the aim of this talk is obviously to help candidates pass the exams, but that's very superficial. We'd obviously like you to be treating patients well. And to do the above two, we have to learn how to read the literature. And I'm going to hope that by the end of this talk, an important part of being a clinician is finding answers to good clinical questions and finding correct clinical questions. Okay. So when it comes to fluids and sepsis, we have 3-4 issues to deal with. Which fluid? How should we monitor the fluids? When do we switch to inotropes? And what are the controversies which persist? It's been an interesting journey for me. I've now been sort of practicing for 30 years. And if I'd had to give this talk 20 years ago, it would have been a very, very different talk from what I'm giving today. Because till about 2020, almost all talks on fluids were based on physiological principles. And we would figure out that we know the physiology, and based on the physiology, which is a good fluid or a bad fluid. And the debates that time were, should we use crystalloid solutions? And if we use crystalloid solutions, should we use balanced ones or should we use saline? Or should we use colloid solutions? If we use colloid solutions, should we use albumin, starches, gelatins, other ones? And when do you use blood? Now, in the year 2021, the whole approach is totally different, and the treatment is really based on what the randomized trials have told us. And the randomized trials have been not so interested in physiology as in clinical outcomes. So one way of looking at it is that with the physiological approach, which we were using earlier, looked at vital parameters, hemodynamic parameters, etc. And based on that, we decided how to do things. While the era now, which is based on randomized trials, looks straight at the important outcomes, and based on these outcomes, tells us how we should use our fluids. So a talk in the year 2000 would go something like this. We have to choose between a colloid and a crystalloid. And we know that colloids require much less volume than crystalloids, so about 40%. So if you're giving 500 ml of colloid, you'll end up giving about 1200 ml of crystalloid to achieve the same hemodynamics. And if you give less fluids, you'll have less edema, you'll have better oxygen delivery and consumption. However, you might have allergic reactions. It was acknowledged that the advantage wasn't proven. And the last factor to keep in mind was if the colloid oncotic pressure increased, that actually decreases filtration and can actually contribute to azotemia. So this was the physiological concepts behind choosing between a colloid and a crystalloid. And going solution by solution, 5% dextrose has almost no role in resuscitation because it leaves the circulation almost completely. Normal saline or DNS is a good resuscitation fluid. It could increase the sodium and chloride, and sugar-containing solution should be avoided in patients with neurological injuries. Ringer's lactate, Hartmann's, and other balanced solutions also gave good resuscitation, and they were more metabolically balanced. And hypertonic saline could achieve good resuscitation with relatively small volumes. These were the options in front of us if we wanted to choose a crystalloid for resuscitation. And if we wanted to choose a colloid, the options were either heta or pentastarch, which might be 6 or 10%. And the advantage of this was a very rapid resuscitation and a long half-life. It didn't have many allergic reactions. It didn't have many bleeding or hemostatic effects. As against that, we could use a gelatin solutions, which had, again, a rapid resuscitation, but with a short half-life. So if we anticipated that, say, for example, the person was bleeding and would require blood later, then something with a short half-life is preferable to something with a long half-life, because if the circulation is fully expanded, then giving blood later might cause an overexpanded circulation and all the side effects of that. With the gelatin solutions, the allergic problems were more frequent. Then there was albumin, and albumin came either as a 4.5% solution or a 20% solution. If at all it was used for resuscitation, it was always the 4.5% solution. However, it is costly. It has an intermediate half-life. And in India, at least, it was rarely used as resuscitation fluids. In places like Australia and UK, where it was a natural product of the blood bank, it was used more extensively. And lastly, we had dextran solutions 40 and 70, which can cause clotting or hemostatic disturbances. And for practical purposes, they were rarely used as resuscitation fluids. When they were used, D40 had a relatively short half-life and D70 had a longer half-life. When should we use blood as a resuscitation fluid? Before we use blood, we need to see what are the advantages of not giving blood. So normally if the hemoglobin falls, the tissues do fine, and they do fine because they just increase the extraction of oxygen. So it's a hemoglobin level in itself is not really critical as long as the tissues can extract the oxygen they need. However, if the hemoglobin falls to less than 7, this mechanism alone is not enough and the cardiac output starts increasing to ensure the tissues get as much oxygen as they need. A decreased hemoglobin means a decreased hematocrit, means a decreased viscosity, which means a decreased afterload, so that the cardiac work is actually less in a person with a slight anemia compared to a normal hemoglobin. And this increased cardiac output comes without an increased myocardial cost because the blood is thinner and therefore easier to pump. It may also improve the microcirculation, hemodilution. So there may be an actual physiological benefit in not having a completely normal hemoglobin, but having some degree of dilution. Having said that, you sometimes do need to give blood, and it would be obviously necessary in the patient who's bleeding a lot. Fresh blood for practical purposes was given up more than 20, 30 years ago. Whole blood also for practical purposes given up. In places which didn't have fractionating facilities, whole blood was an option. But in today's world, that's really out of the question because all blood banks have to be licensed very strictly and they have to fractionate. So we give blood and blood products as required. And we need to keep in mind that a massive transfusion itself can increase mortality, though it's probably not as straightforward as sound because almost every condition which requires massive transfusion is in itself a risk to the patient. But the blood transfusion, the associated shock state, the coagulopathies, and the microcirculatory problems or the immune-mediated problems may make a bad situation worse, may make the multi-organ failure worse because of complications of a blood transfusion. So at that point, the year 2000, we really didn't know what was the hemoglobin target we should do. Some people felt we should go for the normal, about 12 to 14. Almost everyone felt we should keep it above 10. And there were a few people who were targeting 7. And in the first 10 or 15 years of ISCCM and my career here, you could almost bet that every conference, every symposium, everything would have some crystalloid versus colloid talk. And I've been on innumerable panels and innumerable debates, and every possible view was presented. And the presenter of that view just assumed that their view was right. So there were a group of people who said, no, you should only use crystalloids and forget about colloids. Other people should use colloids and forget about crystalloids. Some said, no, use colloids first for maybe a liter and then switch to crystalloids, while others said the opposite, start with crystalloids 2 liters and then to maintain it, add colloids later. Some people said, don't do that, give a fixed ratio, give 500 ml of crystalloid and 500 colloid together and see what happens. So clearly there was lots of diverging views, and all this was because we really didn't have good outcome data, which is better, which is not. Also, that was what a talk 20 years ago would have sounded like. Now, luckily, we have more data, and I would just like to put this in perspective. When we do science, we have actually two processes in science. One is called inductive process and one is called deductive process. What we were doing till the year 2000 was really the inductive process. We had concepts in our mind, we had a few observations, and based on that, we would come up with the ideas that this fluid is better or that fluid is not better. However, there is another side of science called the deductive side, which says you have to test whether your ideas or your hypotheses are correct. And the way to test is to first predict what will happen if your ideas are correct, and then test them in the real world. So till 2020, almost all the fluid science was an inductive form of science. And from 2000 to 2020, there's been a large amount of RCTs which have added a deductive component to the science. And we've really grown much wiser because of this. A quick talk by Richard Feynman, and I'll show you how we can apply that to fluids and how we've learned from this. So this is the key to science. So it's a very lovely talk. It's on YouTube, and I recommend everyone see it. In fact, I recommend everyone see it at least once a year to remind us what science is and how we do science. So in general, we look for a new law, or in the case of medicine, a new therapy by the following process. First, we guess, and our guess is a hypothesis. This is a very important step because you have to have your fundamentals clear. Otherwise, your hypothesis will be pretty weak. And if your hypothesis is weak, it's not likely to prove to be accurate in the real world. Then you say, if my hypothesis is correct, what are the consequences? And in medicine, we call these the primary and the secondary outcomes, or the primary or the secondary objectives. So we say that if a hypothesis is correct, this is what we would expect to find. Then you compare the consequence to experience or experiment, which in our case is outcome data. And if the outcome data doesn't match with our predictions, so if it disagrees with experiment, then the guess is wrong. In that simple statement is the key to science. It doesn't matter how beautiful your guess is, how smart you are, or what your name is. If it disagrees with experience, it's wrong, and that's all there is to it. So let's apply this approach to fluids. Okay. So in general, we look for a new law by the following process. So in medicine, let's say we are looking for a therapy, and let's say we are looking for the use of albumin in septic shock, because that's one of the topics. So we make a guess. Our guess is that albumin is a good solution. And this is based on a lot of concepts. We base it on the fact that albumin is a small molecule, and therefore but it's larger than crystalloid, so it won't leak from the circulation. We base it on the fact that because it's a small molecular size, it's got a high oncotic pressure. And because it's got a high oncotic pressure, as per Starling's forces, it will pull fluid into the circulation. Saline does not have this equivalent, so saline will leave the circulation. So on these concepts, we believe that albumin is a better idea than saline as a resuscitation fluid in sepsis. Also, we have some smaller studies which show this benefit. So on the basis of this, we come up with a hypothesis that albumin is an advantageous fluid to saline in sepsis. Then you compute the consequences. So what are the consequences of giving albumin compared to saline? If our hypothesis is correct, we would say that the hypotension would resolve faster because we need less fluid, and there'll be less edema because there'll be less leakage. If that was correct, then the pressure would be better, the renal perfusion would be better, and there'll be less azotemia, and there'll be less edema, so there'll be less pulmonary edema. If that projection was correct, we would require less vasoactive medication, less mechanical ventilation, less renal replacement therapy. And if that was correct, we'd end up with lower mortality. So these were our projections, or these were our hypothesis outcomes. And so therefore we do the experiment, or in our case, we do an RCT. Patients are randomized to receive either saline or albumin, and we document very, very specific things. How long was hypotension, or how much vasopressors were required? How bad were the renal parameters, and how much renal replacement therapy was required? How bad was the ventilation, the lungs, and how much ventilation was required, and what was the mortality? So it's very straightforward, very simple. And then we say, if the result of our experiment disagrees with our predictions, if the incidence of the above parameters, that is hypotension, use of inotropes, renal replacement therapy, ventilation, and mortality are similar in both the groups, we can conclude that our guess that albumin was a better resuscitation fluid than saline was wrong. And really, that's pretty much all there is to it. After this, you can argue how much you want, that you've used loads of albumin and you've seen this and you've got that logic. Once it failed the test of an RCT, you have to gracefully accept that your hypothesis that albumin was a better resuscitation fluid than saline was wrong. Okay, so this is the sort of deductive approach to science. And as I said, in the last 20 years, we've got this huge number of trials, and we need to know these trials because they are giving us information on how to use fluids when we resuscitate septic patients. So the trial, and especially for those of you who are going for exams, I would expect you all, if I was an examiner, I expect you all to know all these trials, at least know the names of the trials and know roughly what they show. So the trials we're going to look at are called SAFE, FEAST, Christmas, Success, CHEST, Crystal, Albios, Split, Salted, and SMART. Okay. SAFE was the first one. It was in 2004. They compared saline to albumin as a resuscitation fluid in ICUs in Australia, and they found that all the parameters were exactly the same. So this was the first time we really showed that albumin both was safe, because there was some question of whether it was safe or not, and albumin was ineffective compared to saline, or it was as effective as saline. Then a small study called the Christmas study came, showing that using hydroxyethyl starch, we could quickly stabilize patients with septic shock using relatively smaller volumes, and we didn't seem to have too many adverse side effects. And so this is the SAFE study. As you can see, all the primary parameters and all the mortality was the same. What the SAFE study did also is it blew one myth out of the window. We were always told that we need, just 40% of colloids compared to crystalloids. But in the SAFE study, to achieve the same degree of resuscitation, on day one, it was just 1:1.3, on day two, 1:1.6, on day three, 1:1.3, on day four, 1:1.2. So for every liter of colloid, one needed 1,200 ml or 1,300 ml of crystalloid. This 40% was a vast exaggeration when it was tested in this trial. Then came the 6S trial. 6S's were 6S's in the name, Scandinavian Starch Trial for Severe Sepsis and Septic Shock. Okay, 800 odd patients, two groups. One group got 6% HES in ringers and the other group got ringers. They looked at mortality and renal dysfunction. And to their surprise, well, I don't know if they're surprised, but what they found is that the patients on the ringers, ringers, that is the crystalloid group, had a better survival compared to the patients in the colloid group. And in terms of renal replacement also, the amount of people requiring dialysis was less. So what we had is a very, very clear benefit of not using hydroxyethyl starch, at least in this group of patients with severe sepsis. And this was their conclusion, that it increased the risk of death and increased renal replacement therapy. After that came the chest trial. It just came out a few months later, if I'm not mistaken. And again, it looked at almost the same thing. It looked at the HES, this time it was in saline versus saline alone. And this was again done in ANZIX. And here they didn't find any mortality difference. The mortality was almost identical. But the main difference between these two trials is that in this trial, you can see that the mortality was just about 10%, while in this trial, you can see the mortality was close to sort of 50%. So it was obvious that the first study was dealing with much sicker patients than the second study. However, even in the chest trial, the renal, the azotemia was worse with HES, the urine output was worse, and the need of renal replacement therapy was higher. Though this was just about statistically significant. So they came to the conclusion that there was no difference in 90-day mortality. However, people who received resuscitation with HES were more likely to be treated with renal replacement therapy. The main difference in the outcomes of these two trials was because they looked at different patients. It's worth keeping in mind the following thing, that if you test a trial in a group of patients who almost everyone is going to survive, then you're unlikely to show a benefit. Similarly, if you test a therapy in a cohort of patients when almost everyone is going to die, you're unlikely to show a benefit. Benefit is normally best seen in the patients who are moderately sick, and therefore your intervention can actually switch the balance from increased risk of death to decreased risk of death. If there was already a low risk of death, you're less likely to show a benefit. If there's already a very, very high risk of death, you're less likely to show a benefit. So the pendulum was clearly swinging away from colloids, especially hydroxyethyl starch. And then came this trial, which sort of muddied the picture a bit. This was a much more pragmatic trial. It was also not a very clean trial. Basically, this trial told clinicians, you can use any crystalloid you want, you can use any colloid you want, you can use it by any formulation you want, but just use either colloids in those randomized to colloids or use crystalloids in those randomized to crystalloids. And in this trial, at least till 28 days, there was no major significant difference in the mortality, but the colloid group was doing better than the crystalloid group. But when they were followed up to 90 days, the colloid groups had a significantly lower mortality. So their conclusion was, among ICU patients with hypovolemia, the use of colloids did not result in a significant decrease in 28-day mortality. However, the 98-day mortality was lower among patients receiving colloids. Since this was a secondary endpoint, they have labeled this as a negative study. But I think this is a very useful observation that in the long term, colloids could be better in some patients. Okay. So those are the main crystalloid versus colloid trials. A later trial called the Albios trial, looked at the use of albumin, but this trial was not really as a resuscitation fluid. Patients who were already well resuscitated were then, and who had a low albumin, were then randomized either to receive albumin or not. And in that context, correcting hypoalbuminemia after resuscitation, replacing the albumin made absolutely no difference to any outcome, primary or secondary. Some meta-analysis of these trials have been done, and some are negative and some are positive. So that is where we are in terms of the trials which are comparing colloids to crystalloids. The next problem we had to deal with, should we use saline or should we use balanced fluids? The first trial which looked at this was called the SPLIT study. This was a quasi-randomized study. By quasi-randomized, I mean each patient wasn't randomized, but ICUs were randomized. So for example, let us say that Hinduja was taking part in this trial, and let's say Tata was taking part in this trial. At the toss of a coin, we would be told, for this week, all your patients who enroll in the trial, resuscitate them with saline and continue resuscitating saline till they get discharged. And Tata would be told to use a balanced solution. 1 week later, we would switch. Okay, so that was the way it was sort of quasi-randomized. And in this trial, the use of a buffered crystalloid did not reduce the risk of renal injury. Then came a nice bigger trial called the SMART trial. And this was used in ICUs in critically ill patients. And when they had a composite outcome of death, renal dysfunction, or renal replacement therapy, then the group which got balanced solutions did better than the group which got saline. And the third trial was the SALTED trial. This was in non-critically ill patients in the emergency department. And in this group, which was obviously less likely to die than the ICU patients, it didn't matter which fluid group you treated, they both had roughly the same outcomes. So these are the studies we need to be aware of in terms of how to choose a fluid. Now, the next thing is, when we choose a fluid, how do we monitor how much to give and how much not to give? So we have all our standard parameters, CVP, blood pressure, heart rate. We have our perfusion parameters, the urine output, the mentation, the lactate, the SvO2. We have, if we are measuring the cardiac output, we can directly measure what's happening. Is the cardiac output going up? Is the stroke volume going up? Or we can look at the various parameters, which are so-called dynamic parameters, whether the arterial pulse is varying with respiration, the venous pulses are varying with respiration. And so we can look at the IVC diameter, the SVC diameter. We can look at the stroke volume variation, the pulse pressure variation. However, most of these have been validated in paralyzed ventilated patients, and many of them were done in the era before low tidal volume. So it's a little unclear exactly how much we should believe this. And a very elegant study done in Tata Hospital showed that you can do a tidal volume challenge. Make a slight increase in the tidal volume from 6 ml per kg to 8 ml per kg and see if the pulse volume variation increases. And if it increases, it suggests that patient is probably fluid responsive. An earlier thing was called the rule of 3 to 7. That was in the era when everyone used Swan-Ganz catheters. So you're giving fluids and every 10 minutes you make a measurement. And if the wedge went up by 3 or less, then the idea was to continue the infusion. If the wedge went up from 3 to 7, the idea was to stop the infusion, see where you are after 10 minutes, and if necessary, restart it. And if the wedge went up by more than 7, you're supposed to stop it. And then this rule was modified to the 2 by 5 rule for CVP, again with the same thing. You give fluids after 10 minutes, the CVP hasn't gone up by more than 2, continue them. If the CVP has gone up by 2 to 5, you stop it and review after 10 minutes. And if it's gone up by more than 5, you need to stop it. Now, I don't know too many people who actually follow this, but in a crude way, this is what we do. We give fluids, we see what happens. We look at the patient and we decide whether to give more, whether to stop it. And if we stop it, we have to decide whether to restart it or not. So this was a sort of old rule, which I'm not sure anyone really follows anymore. Then we have the fluid challenge and the passive leg raising test. So this is called the modified fluid challenge. I'm not a great fan of the fluid challenge, though I'm in a bit of a minority there. So if you believe in the fluid challenge, then what you do is you give a prescription. I'm going to try so much fluid. I'm going to give it so fast, and I'm going to stop if I reach such and such goal, or if I reach such and such safety limit. So this is a typical fluid challenge prescription. So you can see a patient who has a pressure of 65 and a CVP of 12. We've decided how much fluid we are going to give. And after 10 minutes, we see that the blood pressure has gone up and the CVP remains hardly gone up. So we continue the fluids and we see that the blood pressure has gone up to our target and the CVP is still fine, and we stop it. So this is a successful fluid challenge. There's another patient with the same starting point, 65 and 12. We give fluids, the CVP goes up to 14, but hardly anything happens to the blood pressure. We continue fluids and the blood pressure still doesn't budge, but the CVP has gone up, we stop it, and this is an unsuccessful fluid challenge. So this was someone who was fluid responsive and this was someone who was not fluid responsive. And lastly, the passive leg raising test. Now, this is quite a difficult test to do. And at least our beds in Hinduja, we can't really do this test. But the idea is you make the patient upright, you keep the patient semi-recumbent. So most of the blood is in the lower limbs. Then you tilt the bed so that the chest comes down and the leg comes up. So effectively, you're transfusing a bolus of fluids from the leg into the chest. You do a continuous cardiac output monitoring and you see if the cardiac output goes up. And then you reverse it and you see if the cardiac output comes down again. So if you do this, you can say, yes, this person is fluid responsive. Therefore, you're less likely to overload the patient by giving fluids blindly. So this is, at least it's a theoretically nice way to decide whether it's safe to give fluids or not. There are some ifs and buts here. Many of us don't use continuous cardiac output monitoring anymore, so this test isn't really practical. Many of the beds, at least in Hinduja, they split into 3, but we can't get that kind of movement on our beds. And sometimes just moving the patient, the pain can raise the cardiac output, falsely giving a false positive. If the abdominal pressure is very high, the patient may be hypovolemic, but still may not have an increase in cardiac output because there was resistance to venous return. In very, very severe hypovolemia, the patient obviously needs fluids, but the amount of fluid which shifted from the legs to the heart is so little that you might get a negative test and falsely not give the patient fluids. So with all this, what have our gurus, what have our guideline experts told us how we should use fluids? In the year 2004, this is what they said. I want to just point out there's a grade E here. And a grade E means we're not really sure if what we're saying is correct or not. Right? So they said give 500 to 1000 ml of crystalloid or give a smaller volume of colloid over 30 minutes, repeat the response. And this is sort of fairly practical stuff. And you keep giving fluid till such time as you think the patient is getting better. 2008, a minor variation to this. They said use a fluid challenge. Now, again, you can see their recommendations are very strong. 1, 1, 1, 1. But the evidence behind their recommendation beside the crystalloid colloid is very weak. There's a B here, there's a C here, there's a D there, there's a D there, there's a D there. So this really means this is the way we do things and we think it's right, but we can't justify it with data as of now. And it's a variation of the same thing. Give a fluid challenge, otherwise you give your 500 to 1000 ml of fluids over 30 minutes, and if necessary, give a larger amount. They also said that if there's a cardiac patient, be a little careful about it. So that was 2008. And I really like this. This was a very simple way of giving fluids in severe sepsis. This was in a resource poor setting, that at least make sure whatever else you do, you give 1 antibiotic and 1 liter of fluid in 1 hour. This is a very nice, simple way of deciding how to give fluids, even in a low-tech setting. But the final thing is the 2018 Surviving Sepsis campaign. And I think for those who are giving in exams, it's worth, you really need to know this. So I'm just going to read it out for you all. Early elective fluid resuscitation is crucial for the stabilization of sepsis-induced tissue hypoperfusion or septic shock. Well, nothing great there. Given the urgent nature of this medical emergency, initial fluid resuscitation should begin immediately on recognizing that a person with sepsis and or hypotension and elevated lactate, that this patient is very sick, and you start the fluids and you should complete your resuscitation in about 3 hours. The guidelines recommend that this should be about 30 ml of an intravenous crystalloid fluid. So 30 ml per kg just roughly translates to 2 liters. Although the literature does not include control data to support this volume, recent interventional studies describe this as usual practice. So what they're basically saying is we've done this for many, many years, so we should continue doing it till we have better data. The absence of any benefit of colloid over crystalloid leads to the recommendation that crystalloid should be the first choice. And because some evidence suggests that a sustained positive fluid balance is bad, they said use this whole approach only in the early part of the resuscitation and not later on. Which brings us to the most important question. At what point do we stop fluids and start inotropes? This study, called the classic study, was an underpowered study, but it showed that if you don't give too much fluids and start inotropes relatively early, the patient-centered outcomes tend to be better. But as they said, this was underpowered. 2 more studies are ongoing. I'm really not aware if they are completed or published. I haven't been able to find them, but they are trying to answer the same question. But this is the single most important thing. How should we treat our patients? Should we, a hypotensive patient starts on fluids and simultaneously start the NORAD and fill them up? Or should we not start NORAD, go for 2 liters of fluid, check that the IVC is expanded, check it's not collapsing, and then start noradrenaline? Which of these 2 is a more sound way of giving fluids? And in my opinion, this is the most important unanswered question currently. And I look forward to the results of these trials, which will guide us as to whether we should give fluids first and later add the inotrope, or we should do both simultaneously so that we don't overfill the patient up and we maintain perfusion relatively early on. Which brings us to the last part of the fluid talk. What are the controversies? I'm just going to go over this pretty quickly. The 6S trial was as close to a perfect trial as possible, but an alternate manufacturer didn't like the outcome because it was negative. And the difference of this particular manufacturer and the trial study drug was very, very minuscule. So let's say the concentration of one was say 1.13, the other was 1.14. And the authors have just put this is a 1.1 solution. So the alternate manufacturer threatened the PI with, it was a very, very nasty episode. With legal action, they threatened to make him broke, they threatened to make him bankrupt, and so on and so forth, personally. And it took a lot of intervention from medical societies and governments before this particular company backed down. The chest study, which was the other study, also the manufacturer said, no, these guys really don't know how to do their analysis. And they got an independent person, another fairly high profile American university, to say, and the independent people also said, no, we don't think that the chest people have done the analysis correctly. We want the raw data to look at it ourselves. The investigation said, nothing do, you all will probably give it a spin, but you tell us what your problems are and we'll reanalyze it. So they reanalyzed it as per the recommendations. And they said, no, we are sticking by our conclusions. It remains the same. Which brings us pretty much to the last controversy. Till now, we have made an assumption that when a person is sick, we got to give a bolus of fluids. And in this particular comment by Hilton and Bellomo, a critique of fluid boluses, resuscitation, and severe sepsis, they made this statement. As of 25th May 2011, no studies existed comparing initial resuscitation of fluids of patients with sepsis with fluid boluses without fluid boluses. Now, we are so used to giving fluid boluses that we cannot actually imagine not giving a fluid bolus. So this was the FEAST trial, and it was done in African children with sepsis, most who had malaria. And there were two groups. The biggest group was those who had hypoperfusion without hypotension. In this group, one group got no fluids, one group got saline, one group got albumin. In the hypotensive group, everyone got either saline or albumin because it was believed to be completely unethical not to give fluids to a hypotensive patient. And somewhere down the line, the safety board said, look, you got to stop this study because one group is doing better than the other groups and you're harming the other groups and we need to stop it. So what they found is whether you look at the 48-hour outcome, this is in the non-hypotensive patients, or you look at the 20-day outcome, the group which did not get fluids here had a lower mortality than the fluids who got either saline or albumin. Now, clearly, this was a bit of a shocking study, which effectively said by pouring in fluids to the patients, at least before they become hypotensive, we are potentially harming them. They analyze this in multiple ways. They asked, is fluids causing anemia? Is it causing reperfusion? Is it causing cerebral edema? Is it causing pulmonary edema? Is it, in some centers were not doing a job properly? But regardless, they found that this effect was across the board. It wasn't only in those with anemia, or only in those with coma, only in those with pulmonary edema. Something about fluids was making the mortality go up if it was given before onset of hypotension. So we can say that giving a fluid bolus can increase mortality, definitely can, if it's used prior to the onset of hypotension. But we have to keep in mind that this was one cohort and it may not apply to us. So let's summarize the fluid part. Colloids and crystalloids are largely associated with similar outcomes. Okay, largely. But in the overall scheme of things, a balanced crystalloid solution in severe sepsis, in those with high renal risk, may be the best option because it's shown to be better than saline and it's shown to be better than colloids. Albumin has not been demonstrated to improve clinical outcomes. Monitoring as of now needs to be multimodal, including the dynamic variations. And most important, we need to concentrate on clinical outcomes and don't just be happy with physiological outcomes like the chest got better or the BP got better or the inotropes came down. Those are not good enough. We really need to make sure that patients get better. So I have two options at this point. I can stop at this point and take questions, or I can continue with the controversies. What would you like me to do?
We'll give you a bit of a rest. You can answer the questions.
Okay, let's go for it.
Sir, I think we've only got one question so far. It says that in spontaneously breathing patient, how do we interpret PLR? I mean, interpret volume responsiveness when PLR is not always possible.
It's a nice question. It's also quite difficult to answer. See, we can eyeball pulse variation, okay, with respiration. Now, I just want to keep one thing very clear. If you see some pulse volume variation and the CEP is high, there's a large number of differential diagnoses, including COPD, pulmonary embolism, tamponade, etc., etc. So this is really in underfilled patients. What we can say is the greater the variation, either the respiratory swings are excessive or the volume is underfilled. So if a person is breathing very, very gently and the CVP is low and you're seeing a lot of visual variation, then the chances are that that person needs some degree of fluids. If on the other hand the person is sucking in air and blowing it out, it could be that the swings you see are just because of the respiratory effort causing the pressure to fall. So you've got to put the whole package together. Is the CVP high or low? Is the patient struggling to breathe or breathing very quietly? And based on that, decide whether the variation you're seeing is truly reflective of a hypovolemic state, or it's reflective of an underlying diagnosis, or a respiratory airway pressure, which is pressures are swinging. I don't think you can actually go by numbers because it hasn't been studied well in non-paralyzed patients, in spontaneously breathing patients. But it's still a good visual clue. It's a bit like tachycardia. The more the tachycardia there is, the more you need to be concerned about what's happening. In a similar way, the more the pulse variation there is during respiration, the more you need to be concerned that something is not right.
So, since we still don't have many questions, so one question I had was there's few studies. There was a study which looked at 30 mils per kg fluid in terms of ideal body weight and actual body weight.
Hmm.
What do you think of that? Like, because the guidelines don't mention uh, ideal versus actual. This is 30 mils per kg.
But honestly speaking, I don't think the actual body weight is very important, because if I gain 25 kgs in the next 5 or 10 years, my circulation is not going to expand or come down. Similarly, if I go on a diet and lose 15 kgs, my circulation remains the same. So I think in an average adult, ballparking 2 liters is a reasonably sensible thing to do, as long as you don't get stuck on the numbers and you don't, blindly follow them.
Right. And there was also another trial which looked at fluid bolus within the first hour and fluid bolus given after the first hour, which did show some difference.
It's difficult. You know what? You have to at the end of
Sheel, I am getting Jason's voice there. Can you ask him to?
Yeah.
Yes.
At the end of the day, you're going to have to individualize the timing of the fluid to the clinical status. So, I mean, if someone had a normal pressure on the first 2 hours and then became hypotensive at the third hour, then obviously that person needs more fluids at that particular point of time. But as a general rule, if at all there is a hyper-resuscitation phase, it's in the early part of the illness, and you should probably be hyper-resuscitating at least in terms of fluids later, because it appears that too much fluids is also worse outcomes. Now, whether it's a cause or whether it's just a marker is questionable. But I think you should just resuscitate to the point where you get your parameters. And of course, you should be, if trials show that a certain technique is good, then that's what you should be following, as long as your patient fits the criteria which the trial studied.
Right, because we are sensitized about the timing of antibiotics, but not as much as for the timing of fluids.
I'll come to that part later, but I think if at least if we put in arterial lines and we can see the blood pressure below in front of us, or we put in hourly outputs and we can see there's no output, I think most of us would jump on the, so if you see a BP of 80 systolic, most ICUs would jump on that. While if you see a BP of 120, then regardless of time, most people wouldn't feel necessary to jump in. So I would be surprised if a seriously hyporesuscitated patient doesn't get enough fluids early in at least in a standard bread and butter ICU.
Right, sir. We have one question. Your opinion on plasma light, sir?
Plasma light. So it's a balanced solution. I'm happy to put all the balanced solutions in one group, because I'll have to go. I'm going by memory here, but I think Salted and Smart gave the option of using either ringers or plasma light. So as far as I'm concerned, they're equivalent. Also, the price difference isn't that much, so I don't have very strong feelings about it.
Yes. And your opinion on modified fluid challenge, sir?
I've got a half an hour talk on fluid challenge. At the end of the day, I say I'm quite confused. What is the point of this fluid challenge? My understanding of the fluid challenge, and I accept that it's a slightly minority one, is you're asking a question, is the person responsible to it? At the end of the fluid challenge, the answer you get is that the patient was responsible for fluid in the physiological state at the beginning of the fluid challenge. So after I finish my fluid challenge, I can't say now the patient needs more volume or not. So for this reason, I look at a fluid challenge as a sort of a slightly more structured form of standard ICU titration, which is you do something, see what it is, do something, see what it is. Whether it's the sugar is high, you give more insulin, the urine output is low, you give more diuretics, the blood pressure is down, you increase the inotropes. I look at it as a variation of that. And I'm not a very great fan of a very structured thing. And even if it's positive or negative, I don't see it's given me great information because over and above an unstructured fluid challenge. But as I said, I'm in a minority. I know many people think it's a very good thing. I know Jean-Louis Vincent thinks doing it any other way is criminal. I think even Sheila thinks that it needs to be done very systematically. I've been a little confused about what is the exact role of a structured, formalized fluid challenge as against our standard titration, which we now do in the ICU at all times.
I get that, sir. I
Still,
think
there
there
is one
is.
question about passive leg raising in patient who are amputations.
Who have?
Knee, above knee or below knee amputations. So in these patients, the passive leg raising will be same or it will be different?
I see no reason why it should be too different because I mean ultimately the veins are the capacity vessels. So I mean unless both you have a sort of very high bilateral below hip amputation, I don't think it will make too much difference. I've never actually, as I said, I don't do it, and I think one below knee amputation will hardly matter personally.
Yeah, I mean, I think what they are trying to ask is, uh, so the expected volume that is, I mean, the volume that is expected to pull with someone with both legs intact or both lower extremities intact. So how much blood is pooling in 1.5 leg versus 2 leg is the question.
Yeah.
And I'm sure it's not just the leg blood in the leg; it's also the blood in the pelvis. So unless the patient has intra-abdominal hypertension or something which will affect the return to the central circulation, I don't think it should make much of a difference.
I also think keep in mind that the venous system is really the capacity system as against the
Yeah.
artery.
Yeah.
So the same veins can dilate out to 5 liters and the same veins can contract down to 1 liter. So it's really, the veins can accumulate a large amount of fluid or a small amount of fluid. I don't think it's too much of an issue.
Yeah. So
just one request to the delegates: can we just restrict our questions to fluids in this session? I know you have got an excellent teacher in front of you, and therefore you want to ask all possible questions, but we don't really want to talk about antibiotics in this session. So please restrict your questions to fluids. Amol, you can take up this ARDS question if you want to ask that question on here.
I've actually got the controversies in sepsis. Can I? That's about 5 minutes. Can I finish that off? So that
Yeah, of course, of course.
Yes, sir. Go ahead.
Okay, just can I have that back? Do I have to share it again? The screen?
You will have to share.
Yes, sir.
Okay, now I'm going to do this relatively quickly because it's a very large thing. I'm just really going to. Okay, so. I personally don't like the word controversies because controversies suggest that something is black and white or a yes and no, and science doesn't really work that way. So whenever there's a term controversy, I prefer the term unresolved question. So when you look at it this way, you just say, okay, we'll find out some way to resolve it. And the best way to resolve it is look at clinical outcome from large RCTs. And luckily in the last 10, 15 years, we've had a huge number of RCTs in critical care medicine. And along the way, all of us have had to learn how to read these RCTs and meta-analysis. So let's come to early antibiotics. Now, early antibiotics is our sort of gold standard, so to speak. But I would just like to clarify a few things here. There are two forms of sepsis we get. One is primary sepsis. Primary sepsis, someone is in the community, gets a pneumonia, gets a COVID, gets UTI, gets malaria, and comes to our emergency room, and they're hypotensive. That is one kind of sepsis. Another sepsis is a person who's had a surgery or has had a trauma or has had a stroke or has had GBS on the ventilator, then gets a new infection and then becomes hypotensive. These are two separate syndromes. And all the data for early antibiotics being spectacularly successful are based on this one trial by Kumar. And I'm pretty sure all of you all have seen this trial, but basically in the first half an hour, a very small percentage of the patients got the correct antibiotic, but almost all of them survived, 80%. As time went by, more and more patients got the correct antibiotic. And at the end of 1.5 days, almost everyone got the correct antibiotic. But those who got it late had a very low survival. So this showed a very, very, very clear demonstration that the later you give the antibiotics, the worse is the outcome. So this was their conclusion, that most people didn't get it effectively early enough and it made the outcome worse. This is an observational study. However, when you try to find data to support this, it's hardly available. There are just two, at least when I last checked, there were 2 positive trials and there's a large number of negative trials. And in these negative trials, in one trial, actually in the trauma, the earlier used antibiotics, the higher and this antibiotics were used for fever, the worse was the outcome. I don't exactly know what to make of it. So at this point, I just want to say early antibiotics are only proven, and even proven is in the context of an observational trial, in 2 contexts. The infection has to be primary, so that means the patient has to be presenting to the emergency room, and it has to be severe enough to cause hypotension. We don't have any evidence that early antibiotics makes any difference in secondary sepsis. We don't have any evidence that early antibiotics makes it in less severe infections, that is without hypotension. And again, it goes without saying that antibiotics without source control is in itself not going to work. Okay, so these are some other questions which you all at least need to know, that there are unresolved issues. Should we start renal replacement therapy early or late? Should we use continuous versus intermittent? Continuous versus intermittent has been studied some time back and they've been found to be equivalent. Early versus late, there have been 5 large studies recently, and the names of the studies are ELAINE, AKI, Ideal ICU, START AKI, and AKI KI2. Putting it all together, you can wait for standard conventional criteria, that is high BUN creatinine, BUN crossing 100, or no urine output for 24 hours or so, or the potassium is high, or the pulmonary edema is there, or the severe acidosis. In the absence of that, there's nothing gained by starting renal replacement therapy early. And in fact, a large number of patients, if you wait, will turn around without needing the renal replacement therapy. The next question is, when we do ARDS, we obviously limit the pressure, we limit the tiny volume, we limit the airway pressure, and that kind of stuff. But should we be using the driving pressure? Very elegant studies or very elegant analysis of previous studies have showed that the driving pressure can be kept less than 15, the mortality is less. Driving pressure in simple terms is the difference between the pulse pressure and the inspiratory pause pressure. But as of now, this is only based on sort of analysis, or this is hypothesis generating data, and we don't have outcome data prospectively studying this. Should we use sedatives and relaxants a lot in ventilated patients or keep it light? At this point, I can say we are in the era of relatively minimal sedation and relatively minimal relaxants. And the one study showed that early relaxants was useful, but a larger study failed to confirm that. A difficult one is, should we use NIV in ARDS early, or should we use it, or should we get on and intubate the patient early? This is something which really needs an answer quite badly. Should we use liberal oxygen? 2 studies have shown that targeting oxygens of 90 to 92, 93 is very safe. And earlier studies showed that liberally using oxygen might cause harm. So as of now, the correct approach based on the data we have is that you should keep the saturation above 90, but you should also aim to keep the saturation below 98 so that you don't inadvertently cause the PO2 to go to past 150, 200, which has been shown to cause harm. Should we use liberal blood products? Liberal blood and blood products, now we have a large number of trials. The vast majority show that anything above 7 doesn't really change any meaningful outcome, though possibly 1 or 2 trials show that 9 was better than 7. Should we use adrenaline out of hospital cardiac arrest? Surprisingly, the trials have failed to show any meaningful benefit with adrenaline. And should we use hypothermia and CPR? The trials are moving this way or that way. As of now, we continue to use it, but a recent large trial has made this even more questionable. How early should we start feeding our patients? And if we can't feed them, when should we start TPN or immune nutrition? As of now, again, there is no really good trial which suggests that early nutrition is useful, but probably early enteral nutrition might have some benefit. If you can't feed early nutrition enterally, there is no data to suggest that early TPN is useful, or no convincing data. However, if you know that you can't feed for 7 to 10 days, then maybe starting early TPN might be beneficial. And immune nutrition as of now is not practiced anymore. Glucose control right now, anything less than 180 seems to be satisfactory. DVT prophylaxis is something we all practice left, right, and center. I'd just like to point out that no ICU studies have shown there's been any improvement in any clinical outcome by following this DVT prophylaxis. All we have shown is that we decrease the incidence of DVTs, but we haven't shown any improvement in mortality, length of stay, inotropes, etc., etc. Steroids, I think I'll give it a miss. There is this thing. Another important question in my view, which is unanswered, is if a person gets a new onset atrial fibrillation, how should we treat it? My personal view is you treat the underlying cause and the atrial fibrillation will resolve in 24 to 48 hours. But a large number of people feel that you need to start amiodarone for this. You need to consider anticoagulants. And I think doing it in the first 24, 48 hours may not really be necessary. And there's no ICU data to suggest that this actually helps. Should we be using antioxidants, vitamin C and thiamine? The data is slowly moving away from this. What is very important is that more and more of the studies are looking at longer term outcomes. We're not only happy at 28-day mortality, we're looking at where patients are at 6 months, we're looking at where they are in 1 year. And this is something we need to be focusing more and more as we analyze our practices in the critical care, that we shouldn't just be happy that the person got off the inotropes quickly. We shouldn't just be happy that the person spent less time in the ICU of the hospital. We should only be happy when they get back the full quality of life they had before, and they get it back as fast as possible. And lastly, I'm just bringing this up for the sake of completion. Ulinastatin, polymyxin B hemoperfusion. I don't particularly use them. I don't have very strong feelings one way or the other. But these are some of the partially resolved or unresolved areas. So I'm going to end this section by saying that there are a large number of unresolved questions in sepsis, but the important ones in terms of mechanical ventilation, hemodynamics, renal replacement, blood use, nutrition, oxygen are slowly being resolved. And I'd like to point out that the exact role and timing of antibiotics is not based on RCTs, and it's really based on observational data. Okay, so I'm going to stop at this point again and take questions on this.
Sir, as you have said, there are a lot of questions which are unanswered.
Yeah.
Sometimes we at the bedside, when we get a patient with severe ARDS with bad oxygenation, we initially give some fluids until the patient doesn't respond. So now the question becomes whether I should give patient some more fluid or should we start noradrenaline? So do you have any particular studies which has looked up this question?
There are two questions. Should you give more fluid or should you start noradrenaline? The study has been well looked at, liberal fluids versus restrictive fluids, and the use of swan guns to guide fluid versus the use of CVP to guide fluids. I can't get the exact name of the study. There were two studies. What's the name? I mean, everyone should know this. The studies which fluid balance. Atul, what's the name of these studies?
Sorry, I missed the question.
The liberal versus restricted fluids.
The fact trial.
Fact trial, the lung, fact trial.
T. So fact trial suggested that using, again, I want to suggest that in the fact trial, they first resuscitated the patient as they needed it for the first 24, 48 hours, and then use a liberal versus restrictive. And they found that the restrictive fluids strategy had less time on the ventilation. So it appeared to be a benefit, good thing. But a later analysis showed that those with restricted fluid also had more neurocognitive impairment in the later part of the recovery. So it's become sort of plus minus. So that's the best answer I can give right now. You have to initially resuscitate as per your initial principles. And once the resuscitation is complete, you can choose to be restrictive versus liberal. When to switch to NORAD, as I said, is an unanswered question. So I can tell you what I do, but that is neither here or there. It doesn't mean it's right or wrong. But I think the standard thing would be fill the patient up till the IVC is at least dilated and then start NORAD. And don't take too long to do the whole thing. And check the lactate. If the lactate is coming down, you're probably on the right track. If the lactate is not coming down, somewhere or the other, you're on the wrong track.
Now, the rule of the thumb is that if the pulse pressure is too wide to begin with, or some people suggest that if the diastolic is less than 40 millimeters of mercury, then you should start vasopressors early along with fluids. I don't know, there is no direct evidence to suggest that, but they're taking the diastolic less than 40 as a cutoff for the present.
Yeah,
I don't know the basis for that.
I totally agree with you that the lower the blood pressure is, the faster you need to start your NORAD. So it gives you time to resuscitate the patient. But other than that, I'm going to sort of say we really don't know.
Yeah, that is the correct answer.
This is as good or bad as anyone else's.
We are still in 2000 for that question.
Sorry?
No, and
we are still in the area of 2000 for regarding this question, whether low diastolic.
We've got these two trials ongoing. I don't know whether they finish recruiting or not. So I have a feeling that we will have at least a broad answer that generally start NORAD late, or generally fill them up first and then start NORAD?
Means I mean to say low diastolic BP start NORAD first, looks sound physiologically, but evidence we don't know as of.
You know what, a low diastolic with a normal mean versus a low diastolic with a low mean, I don't think you can really say imagine the same. So a low diastolic with a high systolic is little different from a low diastolic with a normal systolic. So
No. When I said low diastolic, I also meant I'm talking only about patients in hypotension. I'm not talking about patients with.
Yeah, correct. So I mean, you
yeah.
can assume that the lower the mean pressure is, and the wider the pulse pressures, the diastolic will go lower. So I would still concentrate more on the mean, and for a given mean, if the diastolic is low, I'd be a little more worried. Again, in an elderly person, because the arteries are stiff, the diastolic could be low for another totally different reason. So so I would focus mostly on the mean pressure. I'd look at the trace and sort of based on that. And again, honestly, if the person is passing urine and the lactate is coming down, I'm happy regardless of the pressure numbers.
Yeah, the other thing that we need to remember about the FACT trial was, apart from initially resuscitating the patient with the normal, like you normally do, they also had a very strict protocol about patients being given fluid if they develop hypotension in the middle of the course in ICU. So it's not as if conservative fluid means that the patients, they were not allowed to give fluids to the patients at all. So if following the FACT protocol, in fact, is very difficult, particularly if you read the supplement about when you could give the diuretics and when you could give fluids, etc., is very, very specifically designated in the trial protocol, and I don't think we stick to those things in. So I will take those findings of the FACT trial with a bit of pinch of salt, because that is not what we routinely do in our day-to-day practice.
Yeah, okay, but you could also look at it the other way. In the FACT trial, if you take away the first 1 or 2 days and look at the balance over 10 days, the liberal fluids were roughly 10 liters positive or 1 liter positive per day, while the restrictive fluids were roughly in equal balance. So
yeah, so I mean that we know that positive fluid balance is bad.
Yeah.
We know. So the other thing that you should probably comment on, Farhad, is this de-resuscitation, which is now, or the Rose concepts or whatever that is being discussed now. That is something that I think you have not touched upon. That should we actively diurese patients once you think the catabolic phase is over? The question for me always is, how do you know that the catabolic phase is over?
I'm not a great fan of diuretics. I think diuretics should be used very sparingly in ICU for 2 indications. The person has pulmonary edema in a cardiac setting, or the person has a low output. Because the physiology of the patient will determine how much urine output to pass. And we shouldn't override that unless, the fluid is thing. So I personally believe once the catabolic phase is over, the person will go into their spontaneous diuresis, and we don't need to preempt it with a few diuretics here or there, especially based on concepts we don't know how to apply to a patient. So I'm not a great
So
fan.
you are saying that de-resuscitation as of now is not fully approved, or there is not enough data on de-resuscitation?
I would say that artificially de-resuscitating a patient is not what I think. I think as the patient gets better and the catabolic phase, they will de-resuscitate themselves by prompting a diuresis, and that's the correct time for diuresis. That's my current thinking.
Yeah. Okay. Any more questions? Do we have any more questions?
We don't have yet, sir. Only one question: role of adsorption filters like Cytosorb or Oxiris.
As I said, I don't use it. All I can say is that the data is pretty soft. Japan uses it a lot on a pretty soft data. I'm not a great fan of very costly and complicated treatments which have marginal benefits. So,
And the studies have also not shown much benefit. Most of the studies have not shown many benefits in.
Yeah, they just faster or something.
Yeah, I mean, we have tried high dose RRT for removal of cytokines. Cytosorb is just another way of removing the cytokines. So I'm not sure that we might be removing good cytokines also along with the bad cytokines. So there is that thing to consider as well.
It's a very complicated therapy. You got to anticoagulate, you got to put lines in, you got to put them on pumps. I mean, I don't know if the benefit justifies all this. I mean, if someone is already being dialyzed, then to use a filter is slightly different. But to put it in just because you want to do this is a bit excessive in my view.
What is your take on dynamic artery elastance for the measurement of fluid therapy?
I'm not really sure. Just explain it to me.
The dynamic artery elastance, that is the ratio of PPV and stroke volume variation.
No idea. Honestly, no idea.
It's just emerging, Amol. I don't think anything has been proven yet
Yeah.
in this. I'm just coming in, so we don't know much about it right now.
Is don't get stuck up on the pressure. Go with the perfusion. The perfusion is much more important than the pressure. So even when we have pressure targets, it is with the assumption that perfusion is retained or maintained. So I mean, whatever the number is, if I get the sense this is poor perfusion, I'll be unhappy. And whatever the numbers, if I get the sense this is good perfusion, I'll be happy. So I'm really not that tied up with the blood pressure numbers. They shouldn't be separated out from perfusion, because I think the pressure is only of use to us in terms of telling us what the perfusion is.
So in that regards, do you rely heavily on lactate clearance, like the 10% lactate, or
I think
what do
if
you?
I was critically sick, the one thing I would want is my lactate to come down. If the lactate is going up, it's a disaster. So either you've not treated the initial insult, or your resuscitation is not right. Lactate not coming down is a disaster. I mean, there's no other way to describe it. I mean, obviously, let's say there's no fit or there's no seizure or something. If there's a clear, simple cause for the lactate to go up and come down, that's different. But in the absence of that, it's the single most important marker that you're doing badly is the lactate not coming down or going up.
So during the resuscitation phase, you will rigorously look at two hourly 10% clearance, sort of.
No, I don't know that a fast clearance is important, but let's say 6 hours later or 12 hours later, the lactate is not coming down. You really have to ask yourself what you're doing wrong. Something is very badly wrong, and you have to identify that. It's not the
But so
research.
some
Identify what the problem is and reverse that.
like sometimes we feel 6 hours is a long time to repeat the lactate. Sometimes we feel.
Yeah, I know, but you know the lactate as part of a early goal-directed therapy. That trial is a very difficult trial to understand, but with some adjusted thing, it was so-called positive. The real problem with that trial was that in both the groups, the lactate came down at the same pace. So it's a very difficult trial to understand, and lactate every 2 hours is a little tends to be a little costly. I think if you have a bedside lactate, knowing that it's going down is very useful. If you don't have it, I think at some point a patient you feel is resuscitated. Okay, the heart rate has started coming down, the oxygen is good. That's the time to recheck the lactate. And if the lactate is also moving in the same direction, you're on the right track. If the lactate is not moving in the same direction, you really have to wake up because you're missing something. There's abscess somewhere, there's ischemic bowel, something or the other is wrong. The lactate really should not be going up in the face of a successful resuscitation.
In continuation with the same question, like in patients with liver failure, where the lactate clearance may not be reliable, how would you titrate your therapy or modify it?
Liver failure in itself doesn't raise the lactate. What liver failure does is it slows down the clearance of lactate. So a person with liver failure without hyperlactatemia will not have a high lactate, but a person with liver failure and hyperlactatemia will have a slower clearance of the lactate. So if the trend is wrong with or without liver failure, you're doing badly. If the trend is right with or without liver failure, you're doing well. But keep in mind in liver failure, it might take longer to come down. So as long as it's not rising, I may be less paranoid in someone with liver failure than someone without liver failure.
Yeah, because literature is quite in favor of lactate, like even as compared to Q SOFA when they put lactate as a higher determinant. Sir, we've got few questions. How do you resuscitate patients with heart failure, congestive heart failure, and maximum dose of NORAD in sepsis?
Well, heart failure, I mean, you follow the principles of heart failure. I don't, honestly speaking, from an ICU perspective, heart failure is not very hard, especially in the area of NIV. What really happens is chronic heart failure causes chronic hypoperfusion and then causes organ dysfunction, and that becomes hard to treat. And chronic heart failure complicated by sepsis also causes multi-organ failure that becomes hard to treat. So single organ heart failure, which is reversible, is very rarely a problem unless it's exceedingly severe. And almost always heart failure has some underlying cause, whether it's ischemic heart or valve functioning, or and you got to treat that underlying. But otherwise, the principles of resuscitation are not very different for heart failure from sepsis, except that we probably use inotropes and pressors a little earlier. And if you look at the trials comparing noradrenaline to adrenaline, they looked at all groups. They looked at hypovolemic groups, septic groups, and cardiac failure groups. And the basic principles weren't very different.
Sir, do you use BNP or pro-BNP in your
Yeah, I
in a special? Yeah.
use it quite a lot, but it's not a very useful thing in the sense that I think it's more useful in the person with breathlessness who's not in the ICU. And a normal BNP says look for a non-cardiac cause. A high BNP could be many things, including cardiac. But a normal, so it's more like a rule out cardiac. A person is very breathless, the BNP is normal. I will start saying look for other stuff.
So has a good negative predictive value rather than
and also a good negative predictive value in a non-ICU setting, or even better in an ambulatory setting.
so something like a D-dimer for pulmonary.
To some extent, yes, yeah.
So any role of any specific indication for PA catheter?
I can't remember when I've last used it. And even when the patients come from the cardiac OT with them, sometimes I can't remember looking at the numbers.
I think we asked enough questions of Dr. Kapadia, and I don't see any more questions here. So I think we'll move on to the next session. Thank you very much, Dr. Kapadia. It was a pleasure as usual.
Okay, thank you, everyone.
Thank you. Thanks.
Well, we move on to the last session or the last lecture of last topic of this day, and just to remind guys who are interested in getting the books ordered, you can do that these 3 days. So one is the BRITE case-based review in critical care medicine, and the other one is the infectious disease diseases in the ICU. So Dr. Rahul Pandit, we all know him, and especially he's been a big name during this COVID pandemic, who's been actively involved in the task force, and we know how Mumbai and Maharashtra have done well, and Dr. Rahul Pandit has been a major part of it. So Dr. Rahul Pandit is the director of intensive care at Fortis Mulund. He's also the visiting consultant at Barthas Hospital at Wagga Wagga Hospital in Australia, and he will be speaking on how to examine a patient for examination. So I'm sure this will immensely benefit you, all the guys who are giving their exams. Over to you, Dr. Rahul.
Hello friends, I am Dr. Rahul Pandit. I am the Director of Intensive Care Unit at Fortis Hospital, Mulund, Mumbai. The art of examining a patient, more so a critically ill patient, is a very complex one. In this video, we are trying to demonstrate how to examine a critically ill patient in a structured way so that it helps us into coming to a reasonable clinical diagnosis, a working plan, and a treatment plan as well. My colleague Dr. Charudat Vaiti is going to examine a dummy patient so that we can demonstrate to you the steps and a structured way in which we would like to examine these patients in your intensive care unit on your daily ward round. Let's see how Dr. Vaiti goes around with his examination. Thank you.
Hello everyone, my name is Dr. Charudat Vaiti, and today we are going to see on how to examine and assess a critically ill patient in intensive care unit. Before we even start assessing, it is important that we follow the hand washing policies and infection control policies in any intensive care unit by starting by using the hand sanitizer. While we are using the hand sanitizer, it is important to note if the patient has any isolation policies. In some ICUs, it may be necessary to wear gown and gloves before we start examining the patient. While we are waiting to do our hand washing, we can make some general assessment by just standing at the bedside. Before we start doing the formal assessment of the patient, we can get a lot of information by just observing the patient. We should curb our immediate instinct of going straight to the patient, because this information, if we don't assess now, it will be more likely to be missed. So we see that our patient is intubated, he's on the ventilator. We look for any signs of distress, for pain. He looks comfortable and he seems to be sleeping quite comfortably. Look for any drains and tubes. I can see that there is a Foley's catheter which is draining the urine output, and look for what sort of monitoring is going on. So I can see that he is on the continuous monitor, which is reflecting the heart rate and the saturation. Before we start assessing the patient, it is important to respect patient privacy, and I would be doing that by drawing the curtain and getting a private place to examine. Hello, Sister Leji. We are going to examine Mr. Jain. Can you please close the curtain? It's always important to have a nurse alongside with you while we are examining the patient, especially if it is a female patient and you're going to expose the patient. It's important to have a chaperone to examine. It's also important that we take patient's permission before we examine, especially if they're awake, and make sure they have consented for your examination. So before we start our examination, we're going to take permission from the patient, especially if they are awake. Mr. Jain, how are you, Mr. Jain? I am Dr. Vaiti. I look after the ICU. I'm one of the ICU doctors. This is Sister Liji. She's with me. Is it okay if I examine you? I'm going to expose you while we examine. I'm sorry about that, but it will be a quick one. Thank you. So I'm going to expose you, Mr. Jain. Sorry about that. Sister, please help me. Okay, so make sure that the patient is adequately exposed. Limbs, but at the same time we maintain the decency. Expose his chest as well. While examining, we keep a structured approach, and by that I mean that we can have an ABCD approach. So the first assessment will be how is the airway of the patient. While we are assessing the airway, there are simple things which we can look, like is the patient awake enough? How is the speech? Are they able to talk? Or is there any gurgling sound? Are they able to cope up with their secretions? Some of the patients may have an endotracheal tube, like our patient. If we have an endotracheal tube, we look if it is adequately positioned, what is the length of the tube which is inside, what is the cuff pressure, and you can check with the sisters, what is the cuff pressure.
25.
So that's what we want, around 25 to 30. Less than 30 is adequate. Some patients may have a tracheostomy. It is good to know what is the type of tracheostomy. Is it a surgical or a percutaneous tracheostomy? When it was performed, how many days down the line, how is the patient coping with the tracheostomy? Is he close to getting decannulated? And same with the endotracheal tube. Is the endotracheal tube adequately positioned, and can we are we close to extubation? So that is the airway assessment. Moving on to the breathing assessment, that is B. We look at how the patient is breathing. At this stage the patient is on the ventilator, but general assessment will be what is the respiratory rate, what is the respiratory pattern. Is he comfortable with the breathing, or is it a thoraco-abdominal breathing? Is it a distressful way of breathing, labored breathing? Then we look at what is if the patients are on the ventilator, we look at how the ventilator is performing. Are they on spontaneous breathing mode, or are they on a controlled mechanical ventilation? What is the compliance of the ventilation? Are they if they are on a spontaneous breathing mode, how adaptive they are to the ventilation, are they comfortable with the support they are on. Then we look at how much oxygen they are on, what is the FiO2, fractional inspired oxygen, and how well they are saturating at this stage. At this stage, we can also check their blood gas to see what is their PF ratio, what is the oxygenation they are having on the FiO2 you are delivering. At the same time, look at how they are ventilating in terms of the CO2 clearance, and ABG is what we would assess. Once we have seen that, we can move on to doing the actual assessment. We'll use a stethoscope for auscultation. Percussion and palpation, as we would do normally as a medical examination, are not very useful in a critically ill patient, and auscultation is something which would give us some idea about what is happening with the chest. So auscultate on both sides of the chest, see if the air entry is equal or not. So check whether the air entry is equal or not. Examining the posterior side of a critically ill patient is always a challenge, especially if they are intubated. Auscultating the back is always a challenge. But if they are awake, efforts can be made to examine the back and auscultate and see how the air entry is on that side. To complete the airway and breathing assessment, we can check with the nursing staff about how the secretions are, what is the secretion load, especially in patients who are intubated or having tracheostomy. Is the secretion mild, moderate, or on the heavy side? What is the color of the secretion? Is it white, yellow, green? Have the secretion increased in the last 24 hours? To give us an inclination whether they are developing ventilator associated pneumonia or hospital acquired pneumonia. Moving to the circulation, that is C, we look at the heart rate on the monitor. It gives us the reflection on whether the patient is tachycardic or bradycardic or normal heart rate, and check for the blood pressure. We may have invasive monitoring, invasive arterial blood pressure monitoring, which will give us beat to beat reading, or we may have non-invasive blood pressure monitoring, which is intermittent, like in our patient. He's got a non-invasive blood pressure monitor, and this will give us interval recording depending on the time interval we have set. It may be 5 minutes, 15 minutes, 1 hour, depending on the criticality of the patient. While we examine the patient, the circulation, start by assessing the general assessment, how the limbs are they cold, warm. It will give us an indication of what whether they are in any shock state. Examining the upper peripheries and the lower peripheries, check for whether they are warm or cold. Then we look at the capillary refill time to assess the perfusion, and by that you can press for about 5 seconds and then release and count what is the refilling time by counting the seconds, and see if the patient is well perfused or not. Okay, then we can auscultate the heart sounds again by using the stethoscope. We could potentially merge this auscultation with the respiratory auscultation and check whether there is any new onset murmurs or any pericardial rubs. Auscultation of the heart sound should be performed at the mitral area, at the tricuspid area, at the aortic and the pulmonary area. We can complete our circulation examination by looking at the central venous pressure, if at all that is monitored. We can look if there is an intra arterial line, then we can look at the pulse pressure variation or stroke volume variation to make an assessment of what is the cardiovascular status. Coming to D is for disability. In disability, we do a neuro assessment. In neuro assessment, we can start by seeing if the patient is on the ventilator, whether they are on any sedation, and what is the type of sedation, what is the level of sedation. For checking the level of sedation, we look for different scores are there, and mostly what we are following is Richmond agitation sedation score. In that, we need the patient to be comfortable, we need the patient to be easily arousable, and they will follow some instructions. So as we saw earlier, Mr. Jain was able to give us some responses before we started examining. Apart from that, we need to look for how the pupils are the pupils equal or unequal, and for that we need a torch. We can reduce the light and shine the light into the eyes and see for the pupillary reaction. Same on the other side, and see if the pupils are bilaterally equal or unequal, are they reacting to the light or not. After the pupillary reaction, we'll check the GCS, that is Glasgow Coma Scale. In Glasgow Coma Scale, we have got three components. We got eye, we got motor, and we got verbal. So in eye, we see whether the patient is opening his eyes spontaneously or to voice or to pain or not opening at all. In motor component, we see whether they are following commands, whether if they're not following commands, then if they are moving their limbs to pain. If they're not moving their limbs to pain, then not localizing their limbs to pain, then is there any abnormal flexion extension or there is no movement. And with the voice, we see whether they are able to communicate with us in a comprehensible, incomprehensible, or no communication at all. So I can start by saying, Mr. Jain, hello, can you open your eyes for me? And Mr. Jain is opening our eyes, so he is, E3. Mr. Jain, can you lift your right hand for me, please? Yes, well done. How about your left side? Well done. How about your right leg? Well done. How about your left leg? Well done. So in him, as he is intubated, the V will be T, but he is following our command, so M is 6. Apart from looking for the motor movements in terms of the Glasgow Coma Scale, we also assess if there is any focal neurological deficit, is there any unilateral weakness. In patients who are sedated, it may not be very easy to do that, but if they are awake, it is something which you should seek for. Even when they are sedated, see whether there is any unilateral weakness. After neurological assessment, that is D, we move to what is the renal parameters doing. In that, we see how much is the urine output, are they catheterized or not catheterized, self-voiding, if they are catheterized, what's the hourly urine output, and we look for what is their overall fluid balance for the day and cumulative balance if they have been in the ICU for few days. Following that, we move to the GI assessment or abdominal system assessment. In that, we can again look at the abdomen, see if it is distended or not, see for any signs of any organomegaly. After inspection, we can do the palpation and look for any spleen or liver. If the patient is awake and conscious, it might be preferable to bend the knees so that we can have a nice and soft abdomen. Apart from the liver and spleen, we can also feel for any other lumps that like the kidneys, if they are having any polycystic kidney disorders, or any abdominal aneurysm, if you feel any pulsating mass. Also look for the bladder. If they are catheterized and the catheter is blocked, you may sometimes feel the bladder as well. After palpation, percussion is something which may be helpful in an abdominal examination in a critically ill patient to identify for ascites, and we can percuss on the abdomen and see if there is any dullness, and that will reflect on if there is any ascites in it. Apart from that, we should also look at how they have been fed. If they are awake, are they eating and drinking adequately? If they are having a feeding tube, that is a Riles tube or a NG tube, are they getting adequately fed in terms of the caloric requirement? Also, it's important to check whether they have opened their bowels. If not, how many days they have not opened. If they are opening their bowels, is it well-formed stools, or is there any diarrhea? After doing the structured assessment, we can move to general housekeeping. In that, there are different ways of assessing, and one of the popular ways is fast hug. In fast hug, the components are F for fluids or feeding, A for analgesia, S for sedation, T for thromboprophylaxis, H for head up, U for ulcer prophylaxis, and G for glucose. And this will cover the general things what we need, which are not included in our structured assessment. Apart from that, it is very important to keep track of all the foreign devices which are there within the patients and see if they need to be there or not, so that you can have it in your line assessment, how many what types of line they are having. So our patient has a central line, how many days old they are. So central line, arterial line, Foley's catheter, endotracheal tube or a tracheostomy tube or drains, all these things should be accounted for and measured for how many days they have been there. Finally, to complete your assessment, you look at the microbiology, see what the cultures have grown, what antibiotics the patient is on, and whether they need to be on the antibiotics or whether we can stop those antibiotics. As a part of complete assessment, I would even like to do ultrasound, look at the echocardiography screening of the heart and see how the heart is doing, and also look at the chest and see if there are any chest findings, and that's how I will conclude my assessment. To make more advanced assessment of your patients, especially the critically ill patient, ultrasound is become a sort of a must-have in the new critical care units, and it is almost like a stethoscope in ICU to assess the heart and the lungs beyond what we have just seen. Before you use the ultrasound, it's very important to know the regulations of the land, and we need a PCP-NDT PCP-NDT license before we use the ultrasound. So the best probe for us in the critical care would be echo probe, and in that what we are going to see, a quick assessment would be to look at how the heart is. It's good to know the basic views of the heart. You can start by looking at the parasternal long axis view, the short axis view, and look at the four-chamber and the subcostal. And what information we want to have from the cardiac assessment is look at the the size of the chambers of the heart, and look at the contractility, the LV contractility, the RV contractility, look for any pericardial effusions, look for the volume assessment, and in volume assessment looking at the IVC via the subcostal view, looking at the IVC distensibility and collapsibility will give us some information. A more advanced assessment would also mean to look at the working out the stroke volume by looking at the LV, OT, VTIs, and that would give us the cardiac output, and you can do some more derived measurements. moving from the cardiac ultrasound to the lung ultrasound, look for any abnormal signs. So A lines are the normal ones. Look for B lines. B lines can be used to guide your fluid therapy. There are blue protocols to look for the approach for the lung ultrasound. In the same way, you can do our pleural assessment by looking at the pleura, look for any pleural effusion, quantify the pleural effusion and do it on both the sides. The other uses of ultrasound in ICU beyond the heart and the lungs would be, we could do a fast scan or a abdominal scan to look for any fluid collection, look for the bladder presence, and we can also use the ultrasound to look for optic nerve diameter in patients with head injury or a suspected raised ICP. After we finish our assessment, we should always not forget to thank the patient and try and tidy him up. Mr. Jain, we have finished with our examination. We'll cover you up, we'll clean you up, and thank you so much for allowing us to examine. After tidying up the patient and thanking the patient, we will move and assess the investigation sheets. We'll look at the observation charts to see the trends of how the things have moved. We'll also look at the x-rays and any images if they have been done, and look for any cultures, if they've been sent, what have they shown up. We then talk to the parent team and formalize the plan of the day, and then we complete our assessment by talking to the family, communicating to the family and telling them how the patient is doing and what is the expected plan and expected outcomes.
Hi friends, we're back again. I hope this video helped you into understanding how to approach a patient in a very structured fashion. The salient features being that as soon as you are near a patient cubicle, do not have the urge to jump into the clinical examination straight away. The important aspect being is to look at the surrounding and try and pick up as much information as you can, because quite often this information is missed. Then approach your clinical examination by talking to your patient and taking his permission if the patient is awake enough. Proceed with the clinical examination in a structured way. Airway, breathing, circulation is what we have demonstrated the way for you to go ahead, which I think is a very reasonable way to approach any critically ill patient, because those are the important aspects which you want to clear up, as well as pick up if there are any problems in airway, breathing or circulation, and then go ahead with your clinical examination. And always conclude by thanking the patient, going back, looking at the investigations, looking at the x-rays, CT scans and your observation charts over the last 24 hours, and then formulating a treatment plan. Never forget to discuss your plans with the other treating teams, which would be the primary team or the other referral teams, and always discuss with the patient's family and keep them updated about the patient's clinical condition. So I hope this video will help you into building up your own skills so that you can approach a patient in the intensive care unit in the right way every time. Thank you.
Well, with that, I think we have come to the end of the session or the day's this thing today. So there are few announcements. Tomorrow again we will start at 9 a.m. Instead of 8:30. So please be informed that there are no tea breaks or lunch breaks, so that you plan your day accordingly. We will start at 9. There is another announcement that if the exam going students are interested in the class on how to read a research article by Dr. Atul Kulkarni, please put your request or response on the chat box, and we will ask him to do it on Sunday. So put your responses today or tomorrow, and we will request him to do it on Sunday. Regarding again, for purchasing the books, if you can do it online on this website. If there are any questions, comments, you can put it on the chat box. Uh, don't forget to fill the feedback forms. You will get your certificates only after you fill the feedback forms. It is necessary for the MCI requirement, so please don't forget to do that. Are there any other questions? Feel free to put it on the chat box. We will stay live for another 5 minutes. If you have any questions regarding any topics in the day, you can feel free to go and ask. Okay, friends, I think since there are no questions, we will end this day today, and we hope to see you again tomorrow at 9 o'clock. So don't forget to tune in at 9. We will start tomorrow. We have a long day. We have exciting lectures from all the eminent speakers and examiners. So do tune in at 9 o'clock tomorrow. Rohit, any other announcement, sir? Atul, sir? Rohit?
Yes, sir.
Uh, Anything that we missed for the day, we need to tell them?
No. That's fine.
Okay, see you tomorrow. Bye.
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 Thank you.